Yeah.
Ma'am, we are live.
A very good evening and a warm welcome to the Global Neuro-Ophthalmology Case Fest, a novel idea conceptualized by Dr. Satyakarna and brought around by him and his team. Dr. Satyakarna is an Associate Director, Ophthalmology, JP Hospital, Noida, India. He has done his post-graduation and neuro-ophthalmology training at Shankar Nethralaya, Chennai. He's authored 2 books, Shankar Nethralaya, Atlas of Neuro-Ophthalmology, 2 editions, and Step-by-Step Neuro-Ophthalmology Examination and Diagnosis. He is a specialty reviewer to Indian Journal of Ophthalmology, and he is also the Joint Secretary, Indian Neuro-Ophthalmology Society. So with that, I invite Dr. Satya to give us a brief introduction about his novel idea and 2 days program. Dr. Satyakarna.
Thank you, Shikha. Can you hear me now?
Yes, we can hear you.
Okay, so welcome everyone to the Global Neuro-Ophthalmology Case Festival. The Neuro-Ophthalmology Special International Group, NOSIG, originated in India 5 years ago for the sole purpose of case discussions in neuro-ophthalmology. In these uncertain times, we need adventure. And the idea of a festival of cases to be discussed online is good fun. Expertise in neuro-ophthalmology resides all over the world, and it's time to ignore geographical boundaries and think global. So with the fabulous inputs from the members of NOSIG and the superb support of the giants in neuro-ophthalmology, the program has been put together and will be moderated by 6 of us over 2 days. Feel free to type your clinical queries in the chat box and to consider them for discussion, to be taken up for discussion by the moderators. Be with us for both days and let's make the program a worldwide success. I would now like to introduce Dr. Shikha Basi, who is, and I'll just share my screen. Is it visible now?
Yes.
Okay, Dr. Shikha Basi is a Deputy Director, Neuro-Ophthalmology Services at Shankar Nethralaya, Chennai, India. Her areas of interest are atypical optic neuritis, OCT in neuro-ophthalmology, and congenital disc anomalies. And she has won the prestigious SD Athavale Award of the APAO AIOS 2013. And some of her excellent papers are prevalence of optic disc anomalies in the adult South Indian population in the BJO, and OCT in papilledema and pseudopapilledema with and without optic nerve head drusen in IJO. So over to you, Shikha, for the first session today.
Thank you, Dr. Satya. I need to share the screen now to take the program ahead. So now let's begin the first session of this beautiful festival. And this session is titled Optic Disc is Just the Beginning of a Long Story. And we've got 4 very experienced neuro-ophthalmologists from the Asia Pacific region to show us that how optic disc is just the beginning of a long story. But before we start the actual talks, I would like to introduce our esteemed panel. It's a pleasure to introduce Dr. Rashmin Gandhi. He is the Managing Director, Beyond Eye and Healthcare Private Limited. He is also a Consultant and Director, Neuro-Ophthalmology Center for Sight, Hyderabad, and at Leptomeningeal Institute of Medical Sciences, Varda. He's a founding member and Vice President of Indian Neuro-Ophthalmology Society. He received an award for academic excellence by Honorable Chief Minister of Gujarat, Sri Narendra Modi in 2011. Welcome, Dr. Rashmi. We also have Dr. Meenakshi Dhar. Dr. Meenakshi Dhar is a senior consultant, again at Center for Sight, Delhi, proficiently practicing neuro-ophthalmology, glaucoma, pediatric ophthalmology, and strabismus. She has worked as a professor of ophthalmology for 2 decades at Amrita Institute of Medical Sciences in Cochin. And in neuro-ophthalmology, her interests include multiple sclerosis, visual fields, and OCT and IIH. She has also presented many national and she has presented at many national and international fora. Welcome, Dr. Meenakshi. And lastly, we have Dr. Revati Ramesh. Dr. Revati is a senior consultant neuro-ophthalmology at Dr. Tony Fernandez Eye Hospital, Kochi. She's had her education at Chennai and then moved to Kerala, where she has worked in several private sector hospitals. She did her observership in neuro-ophthalmology at Shankar Nethralaya, Chennai, and went on to head the department of Dr. Tony Fernandez Eye Hospital. Welcome, Dr. Revati. Now I request Dr. Rashmin, who will be moderating the program, this session, with me to take the session forward.
Thank you so much, Shikha. I would like to thank Satyaka and all of you for inviting me and making me part of this wonderful program. The first case for this global neuro-ophthalmology case festival is by my friend, Dr. Celia Chen, and she joins in from Australia. She's a currently associate professor and consultant neuro-ophthalmologist at Flinders University. She's also a current president of Neuro-Ophthalmic Society of Australia and is widely published. She's going to talk to us about something which we all know, for a peaceful night's sleep. Celia, over to you.
Thank you very much, Rashmi. And it's lovely to be part of this global fest. So thank you very much. And I would like to thank the organizers for such a wonderful initiative. Now we're going to start. And this is a picture of the lavender field in Australia. So 4 peaceful nights, and let's see what happens as the nights unfold. So I'm going to start with a case, and this is a 32-year-old Asian male that was referred to me by a general ophthalmologist here in Adelaide. This person went for routine optometry review. She's a myope, so she usually wears glasses and went for an update when there was an incidental finding of bilateral optic nerve swelling. The patient had no trouble and was therefore a little bit alarmed that the optometrist rushed her to see a general ophthalmologist. The general ophthalmologist confirmed that it's bilateral optic nerve swelling, did an MRI that was normal. And at that point, they sent it to me for IIH. So let's look further into the story. She had no past history at all, very healthy. She has refractive error with high myopia, but otherwise has not been on any medication. In particular, no prednisolone, no minocycline, no oral contraceptive pills or vitamin A derivative. Now, you know, we all have IIH patients when they walk in, but this woman, her weight is 49 kilograms, her body mass is 21.7. I once was very alarmed when I went to Asia, and the residents presented to me by starting the presentation saying this is an obese 65 kilogram female with IIH. And I must say, by any standard, this woman is not obese and is not an IIH patient. So at that point, I'm thinking, okay, there's a lot more into it. And I went on about my review of system. She denied any headache, any tinnitus, vertigo, or focal neurological symptoms. But at that point, the husband sitting next to her said, can I say something? And he says, I lie on her right-hand side and I can hear this funny whoosh, whoosh, whoosh sound. Okay. So the plot thickens. So let's have a look at her. Her vision was 6 on 6. There were no RAPD. Color vision using Ishihara color plates were 10 out of 10, and HRR plates were normal at that stage. And this is her visual field. And that's her optic disc. Well, I think most of us will say, yep, that definitely does look a bit swollen. And there's also some signs here that definitely tells us that this is not a normal disc. So I'm just letting you look at that for a minute and still for a minute. And like any neuro-ophthalmologist, okay, we don't go by the report. So the OCT definitely confirmed there's optic nerve swelling, some of the ganglion cell changes at that stage. I look at the MRI scan myself and definitely it looks plumb normal to me. Now, at this point, I'm actually going to pause and ask the panel. So firstly, how many people think this is IIH just because the MRI is normal? Okay, good. I'm seeing a lot of people shooting their head. And I agree, as I said, with a weight of 49 kilogram, body mass index of 21.7, and just because an MRI is normal does not exclude other problems. What else would you like to do at this point?
Get a hemoglobin done. If the person is not obese, you know, you rule
And
out
I think we
anemia,
all
at
have
least in India.
We work up a patient with bilateral optic nerves.
What about doing an MRA and an MRV?
Beautiful, beautiful. I absolutely agree. So what happens is that when I see a patient with bilateral optic nerve swelling, this is my algorithm. I exclude systemic disease such as malignant hypertension, medication history. The MRI really only excludes this category to say there's no mass lesion. It does not tell us whether there's a venous sinus disease. And I know that a lot of times people think about venous sinus stenosis or thrombosis, but what happens in this situation is that it's not just the venous sinus disease, there may be other things going on. So in this patient, look, I did an MRA with MRV, and there's definitely a funny little signal going on there, isn't there? So let's look further into that little area there. Okay. Does anyone want to hesitate a guess at this point? What do they think that is?
The thrombus in one of the sinuses. I think probably the transverse sinus.
Okay.
It's a dural area.
That's a great thought. Okay, so we've got our set. Okay, so that's actually a little bit further in. So it's not quite at the sinus level. So what is it? And what's that whooshing sound that's been keeping the husband awake at night?
Celia, Dr. Veena wants to make a comment. Veena, please. Dr. Veena Narona.
Hello, everyone. This is a dural AVF. Am I audible?
Yes, you are audible.
Yes,
Celia.
yes, you are.
If you look at the MRI also
Sorry,
shows.
Shika, you're breaking up a little bit. Would you mind repeating your question?
That was Celia, Dr. Celia. We have Dr. Veena Narona, the neuroradiologist with us at Nethralaya, and she has a comment to make about the images that you are projecting, and she says that there is a dural AV malformation.
Beautiful.
Would you like to,
beautiful.
Yeah, would you like to add anything else, Veena?
It's okay, let her finish the case and we'll discuss it later.
Sure.
That's great. Thank you. Thank you for your comments. And it's lovely to have a neuroradiologist with us. In these type of cases, you guys are wonderful and invaluable. So in my workup from the MRV, we definitely can see a signal. And just as Dr. Veena said to us, it looks like a dural AV fistula. So what happens is that the next thing we did in this situation is that we did an angiogram. And let's have a look at this angiogram. And I'm going to firstly play it. So as we can see the filling of the carotid artery, but look at this area here and the return of the flow. Okay. So it is indeed an AV fistula. And we can go back and play with that, but this is arteriovenous fistula, and as a result, in this case, it causes an increase in intracranial pressure and therefore the bilateral optic nerve swelling. And in this patient, it was treated with embolization. And again, I'll just play through the image as we embolize, and you can start seeing the onyx glue in this area. And this is 4 weeks after the embolization. We can see that the optic nerve swelling is reducing, the patents lying around these margins are reducing. Now, this is quite a simple case, and I'm really just using this as a starting point to alert everybody that in bilateral optic nerve swelling, very importantly, do not forget that there are systemic causes such as malignant hypertension. In this case, the MRI scan is really only just the beginning. And do not forget that in a workup for bilateral optic nerve swelling, we really must include the imaging for the blood vessel MRA and MRV. Thank you very much. And I'll open the case for discussion and also neuroradiological discussion as well. Thank you.
Thank you so much, Celia. That was a wonderful case, and you really brought about the pertinent points very nicely. Very intriguing point, and I think it was discussed sometime, was that how come wife did not hear the whooshing sound, but the husband did? And maybe at the end of it, we'll discuss about that as well. Any comments from other panelists? Any comments, Dr. Meenakshi, Dr. Revati, Ambika?
Very, very nice case presentation. Brings out the pertinent point for the need of MRV. Don't stop when you find an MRI normal and start looking for other causes. You have to go ahead and do an MRV to rule out, and perhaps even an MRA if it is indicated, to rule out any of these vascular problems.
Yeah, I think apart from that, one other symptom which you also mentioned is transient visual obscuration, which might be a part of the symptoms of raised intracranial pressure, which typically is lasting for a few seconds and described as browning out of vision and generally related to the change of posture. Veena, would you like to add to the imaging that you wanted to do? Dr. Veena Noronha? Kaman, do you want to make a point here? All right, so I think probably their connection is poor. So the points which, as was discussed by Dr. Revati and Celia, was that any bilateral disc edema, apart from hypertensive retinopathy, you would have to look for raised ICP. And as Celia mentioned, IIH is always a diagnosis of exclusion. You have to make sure that you rule out the other causes before you label it as IIH, and then make sure that you manage accordingly.
May I make a comment?
Yeah.
Yes, thank you.
More and more cases are coming with sleep disturbances, sleep apnea being the cause of several of these intracranial problems, which present to us as papilledema. History of such a problem, sleep apnea, would probably not in this case perhaps, but in generally in neuro-ophthalmology cases where you find a normal MRI, but papilledema, that's another area to keep in mind.
And that's what probably husband heard. I think that whooshing sound was maybe a atypical snoring.
Possible.
Exactly. And I was asked a question a bit earlier from the panel, is that why is it that the husband heard it and the patient didn't? And I have to say, I think with neuro-ophthalmology, the history is key, but the number of times, you ask a patient, do you snore on the topic of sleep apnea? And they say, no, I don't. And the partner is going, yes. So definitely in the history part, make sure that you include the family. They are very important.
Any other comments, Shikha, Satya?
Yeah, usually for bilateral disc edema where we are suspecting IIH, our protocol is to do an MRI with venogram. We don't add
Yes.
an angiogram. We usually just do a venogram.
Yes.
So I would like to ask, Veena, are you around?
Yes, I am.
Yeah, Veena, so on a simple MRI and venogram, how likely are you, will you be able to pick up a dural AV malformation?
Yeah, actually, you need a good axial T2 weighted image to have a suspicion on a dural AV fistula. We have picked up a dural AV fistula just based on our axial T2 sequence, which shows you multiple abnormal flow voids, in these sulcal spaces where you normally don't see vasculature that much. And then when you do the venogram, it kind of confirms your suspicion on the routine T2. So if you go back to the MRI and you see the image that you showed, it does show, multiple tiny flow voids in the sulcal spaces, which are not supposed to be there. Okay, so a T2 weighted axial image also can indicate that there is something abnormal going on in the vasculature, in addition to, telling you about the thrombosis also. So, looking at the T2 weighted image is very important in these patients of IIH.
So it's kind of that the neuroradiologist suspects the dural AV malformation on the MRI, and then if the neuroradiologist is thinking in terms of dural AV malformation instead of the venogram, would rather do an angiogram and confirm it with the digital subtraction angiography, because that is the one which kind of, Celia, you're saying something?
In this case, I was going to say that, so my standard protocol is always doing an MRI with MRV as well. I don't always do an MRA. And in this case, I've actually been said that it's because it's quite a large flow, and we also saw that a venogram a bit earlier, which actually alluded to something is abnormal. A digital subtraction angiography is invasive, and really that is a gold standard, but that is done in this case because there is that abnormal MRV signal. So just to confirm that my standard when I investigate is always MRI and MRV as well. If I cannot get that, I get CT and CTV.
Right. And I think, Celia, we have a couple of minutes. Maybe if you can give your treatment algorithm for these people who have raised ICP, how do you go about treating them?
Okay. Oh, okay. That's a big area. How long have you got? And I think with this, so look, with this type of situation, the first thing is always, back to that little diagram about systemic disease, space occupying lesion, venous sinus disease, exclude any of the systemic disease. And it does still happen when someone has malignant hypertension with bilateral optic nerves swelling that has been missed because people don't always check the blood pressure. Once you exclude the precipitants or the confounding causes, and also very importantly, talking about space occupying lesion, it has also happened before where unless you tell people what to look for, something like a Chiari malformation may be missed as well that causes a raised intracranial pressure. So going back to the history and investigation, really with the radiologists, we work as a team. You really need to tell them what you are thinking of and what you are looking for. And once it is definitely in this situation confirmed that there's no confounder such as venous sinus disease, etc., I go by the idiopathic intracranial hypertension treatment trial, and that's still my algorithm in terms of starting treatment with medical treatment with weight loss, and go on to talk about in those situations what happens with refractory.
All right. That was a wonderful start to this Global Case Festival. And if there are no other further comments or questions, maybe we can.
Can I just make a comment? The one lacune that we have is that we get MRIs and MRAs done. Shankar Nethralaya is lucky to have Dr. Norona, but most of us sometimes come with the situation where the neuroradiologist is not taking so much of an effort in reading the MRIs and MRVs. So that becomes kind of a limiting factor at times.
Yeah, neuro-ophthalmology is actually a very, very team effort. Unless you have a good neuroradiologist, you have a good neurosurgeon, you have a neurologist, the team works together. So that way, yeah, I agree. Shankar Nethralaya is quite lucky to have a very, very efficient, complete team. And another thing, just to sum it up, if Dr. Ashwin allows me, in this particular case, if, as you were saying initially, the patient is obese, non-obese patient and patient presenting with IH, if I would have done an MRI and MRV also was normal, then here we get quite a few patients who are anemic, non-obese, anemic patients, they could have, a bilateral disc edema. But here, as the session is named, we started off with bilateral disc edema and landed up with a condition which is potentially, fatal. 20% patients can have intracerebral bleeds. The dural AV malformation, if not treated, can cause intracerebral hemorrhage and patient can die. So there, you've saved one life.
So there is a quick question to Dr. Veena Norona from Clementine. Can cerebral venous thrombosis be excluded by just the MRI with contrast or contrast MRI without a dedicated MR venogram? Veena?
Yes, of course. A routine MRI is good enough to diagnose a sinus thrombosis because you have to study the images, the T1, the flare, and the T2, because you will get flow-related artifacts. So you have to see the signal of this dural sinus in all the sequences to see if the flow void is maintained. We do a contrast enhanced venogram now if we are suspecting a transverse sinus stenosis, because now that is like the gold standard for picking up stenosis of the transverse sinus, because on the routine MR venogram we might kind of overestimate the stenosis, or sometimes the hypoplasia may be reported as a stenosis. So for that reason, we now do a contrast enhanced venogram after we do a routine venogram, and if we feel that it is not adequate enough, then we go ahead with the contrast venogram.
Thank you, Veena. And let's move on to the second case. May I invite Dr. Shikha Basi Talwar to take on from here.
Thanks. So now I invite Dr. Clement Tan to present his case. Dr. Clement is an associate professor and consultant ophthalmologist at National University Hospital, Singapore. He's presently Cluster Director of Ophthalmology, National University Health Sciences, and Head, Department of Ophthalmology, National University Hospital, and National University of Singapore. Dr. Tan's particular clinical interests are neuro-ophthalmology and cataract surgery. He has previously served as the Program Director of Ophthalmology Residency Program, and he's currently the Chief Examiner of the Masters of Medicine Ophthalmology. So welcome, Dr. Clement Tan, and I request you now to present your interesting case.
Thank you very much, Dr. Shikha, and I want to thank the organizers for this marvelous idea of having a case festival and for their generosity in sharing this with everybody around the world. Let me just present my case. I work in an institution where we have a very active oncology unit, and with the increasing number of cancer survivors now, we have been seeing a lot of patients with neuro-ophthalmic conditions, as I'm sure many of you have also. And we often have a challenge trying to distinguish between, trying to determine what is the cause of their neuro-ophthalmic syndrome. So our patient here is a 69-year-old male with a T4 node positive, but no metastasis, rectal adenocarcinoma, who was on oxaliplatin and capecitabine, the Xelox regime, and radiotherapy as neoadjuvant therapy. And just as he had done his second cycle of infusion cycle of oxaliplatin, he noticed that he was seeing a bit of a blackish or a grayish or a darkish ring, and the oncologist sent the patient over to ophthalmology. His visual acuity was good, but he had an afferent pupillary defect on the right. You can see he had a swollen disc and an inferior, what looked like an inferior altitudinal field defect with reduced color vision. So of course, we quickly had a neuroimaging done for him, and it showed nothing in the optic nerve in particular, but a ethmoidal sinusitis with some enhancement of the sinus mucosa, and the radiologist has very helpfully tried to label that area for us. There was some increased fluid around the optic nerve, but no contrast enhancement. CSF really only showed a very marginally raised protein, and eventually after all the tests came back, there were no malignant cells, no bacterial fungal growth. Galactomannan is an antigen test for Aspergillus. That was negative, which our infectious disease people sometimes like. That was negative too. We went ahead and had smears and cultures from a nasal polyp as well, but that was negative as well. So, in view of that, we also discussed with the oncologist, and we asked them to. We had the capecitabine, which was the other part of the chemotherapy, stopped as well. Now, 2 weeks after that original presentation, he stayed pretty stable throughout this entire time. But 2 weeks after that, and with no intervention whatsoever, his vision declined to about 6/120. His visual fields also seemed worse, but there were a lot of false positives, so we could not get a really good visual field on automated perimetry. It seemed to fluctuate a little bit. So sometimes it was a little bit better than 6/120, sometimes it was a little bit worse. And so one of my colleagues who was on duty at that time, she decided that we would start oral voriconazole, and in consultation with the infectious disease people, because the first radiologist had suggested a possible sinusitis. The concern was that of a fungal sinusitis in a patient who just had chemotherapy. Decided to start oral voriconazole and IV tazocin. A couple of days after that, dexamethasone was added. The MRI was again repeated, but again the nerve was normal, and you can see though that there are some changes in the MRI relating to the functional endoscopic sinus surgery that was done, and some material inside the sinuses as well. The MRI, the visual acuity though improved quite quickly. 4 days after the antibiotics and antifungals were started, and only a day after the dexamethasone. So a bit difficult to determine if the change was related to the dexamethasone. And so my questions for the panel, right, in this case, which had us very puzzled, is the visual loss more likely to be toxic or infective given the findings? The patient was quite stable for a while, but then seemed to have a second round of loss of vision, despite the fact that all the chemotherapeutic agents were stopped, right? And maybe we pause here for the discussion on that question. And then, of course, I would love your advice on how to manage this cancer subsequently if if this is possibly a toxic optic neuropathy implicating the chemotherapy agents that are used. How do we balance the pros and cons of treatment, life-saving versus vision-destroying therapies? And so I just maybe put back the image for everybody to have a look here, the images for everybody to have a look here as we discuss this case. Dr. Shikha, do you want to lead on the discussion of this case?
Sure. Very, very challenging case indeed, Clement. Very challenging case. You've got lots of decisions to make here, starting right from the diagnosis, whether, it's an infective or a toxic pathology. So Dr. Meenakshi, Dr. Revati, Dr. Rashmin, what's your take on the case? Would you put it as an infective pathology or a toxic pathology? And we also have Dr. Neil Miller with us. So we'll have final comments from him as well. Dr. Miller, are you there?
Yes, I'm here.
Yes. Yes. So we'll have a final word from you as well. It's happening to know that you're around. Yes, Dr. Meenakshi, you were telling me.
Yeah, Dr. Clement, when they did the FES, did they subject the washings of the FES to culture sensitivity, or only the nasal polyp was?
Yes, they did. I sorry, that was my error there. They did subject all the washings, the nasal polyp. I think they even took biopsies from the nasal mucosa as well.
Okay, so that
so it was pretty thorough, I think, in the first round of trying to isolate the fungus, because as has frequently been pointed out to me by the infectious disease and sometimes you have to do multiple biopsies because the fungus is deep and in the bone.
Yeah, so there could always be a false
negative, yes, indeed.
So one thing could be that, and and how long was the voriconazole given? Maybe the
it was only 4 days of voriconazole before there was some improvement, and so I have some doubts about whether voriconazole works that quickly to cause any improvement. And dexamethasone in 1 day, I also am a little bit uncertain.
Now the other thing is the oxaliplatin itself. The drug toxicity is known to reverse in time.
Yes.
So maybe in a longer follow-up, whether the vision would have either way gained if it was oxaliplatin.
So about a couple of months after that, the vision had gotten back to 6/12, but the visual fields were roughly similar. So there was some improvement subsequently.
Okay. And
may I make a point?
Yes, please, Dr.
Here we have a clinical picture where the pointers towards infection is not so high. On the other hand, we have a patient who is on 2 drugs, both oxaliplatin and capecitabine. Both are known to produce optic neuropathy. So with a patient on 2 drugs causing optic neuropathy and a clinical picture which does look like an optic neuropathy, we have to keep our suspicions quite high that these drugs may be responsible. So
Dr. Revati feels that it's a toxic optic neuropathy.
Yes.
And Dr. Meenakshi wasn't very sure whether it could be something originating from the sinuses, and would have wanted some samples from the posterior ethmoid as well. Fine.
Yeah.
Fine. So now, as Clement, you were saying that these drugs have been now taking Dr. Revati's diagnosis, that taking that forward and deciding further treatment of the patient. These are again we are dealing with an adenocarcinoma of the rectum, and it needs to be, at the end of the day, it needs to be treated. We can tell the oncologist that these things are harming the optic nerve, but then that the decision to stop the treatment, and what next lies the question. So any comments from the panel?
It would have been nice to have a gastroenterologist over here who could tell us whether they do have something in their armamentarium to go ahead with if we stop both oxaliplatin and capecitabine.
Can I comment, please?
Yes.
Sure, Veena.
Yeah. One, what was the interval between the 2 scans, the first one and the second one?
About 2 weeks, 12 days actually, to be precise.
Okay, so because one, the sinusitis is definitely increased there, and from the signal which was seen in the previous T2 weighted image, fungal is definitely high suspicion there. Okay, because here if you see there is an opacification, but it is dark on this contrast image. So anything that looks dark on a T1 and T2, one should think of a fungal sinusitis. Were the T2 image, I mean, was there any signal in the optic nerve that was noted in the T2 images is what we need to look at, especially around the canal or the posterior optic nerve?
Not in either set of images. The T2 images for the optic nerve didn't show any bright T2 signals on the optic nerve.
Okay, because the contrast does not show any enhancement. So I would look at the T2 image as well as the diffusion sequence to look at if there was any abnormality in the optic nerve.
No, it was a normal brightness of the optic nerve on the T2s.
Okay.
Dr. Miller, would you like to give your comments?
Thank you. Just two. One is that, as the panel has suggested, when you deal with a patient with cancer, you have to consider that a problem that occurs may be due to the cancer or its treatment. And so you have the possibility that this is cancer, you have the possibility that it is drug-related, you have the possibility that directly drug-related, you have the possibility that there's a secondary process such as fungal disease, and these are difficult. I personally would have been surprised if this were fungal disease, given the fact that there was such improvement so rapidly. That's something I certainly haven't seen, especially in somebody who has these problems in the rapidity with the visual loss. The second thing is that I just make the case that if you do suspect fungal disease and you do an MRI, the sinuses, and I'm hesitant because Dr. Veena is here, so she knows much more than I do, but I always, if I suspect fungal disease and I don't see anything on an MRI, I will get a dry CT of the orbits, because fungal disease can have a low density, look just like air on an MRI, and on a CT it will be obvious. Also, I suppose CT shows the bone better, so I like that as well.
So you are favoring the diagnosis of toxic optic neuropathy, Dr. Miller?
Actually, I don't know. I don't know for sure. I think the improvement is awfully rapid. Plus, I don't like the fact that the disc is swollen and there may be a little hemorrhage inferiorly, and the rapidity with which it improved. I just wonder if there's a general sinusitis that happened in this case.
There are 4 keys, then at least one key, one set of keys can
how would we explain the unilaterality of the effect of the visual loss?
Toxic optic neuropathies usually are bilateral, but the case reports with oxaliplatin, I think there have been of unilateral vision loss.
Yep.
And that too a transient visual loss, which improves just the way it's being reported. A similar case has been reported, isn't it, Clement? You would have done the net search, and something similar has been reported.
Yes.
Yeah.
But
that
I
was
think
by Noor et al.
But I think the challenge for us really was the second drop in vision when he was initially doing quite okay, didn't get worse. We thought, okay, maybe it's drug toxicity. We waited out, because what we've done what is usually done, which is to remove the drug. But then he took a turn for the worse, which then made everybody get a bit worried. I think one of the concerns was, as Dr. Veena pointed out, was in doing the FES, one possible suggestion is in doing the FES, they actually breached the bone a little bit, and then whatever was the sinuses went to the optic nerve. And as Dr. Miller points out, the recovery thereafter is a little too fast. So perhaps that theory needs to be relooked at as well. So I guess the last question I would have is, if we are not absolutely sure that now he's done pretty well. He's done okay cancer-wise because he's just had a local transanal resection of an ulcer, so he's done reasonably okay. But if he needs another round of chemotherapy, what will be our suggestion to the oncologist?
If it's life-saving, you have to go ahead.
Yeah, thought so. Exactly. Yeah, that's what we eventually have come round to. We just have to tell them to go ahead if they need it.
Thank you, Clement. That was really, really a very nice case, a challenging case. With that,
thank you all for your comments.
Now I request Dr. Rashmin to move the session forward.
Thank you so much. Great case, Clement. And let's move on to the third case of the morning, and that's being presented by Dr. Sharon Taw, who joins us from Singapore. She's a senior consultant at Singapore National Eye Center. She, in fact, after her training with Dr. Miller at Wilmer, she helped establishing the department and was head for 13 years. She's also involved in resident and medical student education, and she represents neuro-ophthalmology in various committees, including Residency Advisory Committee. Dr. Sharon Taw, it's all yours. Her case is just near miss. Dr. Sharon?
Hey, Andy, when did you join?
Hello, good evening.
When Neil started.
Can you hear me?
Yes, we can, Sharon.
All right, great. Hi. I'd like to thank the organizers for inviting me to this wonderful case festival. My case is a 32-year-old female who came to our acute care clinic with a sudden onset of painless bilateral blurred vision, which she experienced after waking up. 2 days before this, she
Excuse me, Sharon, your screen is not shared.
Oh, sorry. I thought it was under, okay.
Perfect.
Is it shared now?
Perfect.
Yes.
All right, so sorry about that. So just starting again, this 32-year-old female came to our acute care clinic at our center with a onset of painless bilateral blurred vision when she woke up. And 2 days prior to this, she had an onset of severe headache and vomiting associated with blurred vision. She was given paracetamol and prochlorperazine at the ER, and because of the severity of these symptoms, she was sent away, and the blurred vision wasn't addressed. So on examination, her visual acuity was count fingers, improving on pinhole to 660 in both eyes. She wasn't able to read any of the Ishihara plates, and her pupils were sluggish to light with no RAPD. Her visual fields were inconsistent to confrontation testing, and these Goldman visual fields showed that she couldn't fixate very well. Her ocular motility examination, as well as examination of cranial nerves 5, 7, and 8 were intact. Anterior segment examination on the slit lamp was normal. Dilated fundal examination was also normal. In particular, the optic discs were pink and the margins were sharp. We sent her for an OCT, and it shows that the retinal nerve fiber layer were more or less within normal limits. However, the ganglion cell inner plexiform layer showed a pattern of binasal thinning. So with that, we had something in mind, and we thought that this patient with a history of headache and vomiting, followed by bilateral severe vision loss, sluggish pupils, needed to go to the accident and emergency urgently, where she received an urgent CT scan, and this showed a cellular area, hyperdense, well-circumscribed lesion, which suggested that there was a pituitary, most likely a pituitary lesion with intralesional bleeding. So she was admitted and subsequently received an MRI scan, which shows heterogeneous finding of hyperintense and hypointense changes within the tumor, and the optic chiasm could not be seen, most obviously compressed by this lesion. So she was admitted and underwent urgent endocrine evaluation, and thereafter, that same night, underwent a transsphenoidal endoscopic resection of the pituitary tumor. Post-surgery, at day 6, her visual acuity had improved to 6.9 on the right and 6.12 on the left. Her color vision had improved to full, and she now had a small right relative afferent pupillary defect. At 5 months, her visual acuity was normal, and at 1 year, she was clinically stable. This is her OCT at 1 year, more or less the same as at presentation. So pituitary apoplexy, which is what this patient had, is rare. However, it's associated with significant visual morbidity as well as systemic morbidity and sometimes mortality. Its classic presentation is headache, nausea, and vomiting, but also often associated in up to 85% of patients with visual impairment, and then also often with ocular paresis. Almost all patients also have hypopituitarism. Predisposing factors include major surgery, drugs, head injury, and radiation therapy. The pathophysiology is said to be due to tumor necrosis, due to outgrowth of blood supply or compression of the pituitary vessels at the diaphragmatic notch. And this is associated also with tumor vasculopathy, where they're more susceptible to hemorrhage, and the susceptibility for hemorrhage has also been reported to be due to intramural expression of VEGF and tumor necrosis factor alpha. So the management is multidisciplinary, and the indications for decompression surgery urgently are severe visual acuity or visual field impairment. And if done within 8 days, the recovery is very good, as you can see, up to 93% for visual acuity and 95% for visual field impairment. However, if the patient presents with visual acuity or visual field that isn't that severe, however, they start to deteriorate, that's also an indication for decompression and also obviously impaired consciousness. For patients that are treated conservatively, those would be those patients who are elderly, frail, or with stable, mild symptoms visually. It was reported by Danish Meyer and her co-investigators that pre-op OCT parameters can predict both immediate and long-term visual recovery. So if the patient pre-op had normal RNFL, then up to 96% of them achieved 6/9 visual acuity, and more than 75% of them had significantly greater visual field improvement than those who presented with thin RNFL. Normal taken to be greater than 80 microns. Visual recovery also was shown to continue up to 2 years post-op, especially if thin, even if thin pre-op RNFL was present. So when we saw the patient, our patient with the pattern of binasal RNF or GCIPL thinning, we thought immediately of chiasmal compression. And this is nicely shown by Harry Yam and co-investigators, where they showed that the characteristic nasal macular GCIPL thinning using macular ganglion cell analysis reflects crossed nerve fiber pathology in eyes with chiasmal compression. So in this patient in that paper, the visual field is normal, and the RNFL also not too remarkable. And if the GCIPL investigation had not been done, then the suspicion for a optic chiasmal lesion would not necessarily be there. So in summary, it's important to familiarize yourself with the features of pituitary apoplexy, namely the history of sudden headache, often severe, nausea and vomiting, usually severe vision loss that comes on suddenly. Also, patients may present with diplopia. And then remember that if the patient has pre-op OCT RNFL greater than 80 microns, this predicts better visual prognosis for the patient post-op. And this is useful when you're seeing a patient going for surgery and in your counseling. And of course, when you do OCT, remember to order also the GCIPL in patients where you're not quite sure what's happening, where the visual fields are normal, because if you see binasal thinning, you can be pretty sure the pathology is at the optic chiasm. So thank you very much for your attention.
Could I just make one comment? I think it's interesting that we started out by bowing to the RNFL thickness as a marker for improvement or non-improvement. And it's been shown that while it's true that if you've got more than 75 microns of thickness, you're more likely to have an improvement with decompression of whatever the process is. But obviously we see plenty of patients who improve even with less than that. The same thing I think is true of the RGCIPL. In your patient, you had pretty significant binasal thinning, and yet the patient improved both with acuity and with fields. So I think you can't bow to that either. It's helpful, but it just shows that there is some disconnect between the OCT, whether it's RNFL or RGCIPL, and visual fields. And while you can be slightly pessimistic, I suppose, in terms of recovery, just because you have a decreased RGCIPL doesn't mean you can't recover. And I think it's a great example of it.
Thank you so much, Dr. Miller. May I request Dr. Tauk if you can stop sharing so that we can look at all the panelists. So one point which you brought about very nicely, Dr. Sharon, was that if somebody comes to your ER with headache, vomiting, and visual disturbance, then paracetamol is not really the treatment of choice. It does require a little more investigation, and that you brought about very nicely. Any other comments? Andy?
Yeah, I was just going to say, I use that GCL when the field is unreliable, and it's so great because when you have this unreliable field and you don't have the classic bitemporal, you have something to say, okay, wait a minute, this is real here.
Yeah, and Sharon also brought about that point that, and I think Andy had reported a case where a 6-nerve palsy, which was isolated, which actually turned out to be apoplexy. So I think high index of suspicion in somebody who has headache, vomiting is always always required. Any other comment from the panelists? Dr. Revati, Dr. Meenakshi?
I think it was all the points were brought out beautifully in the case presentation. The only thing that I would like to add is when you go to the diagnosis, without the the fact about the panhypopituitarism or diabetes insipidus brought out. We couldn't label it pituitary apoplexy. Even that point was brought out by Dr. Sharon. So that is something to keep in mind. We have to do an endocrine workup for these patients to call it a pituitary apoplexy.
Did the endocrine workup show anything?
The patient was a bit low in cortisol, but nothing else.
This is Dr. Pervin. Can you hear me okay?
Yes.
Yes.
Good morning. Good morning in Indiana. Just wanted to point out it's such an important diagnosis. Yes, it's rare, but it's life-threatening, preventable blindness, all of that. So just one point, because this becomes a medical legal issue. Occasionally there was a few years back, JNO had an article called "Pituitary Apoplexy Goes to the Bar." The bar being this is legal aspects, not the medical aspects. So pointing out the danger of missing this diagnosis, and one aspect of the likelihood of missing this diagnosis, specifically that's because in the emergency room, what's so often obtained is a CT scan rather than MRI for obvious reasons. It's quick, it doesn't matter if the patient is moving. And so that's appropriate. I'm not complaining about that being the first step. So CT head, and with that technique, it's very easy to miss a pituitary tumor, including one that is big enough to have bled, because they're midline structures. So the point is that the way most of us read scans, it's a human thing. We read scans by comparing left to right. What's this on the right? I don't know, but here it is on the left also. I guess that's okay. So, but a midline structure where the comparison is not to the other side, the comparison is to normal. So you need to know what's normal. For the pituitary gland, for the suprasellar cistern is supposed to be empty. So the thing to watch for is whether it's in fact filled in with soft tissue. So a strictly midline pituitary tumor is very easy to miss on CT scan. And I've seen several of these. I expect other panelists have as well. So just be aware of that. I guess the caution would be if the patient you're seeing fits clinically for pituitary apoplexy and what was obtained as a CT, keep an open mind, go over this, look at the scan yourself, review the scan with a neuroradiologist, ideally, tell them what you're looking for, and really look at that suprasellar cistern, make sure it has CSF in it and not soft tissue.
Another thing to note is that actually 60% of patients with pituitary apoplexy, the pituitary apoplexy was the first symptom of the pituitary tumor, as per literature. So we need to remember this, in fact.
Right, that's another way that the diagnosis can be missed, because if you're thinking, oh, this will be the patient who's been followed for their pituitary tumor and now has acute headache. No, that's so often not the case. The other thing to watch for, I think about 80% have some precipitating factor. So to watch, that should be a tip-off. Often it's an abrupt period of hypotension, sometimes hypertension, sometimes both together. So that onset of headache and decreased vision in that setting should make you particularly suspicious of pituitary apoplexy. Nice case, great subject.
Dr. Sharon, was there any high risk factor in this patient?
No, she was otherwise well.
Thank you.
I think it's interesting that in the era of MRI, it's not at all unusual to see hemorrhage in pituitary adenomas in which the patient has not had any acute process, no headache, no obvious endocrine changes. And it's interesting that the neurosurgeons, if you talk to them about it, they're not worried about that at all. So it's never really made sense to me that if you see blood in a pituitary adenoma, it's not an urgent or emergent process, only if it's an acute change clinically.
Pituitary apoplexy is one extreme. What about a patient presenting to an ophthalmologist with headache? How often you advise a visual field? Every second, third patient to an ophthalmologist, presents with headache. So how justified one is in ordering a visual field in these patients? Here, the visual field, if had it been done at that hospital, it could have picked up the diagnosis earlier.
I think you have to take that in context with any other associated symptoms, whether there are visual symptoms associated, the nature of the headache, a lot of things, not just headache.
So I'm asking all the neuro-ophthalmologists present here, if the patient is referred from your colleague for headache evaluation, so visual fields is a part of your investigation, or how do you go about it?
May I say something?
Yeah.
If the patient has a long-standing history of headache, I would look for any history of a change in the character of headache. So a change in character of headache, thunderclap headaches, where the patient says they've never felt headache like this before, and this is the first time they're feeling this severe a headache, that would be another reason why I would do a visual field with possible neuroimaging in mind. And a patient who complains or gives a history of cluster headaches, and suddenly he has gone into another kind of picture, say he's had a isolated event which does not fall into the clinical picture of cluster headaches or any other headache that he had before, that would be another reason why I would do visual fields, perhaps with the neuroimaging in mind.
Dr. Shikha, probably I would be very relaxed in doing a visual field. It does not harm a patient, and in fact, we get a more with affirmation. We can say yes, at least your things are normal. So I would go, and especially if it is being referred to us, that means the clinician has probably taken care to rule out the bare minimum. So I would be do it in most of the cases.
Yes, comment.
Yeah, I was going to say, well, the first thing is I'm quite lucky that they don't refer headaches patients to me. But in my institution, there is actually a waiting list for visual fields. So so for me, I think if I'm in doubt, actually I just do a confrontational visual field first, because that's all a simple way to, well, to make sure that I'm not missing something really obvious. And also, also doing the visual field with a red target as well. If I'm worried about bitemporal hemianopia, then putting red targets onto either side of the midline sometimes is quite helpful. So it's going back to,
actually,
like, everything for us has to wait.
I'd like to also mention the new devices which have come for a quick evaluation of the fields. I feel they may not be so useful for glaucoma, but for the ones which there are different ones, like the one which is the Melbourne one. We can pick up a neuro-ophthalmological field very easily, especially in patients who are not so mobile, and we can do it at the bedside.
Right. Thank you very much. I think there was a great discussion. Thank you, Sharon, for a lovely case. And
Thank you.
Up to Shikha.
Thanks, Rashman. Now I invite Dr. Carmen Chan to present her case, the last case of the session. Dr. Chan is currently consultant at the Hong Kong Eye Hospital and honorary clinical associate professor at the Department of Ophthalmology and Visual Sciences of the Chinese University of Hong Kong. She subspecializes in neuro-ophthalmology and uveitis. She is on the editorial board of Journal of Neuro-Ophthalmology and is a member of the International Relations Committee to North American Neuro-Ophthalmology Society. Dr. Chan received the Asia Pacific Academy of Ophthalmology Distinguished Service Award in 2013 and the APAO Achievement Award in 2015. It's a pleasure to have you with us, Carmen. Now I invite you to present your case.
Okay, thank you, Dr. Bassi, for the kind introduction. Let me share my screen. So are you able to see, the screen?
Yes, yes.
Okay, so, well, first, no financial disclosures as a neuro-ophthalmologist. So the case I'm going to present has been presented at the NANOS 2018 meeting as a watch case. So some of the panel members may know the answers. Okay, so we have a 24-year-old Chinese man who presented to an outside center in May of 2017 with progressive blurring of vision for 1 year. First started in the right eye and then to the left eye, and there was no acute loss and was painless. He was a very intelligent young man, and he told us, he volunteered the information that he had subjective decrease in sweating over his body from the neck downwards. And also he had right-sided headache since a young age, and it was not worse in the morning and not worse when supine. So he has a past medical history of migraines, but otherwise his medication, allergies, past ocular history, and family history were non-contributory. He was a graduate student. He denied alcohol, tobacco, or illicit drug use. So on his first examination by an ophthalmologist, the right eye best corrected visual acuity was 20/100, the left eye was 20/30. There was decrease in color vision in both eyes, as worse on the right eye. There was a relative afferent papillary defect in the right eye. Otherwise, the intraocular pressure, motility, anterior segment, vitreous, macula, retina were all normal. But his discs had established disc pallor with a cup disc ratio of 0.9 in the right eye and 0.7 in the left eye. And the optic atrophy was also confirmed on OCT. So his visual fields were very poor. In the right eye, there was general depression. In the left eye, there was a very grossly constricted visual field. So he had an MRI brain and orbit done, and the formal report actually said there was no gross optic nerve enhancement or compression. However, T2 hyperintensities at the genu of the corpus callosum and the adjacent white matter, highly suggestive of demyelinating disease. So at this point, he was reviewed, he was worked up first. I mean, CRP, ANA, RF, vitamin B12, folate were normal. His NMO antibodies were negative. His serum alpha-fetoprotein and beta-HCG was negative. He also had a lumbar puncture, which showed a raised white cell count, 99% of lymphocytes, and he also had unmatched oligoclonal bands in his CSF. So he was seen by the neurologist with such an MRI appearance and the CSF finding. They, of course, were suspecting MS, multiple sclerosis. However, the neurologist thought that this was a clinically isolated event, no dissemination in time and questionable dissemination in space, and therefore we would manage it as a single event. Intravenous steroid was considered but withheld because he didn't really give an acute didn't give a history of acute deterioration. So they kind of thought of it as probably he had optic neuritis in the past causing a bilateral disc pallor, and there's nothing active at that time, so he was not treated. So he was reviewed 3 months later in August of 2017. By then, his vision has deteriorated gradually. In the right eye from 20/100 to 20/400, the left eye from 20/30 to 20/100. And at that time, he was referred to our center for further management. So maybe at this point, I'll open it up to the floor to ask the panelists, what would you do next? Maybe I'll stop share for a second and invite the panel to comment. Anyone?
For antibody been sent, an anti-MOG antibody?
It was not, because at that time, anti-MOG antibodies were not routinely done. Of course, if the patient were to present now, I mean, we would have sent it now. Anyone else? I'm surprised that the neuroradiologist didn't speak out. If not, then maybe I'll continue with the story for now.
Dr. Veena will be joining us shortly. She's not around at the moment, so you can continue. Any comments from Dr. Revati and Dr. Meenakshi?
View of the fact that the vision has deteriorated, perhaps another neuroimaging is indicated at this point to see whether there are fresh lesions.
Yes. Yeah, precisely. That was.
We have a question from Dr. Umapati. Syphilis.
Yes. Syphilis, of course.
Has been done.
Yes,
or not?
PDRA had been done. It was negative. We screen all out. Well, I can't say too much about our suspicions of our patients, but everyone who comes in with an optic neuritis actually gets this PDRL at our center. Is that the same with elsewhere, or do you trust your patients a lot? Anyway, so okay, so as the panel suggested, we went. So is my screen sharing again? Is it sharing again? It is, right?
Yes.
Okay, good. Okay, great. Okay, so we went on and repeated the neuroimaging. So, and as before, there were hyperintense lesions at both frontal horns, also in the periventricular regions near the genu of the corpus callosum, which could suggest multiple sclerosis. However, there were other strange lesions. For example, there was some abnormal nodular ependymal and subependymal enhancement around the ventricles. Most disturbingly, there were these enhancing lesions at the hypothalamus and the pituitary stalk, which is highly atypical for MS. And of course, as neuro-ophthalmologists, we're most interested in the optic apparatus. So if we were to look at the optic chiasm, there were also abnormal hyperintense signal changes at the optic chiasm, which our neuroradiologists commented that there were T2 weighted signals which do not follow along the callosal septal interface, which was atypical for MS. And in retrospect, if we were to review the MRIs from 3 months ago, they were there already. It's just, it wasn't on the report. So at this time, as we go, a diagnostic procedure was performed. So as you can guess, the patient had a mini craniotomy and a brain biopsy. So intraoperatively, they found that there was diffuse leptomeningeal thickening. That was biopsied, but the histology was non-contributory. He was also found to have atrophic optic nerves and also a thickened hyperemic pituitary stalk, which they managed to take a 1 mm biopsy. And what they found was there were large malignant cells with enlarged nuclei, clear neoplasm with distinct nuclei. And when they did the immunostaining, they found malignant cells exhibiting immunoreactivity to CD117 and also OCT34. So the histological diagnosis was CNS dysgerminoma non-secreting. So maybe at this point, I'll just give a few words about CNS germinomas. So CNS germ cell tumors are either classified as germinomas or non-germinoma germ cell tumors. The prevalence is the peak age is 10 to 21 with a male predominance. Most frequently affected site is the pineal gland, and less frequently it can affect the suprasellar region, basal ganglia, and the thalamus. So it can be focal as well as multifocal, which is probably what we have in our case, a multifocal germinoma. The common presentations are diabetes insipidus, hypopituitarism, and also visual field defect. So potential positive findings includes elevated levels of AFP and beta HCG, which was absent in our patient, and also imaging findings of T1 weighted iso or hypo-intense, T2 weighted iso or hyper-intense midline lesions, which enhances with gadolinium, which is what we found in our case. The first line treatment is radiotherapy with a 2-year survival of greater than 90%. The alternative is a systemic chemotherapy with reduced doses of radiation. So the progress of this patient, so the preoperative hormonal profile was showed he had hypopituitarism and also central diabetes insipidus. Luckily, he had no other systemic involvement with other systemic investigations. So he was referred to oncology for radiotherapy, which was completed in November 2017. So his visual acuity initially deteriorated a little bit after his radiotherapy. But fortunately, when I saw him 2 months ago, he was at least able to maintain 2200 vision in the right eye, although left eye was only hand movement. He was systemically well. He was still on hormonal replacement, and his MRI only showed post-treatment changes, and he was actually able to go back to work as a salesperson. So, so the summary is that In this case, although his MRI was highly suggestive of a demyelinating disease and his CSF showed oligoclonal bands, which kind of should suggest a diagnosis of multiple sclerosis. However, on the MRI, when reviewed by a neuroradiologist, there was atypical involvement of the hypothalamus and the pituitary stalk. And I think very important for us is that he actually had an atypical clinical course. I mean, he did not complain of the typical optic neuritis associated optic neuritis type of symptoms at all. So it is these sign of suspicions which led to the diagnostic brain biopsy and also the final diagnosis of CNS dysgerminoma. So I'd like to thank my team members and also the neurosurgeons, the neuroradiologists at different hospitals, and especially my colleague Noel Chan. And this was eventually published with another 2 cases with Dr. Andy Lee's team. So thank you. So I'll stop sharing now and would like to invite comments from the panel.
Great case, great case. Yes, Andrew.
So as Carmen said, we wrote up these cases together, and the 2 things that I learned from my cases are, my cases had pineal lesions, which I thought were benign. I said, that has nothing to do. I actually told the patient, that has nothing to do with your optic neuritis. Man, was I wrong. And that pineal lesion kept growing. And I really did not think about dysgerminoma at all in my case. I was just totally off the rails on it. So I would just add, if there was this pineal thing, you should be worried about that thing too.
Yes, Dr. Miller?
I'm interested in that you said that the first line of therapy, and apparently what you did as first line therapy was radiation therapy. We no longer give pure radiation therapy. Our oncologists feel very strongly that chemotherapy and radiation therapy together offer a much better prognosis and less potential for difficulties from the radiation. So we're always using chemo and radiation therapy for germinomas.
There's a question from Dr. Umapati, localized about the sweating abnormality, the explanation for that, Carmen.
We feel that it's due to the hypothalamus involvement rather than an infiltrative gangliopathy. To be honest, I don't know what an infiltrative gangliopathy is. So
in this case, the optic nerves, as we were discussing, the optic nerves were infiltrated?
The optic chiasm was infiltrated. In fact, if you review the original MRI, it looked abnormal. It's just when the MRI was taken and it was at an outside center, they had just your normal radiologist reporting on it and not a neuroradiologist specialist. So I think another lesson to learn is if the radiological findings are not consistent with the clinical findings, the neuroimaging always require reinterpretation by the neuroradiologist.
Another thing, the age group was a little older, so probably the lesion had been there for a long time because the patient presented at 24, while it's first and second decade that it presents.
Yeah, he was 24, but I think he already probably had I think his visual loss was quite insidious. So he probably had some problems maybe a year or 2 prior.
You have a short stay.
I don't want to say something.
Because of diabetes, insipidus or anything?
We're not able to hear you, Dr. Meenakshi.
He did not.
I asked if their patient had a short...
Dr. Meenakshi was asking whether she had...
Short stature.
Yeah.
I think she asked whether... No. He had normal stature, but just like any other Chinese young man, he was quite clean shaven, and I didn't really ask him about other symptoms of testosterone deficiency. He was of normal status. He looked normal, but just clean shaven. Yeah.
Andy, he wants to add.
Yeah, I would just add that the other things that were tip-offs only in retrospect, that they were both young men So that's kind of a germinoma story. And also my patient responded to steroids. So we should add that to the list of steroid responsive, the lymphoma story, except it was just germinoma. So those are the two other things I learned from that case. Is that
what about
steroid
the
responsiveness.
OCB positivity? How is that explained?
Yeah, Carmen can comment on that too. I think that we use that all the time for MS, but it's just not specific. I mean, you get oligoclonal band response from immunoglobulin to all sorts of things, sarcoidosis, tumor. Just to me, it just means you have oligoclonal production of intrathecal immunoglobulin. It doesn't tell you that the target is myelin.
Any
It's
other
very
comments?
non-specific. I was just going to say oligoclonal band, it's any CNS inflammation can cause that. And so that is why in this situation, it's misleading here. It's also quite interesting that your case was in October, it was in August 2017, and the new McDonald criteria came out around October 2017. And you made a comment that initially it was classified as a clinically isolated syndrome based on the old McDonald criteria. But if you had put the new McDonald criteria,
with the new criteria, it would have been MS already.
Yeah, mine too. Mine would have been MS too, because my guy had the pineal thing. So he kind of had this dorsal midbrain looking thing. So he had optic neuritis and then he got dorsal mid. So my guy would have met criteria too.
I have a question, please, for Neil Miller. Back to your comment. You're still there? You're not on my screen, but you're hopefully
Yeah,
He's
somewhere.
there, he's there.
Hi.
here.
Yeah, your comment about using radiation and chemotherapy, is that typically done now? Are you doing chemo first and then radiation on what's left, or vice versa, or concurrent? Could you just comment on how that is actually done?
It's concurrent. Basically, they start with some chemotherapy, and then about a week later, they start radiation therapy. But it's a combination of the two. As I say, I was trained just radiation therapy, and everything melts away, and it's wonderful. But according to the literature, apparently, you do better with a combination of chemo and radiation.
Okay, thanks.
Any other comments from the panel?
May I ask a question, Dr. Shikha?
Yes.
Yeah, Carmen. Hi, Ambika. So did you have any presentation of increased urination in the night? Because I had a patient who had a bilateral thickening, and a child, in fact, it was a 12-year-old girl, who had presented with a bilateral asymmetric drop in vision with a diffuse thickening of the optic nerve and the chiasm. And the only added symptom was frequent urination in the night.
He didn't volunteer this, and I didn't really ask about his. I
didn't ask this because during the entire examination, that child went from my OPD room twice for urination. So I was asking, is she feeling cold or why is she running like this? Only then the father brought out that history of, she's gone only twice now. She used to go 10 to 20 times in the night waking me up. I was shocked. I asked, this is something new what she has developed, because we were puddling with the diagnosis of atypical neuritis with a chiasm thickening, suspected she was aquaporin negative. She was a 12-year-old girl. She did not recover from the vision, and the thickening was not that severe and not too classical for a germinoma. And even when we gave the option of a biopsy, the father refused at that time. But when she came back after the probable treatment for a demyelination event from a pediatric neurologist wing, we went ahead, did a biopsy, and it turned to be a germinoma, and we have published that case report too. Wow. So that child had, and then the neurologist said that that's the diencephalic involvement, and that's the reason. And she brilliantly responded to the desmopressin, and she stopped waking her dad in the night.
I think that's a really interesting issue, Ambika, because we're used to asking these patients if they drink a lot of fluids and how much fluids they drink, and not necessarily how often they urinate during the day and night.
I also like this. So I'm sorry, just very briefly. Just one more thing that you could miss if you do video conferencing instead of a live patient evaluation. You might miss the fact that the patient just left the room 5 times while they were with you. Just saying. I'm not a huge fan of video conferencing, but thank you.
I think we'll have a final comment from Andy. We're running late. Andy, you want to add something?
So I was just going to say that's a really important thing that I've changed in my practice. All my optic neuropathies, I'm asking about those hypothalamic things. Sleep disturbance, the urination, DI, nausea, vomiting. I mean, weird stuff that I never would ask in a million years. And when I hear that hypothalamic stuff, I'm thinking, okay, that's infiltration. That's not demyelination. So yeah, I'm asking all these weird things and they look at me like I'm nuts.
Yeah, I think from now on, I need to ask many more questions during my neuro-ophthalmology clinic, which will overrun even more.
So in this panel itself, 2 cases from Andy, 1 from Carmen, 1 from Ambika, and in the chat, even Luciano has written that he's got 1 case. So we've got 5 cases reported in the meeting itself. So a great session. I thank everybody. And now I request Dr. Satya to take the program further. And I request Dr. Padmavati also, if she's there, Dr. Satya, Dr. Padmavati, to take the program ahead. Let's move on to the second session.
Thank you very much.
Thank you.
Thank you so much, Shikha. So now I'm going to introduce to you Dr. Padmavati. Let me just share screen now. Yeah. So Dr. Padmavati is the head of neuro-ophthalmic services at Arvind Eye Hospital, Tirunelveli, South India. Her areas of interest include OCT analysis of disc edema of varying etiology, supranuclear palsies, and toxic optic neuropathy. She has publications in various national and international journals, and she's an invited speaker in state and national conferences. Over to you, Dr. Padmavati.
Thank you, Dr. Satya, for introduction. Good morning, good afternoon, and good evening. It's a warm welcome to one and all. We move on to the next session, session 2. That is, I'll share my screen. This is the second session. We have 3 cases with 3 panel members, my colleagues. So let me introduce the first panelist. It is Dr. Ambika. She is head of the Department of Neuro-Ophthalmology in Shankar Nethralaya, Chennai. Her areas of interest include optic neuritis, demyelination, ocular myasthenia gravis, mitochondrial optic neuropathies, and neuroimaging. She has authored many publications in ophthalmology, neurology journals, and she has authored an atlas in neuro-ophthalmology, also an atlas in neuroimaging in ophthalmology. Also, she is also an executive board member of Indian Neuro-Ophthalmological Society and Neurological Societies. She is also in the editorial board of AOS. Dr. Ambika will share. The next person is Dr. Jyoti. She is the head of the Pediatric Ophthalmology Department at Narayana Nethralaya, Bangalore. Her areas of interest include pediatric cataract, neuro-ophthalmology. Teaching is her passion. Dr. Matelia is volunteer faculty of Orbis International as well. She has undergone her fellowship training at LV Prasad Institute, Hyderabad, and completed her ICO fellowship at Wilmer Institute, USA. She has more 45 publications in reviewed journals She has also presented in various conferences in India as abroad. She has several award-winning teaching videos in the American Academy of Ophthalmology and ECRS. The third panelist is with me, Dr. Krishna Vaidishwaran. He heads the Department of Ophthalmology at Stephens Hospital, Delhi. His interests include optic canal decompression for traumatic optic neuropathy and idiopathic intracranial hypertension, as well as optic nerve vascular disorders. He is the editor of the book Current Perspectives on Ophthalmology. This is the edition 5 to 10. Next, Dr. Ambika will introduce the speaker, Dr. Stephen Hoffman. Over to you, Ambika.
Am I audible? Okay. Thank you, Dr. Padma, for the warm introduction. And now we will move on to the first speaker for the session 2. Let me introduce Dr. Stephen Hammond, a clinical research associate professor and consultant neuro-ophthalmologist from University of Copenhagen, Denmark. His research interests are around optic neuropathies, and he is the founder of International Optic Disc Drusen Studies Consortium, of which he is the chair. And the aim of the ODDS consortium is to investigate in depth the etiology, diagnostic principles, structure, function relationships, and management strategies of optic disc drusen. It's nice to have you, Dr. Stephen, over here. And I think you can start your talk. Over to Dr. Stephen.
Thank you very much. And good afternoon here from Copenhagen, Denmark. And thank you very much for the kind invitation. And to the organizing committee, I'd like to say thank you for this beautiful meeting in these troublesome times. All right, the title of my talk is Twice in One Eye, What Are the Odds? So this is a 12-year-old boy who was referred from his own eye doctor with a suspicion of bilateral papilledema. The day before, he experienced a sudden painless visual field loss in his left eye, and he had no other symptoms. He was completely healthy. Upon examination, he had a normal visual acuity, and in his right eye, he had some minor visual field defects, and in his left eye, he had a severe infranasal defects. Color vision and pupil examination was normal. When we looked at his discs, the right had slightly blurred margins, no central cup, and on the left side, there was some superior disc edema with a hemorrhage and also a central hemorrhage. So what we did in our clinic was to do an enhanced depth imaging OCT of the optic discs. And here we see two important findings. First, we see some hyporeflective structures with hyperreflective margins, and then we see some hyperreflective structures also, but those are peripapillary. I'll get back to these structures in a little while. In this case, we also did an ultrasound of the orbits, and here we saw some hyperechogenic structures at the optic nerve head, and he had a CT scan of the brain and orbit. It was completely unremarkable, apart from some hyperdense structures at the optic nerve head. So the diagnosis here was bilateral optic disc drusen and left optic disc drusen associated anterior ischemic optic neuropathy. I'll get back to the case in a short while. First, I'll talk a little bit about optic disc drusen. Those are calcified deposits located in the anterior part of the optic nerve head in about 2% of the population. And in the vast majority of cases, it's a bilateral condition. The pathophysiology is yet unknown, but we believe that there's an impaired axonal metabolism in genetically predisposed individuals, and also the presence from birth of narrow scleral canals. Those are all factors that are believed to play a role in ODD development. In nearly all cases, or at least 90%, we see visual field defects probably caused by progressive axonal injury due to compression. And in some cases, like this one, we see sudden axonal injury and visual field loss, usually due to AION. So let's talk a little bit about diagnosis. So when the drusen are visible on the disc surface, it's quite easy to place a diagnosis. But sometimes we face this diagnostic dilemma, whether it's a case of subtle papilledema or buried optic disc drusen, and this can actually be quite hard. And in this case, we have in the middle buried optic disc drusen. Here we have idiopathic intracranial hypertension. Luckily, we have the OCT, because we've known for a long time that about 60% of the drusen material is actually located underneath the surface of the disc, like an iceberg. And we've come a long way since the first OCT scan of the optic disc drusen was presented by Rowe and colleagues in 1998, to the non-enhanced depth imaging spectral domain OCT, and now to the enhanced depth imaging OCT, where we can identify the whole drusen, including the posterior border. So now we speak about visible or buried drusen based on fundus exam, and based on OCT, we can speak about superficial drusen and deep drusen. And it is the superficial drusen are the ones that are above Brooks membrane opening, while the deep ones are below. And furthermore, we can speak about large drusen, small drusen, and conglomerates of drusen, and we can use the small scale bars that are usually in the OCT scan images. So in that way, we can use OCT to detect optic disc drusen in all ages, regardless of the degree of calcification. This is just an example from a 3-year-old boy. So in the Optic Disc Drusen Studies Consortium, we've come up with some guidelines. I will not go through these in detail, but just to mention to you that it's very important to do a very dense optic nerve head scan. We use at least 97 sections to go through the optic nerve head, because in that way we get 30 microns between each scan, and in that way we're certain not to miss any drusen. So here are our guidelines for diagnosing drusen using OCT. So the OTD always have a signal poor core. They usually have a hyperreflective margin. It's most prominent anteriorly. Prelaminar hyperreflective lines, they probably represent early OTD. And then we have these structures, the FARMs, the peripapillary hyperreflective ovoid mass-like structures. These should not be diagnosed as OTD, and they probably represent herniated retinal nerve fibers. I'll go back to them shortly. And finally, we have the vessels. And the vessels are tubular in structure, and they cast shadows all the way through the disc, as you see here. So the FARMs are unspecific OCT markers of exoplasmic flow stasis, and we see them in all kinds of optic disc edema, as well as in optic disc drusen, and also in obliquely inserting optic nerve heads. So there are two signs to look for on OCT to make sure it's the FARMs. First one is peripapillary. So you can clearly identify the Brooks membrane underneath the FARMs. And then there's this, what we call the ski slope sign, which is like an upward deflection of the overlying retinal layers. Those are very good signs to look for. Recently, we found out that in the beginning, we thought that we saw all these 2D images of the drusen and FARMs. We thought that one disc had multiple FARMs, but actually it's the same FARMs that if you do the radial section, you can follow it all the way around the disc. And here's a little video, and you can see here, we do the 97 sections, you can follow the FARMs, and it goes all the way around the disc. Here you have it. So it has this toroidal extent like a donut. The peripapillary RNFL thickness is useful for screening and follow-up, but it's not a reliable tool for differentiation between pseudopapilledema and papilledema. And this is just one case illustrating this with a 28-year-old with IAH and a 10-year-old with optic disc drusen. And the RNFL is way thicker in the drusen case. So in our opinion, the best way to distinguish the two using EDI-OCT is to simply diagnose the ODD, looking for the characteristic hyporeflective structures. You should, however, be aware of coexisting ODD and papilledema. And in these cases, the peripapillary wrinkles, folds, and creases are signs of coexisting raised intracranial pressure. And Patrick Sibony and colleagues recently came up with a beautiful review in JNO regarding this. So back to our case. This is when he presented. 8 months after, he had no new complaints, same visual field defect, and now some segmental atrophy of the disc. Unfortunately, when he was 15 years old, 27 months later, he had a new bout of sudden blurred vision in his left eye, so the same eye. This time it was upwards in his visual field, and he had a new segmental disc edema. And finally, when we saw him at control, he of course had severe optic atrophy and now a very constricted visual field. So the final diagnosis is ipsilateral recurrence of ODD iron in a 15-year-old. So what are the odds for this? Well, ipsilateral recurrence of iron in itself is rare, and it has been described in old Hayrate papers in 6.4% of all iron cases. And we believe this is the first description of an ipsilateral recurrence of ODD iron. It was recently published in here in JNO. So ODD iron, is it rare? Well, perhaps it's not that rare. This is just one quick case I'll mention that I saw just before coming here. It's a 14-year-old healthy boy with bilateral sequential ODD iron, and he had less than 6 weeks between ischemic events. So he had his right AION in the beginning of August. Here you see the disc edema. And then on mid-September, only 10 days ago, he had his left AION, and now he has optic atrophy on the right side. And you see these big drusen here on both sides. So we did 2 studies, retrospective studies, looking at the young NIAN patients, so NIAN patients below the age of 50 years. And we found a high prevalence of 51% in one of the studies that was done in the ARTS consortium. And in another study of Canadian and Danish patients, we saw 53% of young NIAN patients having ODD. So based on these findings and multiple earlier reports, we think that ODD iron should be considered a separate subtype of NIAN. So the question is this only in young NIAN patients? Well, I don't know, but this is just recent findings from our clinic with a 74-year-old woman with left ODD iron and an 82-year-old woman with left ODD iron. And interestingly, you don't really see the drusen on the surface in these cases, and they had really no significant vascular risk factors. To find out the prevalence in older age population, we're going to launch a prospective ODD iron study in all age groups in 2021. All right, so I'm just going to sum up now the take-home messages. ODD are best detected using EDI OCT, can be seen in all age groups. It's well suited to distinguish between subtle papilledema and buried ODD. ODD iron is a subtype of NIAN and constitutes more than 50% of all NIAN cases in young patients, and we don't really know the prevalence in the elderly population. In the initial stage of an NION, it can be quite difficult to see the ODD if there's severe disc edema. Here's a good trick to look at the fellow disc and then to look again at the NIAN disc when atrophy ensues and the ODD become easier to visualize. Based on these findings, we suggest that all patients with NIAN under the age of 50 years and no visible ODD on ophthalmoscopy should have an EDI OCT of the optic discs to look for ODD. All right, finally, I'd just like to thank the ARTS Consortium, which you can see here are based all around the world. We have our annual meeting at NANOS. This is from the last real-life meeting. Unfortunately, the next is going to be a virtual one. And we're working on several fronts, and all with the ultimate goal of reaching a stage where we can say we can treat and prevent ODD and ODD-related visual loss. Thank you very much. Any questions?
Thank you, Dr. Stephen. It was indeed a very nice presentation. Actually, when the incidence of non-arthritic A1 in young is relatively rare, do you have any systemic association associated with it?
You mean with the ODD AION? If we see, well, we saw. We looked at the vascular risk factors as well, and we saw slightly less vascular risk factors. But of course, it's we have only been looking at the young age group, so so it's natural that they should have less risk factors. It's going to be interesting when we're going to compare in all age groups, of course.
One question I had is that for those in older age group, did they have any ischemic risk factors? The two cases you showed.
The 2 cases did not really have any risk factors, no. But those are just 2 cases, yes.
Right.
Over to Ambika. I think I'll start share my screen regarding the questionnaire which we had prepared for Dr. Stephen. 1 minute.
Stefan, I have a couple of questions for you. You've written about this peripapillary vascular density. Do you think OCTA really has a role in diagnosing optic disc drusen, or is it just a general finding? And the other question I have, and Andy brought this up in his thing, you back in 2016, you and Malmquist wrote about the histologic findings. Have you compared the histologic findings with these ovoid masses? I mean, to see exactly what they are?
Thank you. Yeah, that's two good questions. The first one, the OCTA and the FARMS. Well, there's another group that has found, perhaps that's the one you're referring to, who has found vasculature within the FARMS, and which pretty much rules out also, together with other arguments, that it's not the drusen structures. But apart from that, I'm not really sure of the role of OCTA in this, but we're definitely going to look more into this. We're at an early stage here. Regarding histology, yes, we unfortunately haven't done histology on a same patient where we have OCT. So so the people are not sacrificing their eyes because of drusen. So that's a problem. But we have quite a large material of old material from early days. And we just finished a review focusing on these similarities between FARMS and the structures that are pericapillary on histology, and hopefully this will come out soon. Yeah, but
Okay. Ambika, your question.
Sure. So that's an interesting presentation, Dr. Stephen. And one important thing, what we all face the difficulty is differentiating early papilledema from that of a buried drusen. That's one thing which we all struggle in the clinical practice. In spite of using a OCT, many a times we find it much difficult. Is there any guidelines what you can give on OCT which can give us more clues towards a papilledema rather than a disc drusen?
Yeah, so there are several clues, but I think the most important one that I just mentioned was to do the really dense optic nerve head scan. So in our opinion, you can do it with the Heidelberg EDI OCT. You can also do swept source OCT. And at the moment, we are comparing different modalities in their ability to pick up the small drusen. And our opinion is that the EDI OCT has a higher resolution, but it's very important that you do the 97 sections and that you do the averaging of the scans if you're in doubt. So usually you should be able to pick up the drusen in these cases. And I think it gets more difficult, of course, if it's a child and the child has headache, so you can get in doubt whether there's an overlying raised intracranial pressure as well. And in these cases, I think it's a very, very good idea to look for the pericapillary wrinkles and folds as described by Sipani and colleagues especially.
I'd like to add a point here. So it's OCT, especially in a child, sometimes it may be difficult. I tend to use the B scan. B scan not only helps pick up a drusen, but if you actually do a cross section of the optic nerve, we can pick up presence of papilledema by looking at the subarachnoid fluid right behind the optic nerve. And it's like a hypoechoic crescent that comes, or a donut sign, which can tell you. So in cases where you have a simultaneous drusen with papilledema, this can be an easy step in the OPD to pick up the findings.
Yes, I think that's a really good point. And the only thing I was just going to say regarding this is that if you have a very small child, and it can be very difficult to pick up the drusen because they're not as calcified. If you're like it's a 2-year-old or 3-year-old, maybe they're not calcified. This one was a 12-year-old, which clearly had a huge degree of calcification, so you could easily pick it up on both ultrasound and CT scan.
So Andy, you had a point?
Yes, Stefan, that was really great. can you comment? The way I tell our residents about the FOMS is, because I think it used to be said the FOMS was drusen, but now it's like, it doesn't mean anything. It could be real disc edema, it could be fake disc edema. We should just blow it off, right? I mean, it can be real disc edema with the FOM.
Yeah, definitely. Definitely, I would say that it's rare not to have FOMs in disc edema, actually. So this is just, you know, an unspecific marker of axonal congestion in the optic nerve. And if you have disc edema, you can also see that the FOMs resolves afterwards. And, you know, if you take a new OCT of the disc half a year later, or something like that, there's no FOMs anymore. So you can also have the FOMs in maybe if you have a narrow scleral canal and you have no problems and no symptoms at all. The abnormal disc also have. So yeah, it's really a non-specific marker. I agree.
Dr. Stephen, I have a question. Is the management any different from that of the adult non-arthritic AON?
Well, that depends. You know, in the beginning, the reason why we started to look so much for this was because we saw some cases with completely healthy young people, active people, and who came in with an NION, and they were sent out for all these kinds of examination, and they always came back normally. And then we started to looking more in detail after the drusen. So the question is whether we should still keep on sending everyone for a thorough vascular examination if they come in. I think we will have to base this on now we're going to launch this large prospective studies, and when we can collect the data from this from all age groups, we can start saying something definite about this. But until then, it's probably a good idea to have like a basic checkup, even in a young child that comes in with an iron, or although you say if the optic nerve is filled up with drusen, you're probably sure that that's the only reason, and if there's no symptoms whatsoever.
Dr. Krishna, any comments on the?
I think it is an excellent presentation, and yeah, I mean, I think it's something which we see so often. But I remember that in India we don't see too much of optic nerve head drusens. There was a South Indian study, I think by Shikha, who presented about 0.03% in the population. So we don't get to see too much of optic nerve head drusens. But as somebody in the chat mentioned, I guess we're going to see a lot more of optic nerve head drusens after your OCT parameters that we get to see. So I think we'll be diagnosing far more optic nerve head drusens than we previously reported.
Yeah, thank you. Yeah, I noticed this. This is a very large study you had with a very low prevalence. But I definitely agree. Once you start looking for it using OCT, you'll probably find more. Yeah.
I have a question to you, Dr. Stephen. Have you seen any difference in the level of the drusen in a child when you did the repeat EDI OCT? Was the surface, or the level of drusen, has it moved or changed?
Yeah, so that was one of our goals initially, was to we have been following kids from the age of 11, 12 up till 16, 17, and we have been looking at what happens with the drusen and with the hyperreflexive lines and all that. And we were very interested in watching whether the drusen they enlarge or whether they migrate in a way. So our impression is, well, our studies show that the drusen, they sometimes enlarge and sometimes they develop de novo, but we don't really see that they migrate. So you cannot say that they move to another place. They just either they get bigger or they become more of it.
Okay.
I think we are running short. Yeah, finish it. Yes,
Dr. Padma, only one last question, because since this patient was a child with a bilateral disc edema, I don't know how frequently we would directly go for, after the visual fields, and EDI OCT to do it, because in India way back, first thing we will check BP, because whatever said under the thing, like a child, we happen to see a child with a adrenal gland mass presenting with a malignant hypertension like this, with one eye ischemic optic neuropathy. So that's another one thing, like what he had highlighted, that we have to do the systemic evaluation and then probably move on to EDI OCT, because not many centers would have this facility of EDI OCT also.
But you know, this was this guy. He came in with buried drusen on both eyes, and then segmental disc edema on one eye, and he only had blurred vision in a lower visual field. He had no other symptoms, so he didn't have bilateral disc edema. So if he would have had that, perhaps that would be another story. Yeah.
I just want to make just one little more point about hypertension and disc edema. Usually, if you have a hypertensive child with disc edema, usually you would have vascular changes going beyond the second and the third crossing, which can easily differentiate between the actual the ischemic optic neuropathy or a hypertensive neuropathy. And because if there's a mixed picture with an ischemic neuropathy and a hypertensive retinopathy, that could support the diagnosis. Just an indirect exam, just beyond the, or a wide field photography, just beyond the third, vascular crossing.
Yeah, great point.
Okay, I think we'll move on to the next case for the want of time. It is a marathon, not a sprint. It is by Dr. Marian de Virgals. We will ask Dr. Jyoti, please give the introduction. Over to Jyoti.
Yeah, thank you. Can you put the slides?
Yeah, 1 minute. Just... This is, I'm sorry.
Yeah. So I'd like to invite the next speaker for this session, Dr. Maria D. Virgilis. She's the head of neuro-ophthalmology at the Pedro Laglaese Ophthalmology Hospital and the Austral University Hospital. She's a neuro-ophthalmology coordinator of this hospital and Argentine Congress of Ophthalmology. She is also the director of postgraduate and undergraduate degree in ophthalmology at the same hospital for the Buenos Aires University Argentine Ophthalmology Society and the principal investigator of the ECU 301-302 ophthalmology optical neuromyelitis protocol. Over to you for your presentation.
Thank you so much for the invitation. I will share my screen. Yeah, here I am. Okay, incredibly excited to be presenting this case here today. I know I have no financial disclosure. I would like to present you a clinical case of 21-year-old woman with an acute painless severe loss of vision in her left eye, OS. No other symptoms, only positive cut exposure. At presentation, she has count fingers OS, RAPD, fundoscopy normal. So here the visual test, OD normal, OS dense central scotoma, brain MRI, you can see T1 and flare unremarkable. Orbit MRI shows the enlargement and brightness of the left optic nerve. So here's the discussion, but in 2003, optic neuritis associated with melating disease, post-vaccination optic neuritis, but no previous history. Optic neuritis associated with inflammatory or infectious disease like cat-scratch disease, Bartonella-Hensley, tuberculosis, syphilis. they decided not to treat and diagnose typical optic neuritis without recovery. Here, our first red flag. So from 2003, first episode of optic neuritis without recovery, without treatment, and without symptoms, till 2007, where she presented with this long, extensive myelitis. As you can see in the MRI, you can see the extensive almost more than 5 segments. So intravenous methylprednisolone 1 gram per day for 3 days, oral taper, azathioprine 150 milligrams, indirect immunofluorescence aquaporin 4 was negative. The new criteria diagnosis published in 2015, Dr. Winhead took, International Consensus Diagnosis Criteria, the core clinical characteristics remain optic neuritis, acute myelitis are the 2 most common NMO spectral disease. But the second most common way can present actually is area postreme syndrome, where you can get a lesion in the posterior medulla, as you can see, and where the patient can present with unexplained hippus or vomiting. Acute brainstem syndrome, symptomatic cerebral syndrome, symptomatic narcolepsy. And to make the diagnosis, you need 1 core clinical characteristic plus aquaporin 4 positive. And you can make the diagnosis of seronegative aquaporin 4. And for this, you need at least 2 core clinical characteristics, and one of them has to be one of these 3 major common presence. So what happened in 2010? A new optic neuritis diagnosed, but this time OD. She received IV methylprednisolone and plasma exchange, azathioprine, and cyclophosphamide because a detail, node coverage for mycophenolate or rituximab. But luckily, visual acuity, final visual acuity was 20/20. So this time, equal vision in the acute treatment of cohort, aquaporin, or MUG optic neuritis. Here we see that even a 7-day delay AVMP initiation was detrimental to the vision of patients with biomarkers. So acute treatment, IV methylprednisolone 1 gram per day for 3 or 5 days, and plasma exchange has been shown that the earlier you treat, the better recovery you get. So 2011, autoimmune thyroiditis. Here, the description of autoimmune disease and antibodies as aquaporin 4, and we have almost 20% of overlap. 2012, acute and severe spastic weakness of the legs, severe paraparesis, and in the MRI, again, extensive lesion, you can see that it extends more than 5 segments. In IV methylprednisolone, 1 gram per 5 days, oral taper, mycophenolate. And guess what? Rituximab not covered. So 2015, new relapse, optic neuritis OD. We knew the patient at this time, so we decided intravenous methylprednisolone, plasma exchange, and started with rituximab. Also, we performed cell-based method and aquaporin 4 was positive. Final visual acuity 2020. So what's about antibodies? All antibodies are specific, but cell-based method is higher sensitivity. As you can see, more than 90. So the serum is actually more sensitive than CSF other point. So chronic treatment, azathioprine, is the cheapest but less effective than the others. So experts recommend starting with azathioprine for mild disease or when neither rituximab nor mycophenolate is available. Mycophenolate is more expensive than azathioprine, has fewer side effects with more efficacy and more tolerated than azathioprine. But rituximab, several comparative studies have demonstrated that rituximab is more effective than the others. So some recommendation guidelines have suggested that rituximab may be used as the first-line treatment, but on the other hand, we have high cost and limited access. So 2019, this publication shows the availability and affordability in 60 countries, shows the different reality of Latin America and the decision of medication according to the availability and income levels. This year, we have Latin American consensus, and the recommendation of the consensus guidelines seek to optimize management and specific treatment of NMO spectral disease patients in Latin America. So I received another gift for 2020. The patient started with fever, cough, difficulty breathing, so bilateral atypical pneumonia, COVID-19 was diagnosed. Luckily, she's pretty well right now. So we can stop here in this summary. First, optic neuritis episode 2003 without recovery, our first red flag. 2007, myelitis. 2010, a new optic neuritis, OD. 2011, autoimmune thyroid disease. 2012, myelitis, and the last optic neuritis, 2015. To sum up, NMOs was diagnosed in 2007. Recurrences occurred 2007, 2010, 2012, 2015. Finally, from 2015 up to now, she hasn't had any relapse. What will happen next? New relapse in the future? So maybe the answer is in this article. The American Academy of Neurology called NMO the disease of the year in 2019 because 3 separate NMO clinical trials showing efficacy of 3 different new medication. First one, eculizumab, first FDA approved. Second one, inebilizumab, and the last one, satralizumab. And this year, we have new studies about safety and efficacy of rituximab, tocilizumab, and satralizumab as monotherapy. In conclusion, we need to consider the different circumstances of our patients. All antibodies are specific, but the cell-based method has higher sensitivity. Prognosis and treatment are different between MS, NMO, or MOG disease. And please treat all patients with IV methylprednisolone and oral taper. Thank you very much. Muchas gracias from Argentina. And this is our Argentinian team. Thank you so much.
Thank you. A very nice case, a long, elaborate history. So one question I had, was it possible to diagnose NMO in the first visit itself? Were there any features that you could look for to help you think of NMO at the first visit?
Yes, maybe the lack of recovery and the severe decreased vision was the first red flag. I knew the patient in 2015, so I don't know what happened because the patient lives so far away from Buenos Aires. So, but yes, you have the first red flag, and was in 2003, and aquaprine 4 antibodies are from, Lennon 2004. So we can, but yes, when you have an atypical optic neuritis, you have to ask about MOG and aquaprine 4 antibodies, of course.
Mariana, how long does it take you to get your antibody assay back? Because one of the issues you pointed out, this issue about 1 week versus 2 weeks before you start Plex or something of that nature. And we find ourselves always in conflict where you have an optic neuritis, it doesn't get better in the first week, and that's not unusual in a lot of cases of standard optic neuritis. and yet we don't know whether to wait an extra week to get the assay back or begin Plex right away.
Yes, we always try to get the antibody before the intravenous or the immunosuppression treatment, because that diminishes the rate. And before, of course, before plasma change. Sometimes you don't ask because it's the first optic nerve and it may be recovered and you don't know, but we try, if the patient have a severe loss of vision or a great disc edema, we try to ask about the antibody as soon as possible.
Dr. Padma? May I ask a question, Dr. Padma?
Yes.
Yeah.
Okay, so my question is to the panel, like when do you choose the next line and when do you decide when there is an isolated optic neuritis, when there is no recovery, MRI negative and CSF negative and markers negative? The patient has not responded to the intravenous steroid therapy, and we are in this situation where we don't have an MRI evidence, we don't have any zero markers which are positive, but the patient has not recovered from the vision.
Well, that was sort of my question, is you have that situation, how long do you wait before you go ahead with, and you don't have your antibodies yet. When I was in Asia some months ago, before all the pandemic, they were saying that it was not unusual for them. The neurologist felt comfortable waiting about 2 weeks. John Chen tells me that he feels that a couple of weeks is okay, but it makes me very nervous about things. And we tend to push, probably within 7 to 10 days, we would start Plex
Yes.
In those cases. I don't know, Mariana, what you guys do.
Between 5 till 7 days also. We try to put under Plex immediately, because if it not respond, we need to do something. Andrew?
Dr. Lee, you have a question? Yeah, please go ahead.
So I start pushing on them at day 5 because I know it's going to take forever. And then we keep pressing harder every sequential day. But I already start raising it at day 5. But they're going to say no. Then 6, they say no. 7, they say maybe. Day 8, they're like, okay, maybe we'll try to do it. And then by day 14, we have it.
Yeah. So, yeah.
So Plex will be your, sorry.
Yeah, please, Ambika.
Yeah. So Plex will be your choice in this situation when there is no visual improvement.
Yes. I'm thinking about in something else, in MOG disease, in NMO disease. You have to think in something else when the patient don't recover vision.
When the markers are negative?
But you have NMO spectral disease, 20% of negative, and this negative NMO antibodies may be a MOG positive antibody. So you have to undergo to MOG antibody samples.
My question to, okay, Andy.
Yeah, I've taken to writing that on the chart, zero, negative, or we don't have it yet, but it's still NMO. Otherwise, our insurance companies won't pay for it. So we have to write zero negative on their chart, zero negative NMO on their chart. Otherwise, they don't even look at it.
There is a question in the chat. Do you see a macular microcystic edema in the OCT of this case and other NMOSD patients? Dr. Marian?
Excuse me?
Do you see a macular microcystic edema in the OCT of this case? And do you see in all other NMOSD cases?
No, I never see. I know that it's described microcystis in the macula, but I never have a patient with a macular microcystic edema at the OCT.
Is there any racial difference in the presentation of atypical optic neuritis across the globe? Anything which you would like in the Western as well as in the Asian perspective? You didn't get it?
I think the internet is like, could you repeat?
I think she's asking like how frequently you see MS and NMOSD in your place as opposed to the other.
Like a misdiagnosis between MS and NMO. You see, we see before the aquaporin 4, we have a lot of patients like MS or cryon, optic neuritis, and with the antibodies, we have more tools to know. And with the new criteria diagnosis, we have also a lot of new images that you can you can join, and you can think about optic neuritis for NMO spectral disease.
Okay, any other questions? I would like to ask the panel, how about the use of monoclonal antibody here in India? Because till plasma exchange we are doing, I had one case, one young girl who couldn't have any improvement in the vision. With plasma exchange, she had a better recovery. But regarding the use of monoclonal antibodies, what is your say, panel?
Andy, would you like to take it?
I'm sorry, the state of the monoclonal antibody in our country? So we are rituximab first. That eculizumab is like $300,000 in our country. In my town, the limiting factor is not what monoclonal I want. It's whatever they will cover. That is what I get. I get IVIG, Plex, or rituximab, whatever they pay for. I actually don't get to choose. They tell me what I can give the person, not the other way around.
Dr. Miller?
That's exactly the situation at our institution. I mean, basically, we know that Plex is not very expensive. So once we do that, rituximab is probably our go-to because it's less expensive than eculizumab and tocilizumab. I think that, as Mariana said, I think it's really exciting with these monoclonal antibodies, but most of the insurance companies consider them experimental. And even if they're not experimental, that's what the insurance company says. So we do whatever the insurance company says we can do.
I think we live in a country where we don't have an insurance, and we still practice optic neuritis, which are not responding to treatment. And I go with Andy saying that we give anything that doesn't respond. The first choice what is given is Ritux, because it's much cheaper compared to any of this monoclonal antibodies. And even Plex is not that easily accessed because we need to hospitalize the patient. And even each cycle would cost around Indian rupee or 50,000, which the patients are not keen on getting. And they would prefer to have a rituximab once in 2 weeks, a shot, and go home. So I think we are having way down in monoclonal antibodies, and we are still continue to give anything, even because I think it's much better. Even by chance it turns out to be a MS, because imaging characters are not specific, our neurologists do not hesitate to give rituximab in such a situation where they have a debate whether to give a immunomodulatory agent or not, because we see a lot of mock disease now, because I think the access to the test has revolutionized our way of looking and treating these patients, because we were not having MOG antibodies until maybe a couple of years back in our place. So we started getting MOG antibodies and NMO spectrum disorders much higher, but still we have a huge chunk of double negatives presenting like this with a severe vision loss and not having classical findings of NMOSD disorders.
Yes, we prefer rituximab also, but sometimes the insurance or in a public practice, we can't afford the rituximab. So we have all these other things. And of course, eculizumab and satralizumab, and those are more expensive.
Any other questions from the panel? Otherwise, we'll move on to the next talk. It is GCA, which is the last talk of this session, Paradigm Shifts and Particularities to India. It is by Dr. Edsel Ing. Dr. Krishna, can you?
Yes, please.
Yes.
Yeah, it gives me, I think.
Will you share or I should just share the screen?
Can you share this? Yeah.
1 minute.
Yeah.
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 I'm sorry, it's running. My screen is very fast.
Anyway, I think I should begin by saying it gives me great pleasure to introduce a very, very talented and extremely well-read person, Dr. Edsel Ing. He's a professor of ophthalmology at the University of Toronto. I mean, he's totally blown my mind when you come to think of the wide range of talents that he has. He's completed 3 subspecialty fellowships at Wills Eye, Mayo Eye Clinic, and Allegheny General Hospital. He also has his master's in public health. I mean, that's amazing. As also a master's in political science with the United Nations. He's got his PhD in giant cell arteritis at Kingston University. And the last I heard was he was taking an exam for his MBA. So I want to welcome Dr. Edsel Ing, and a very talented, multifaceted person.
Thank you very much for the introduction. Can everybody hear me?
You're audible, Dr. Edsel.
Okay, great. So, namaste. I thank the organizing committee for this opportunity to meet with you. Today, we mind the P's of giant cell arteritis to enhance the Q's. That is the IQ and quality improvement in the management of GCA. We discussed the pretenders that mimic GCA, compare the presentations of GCA in India versus North America, and paradigm shifts, including problems with the American College of Rheumatology criteria and occasionally ultrasound, utility of platelets and prediction models as adjuncts to neuro-ophthalmic diagnosis are reviewed. So although GCA is uncommon in India, I hope this talk will keep you awake because 1, GCA is a prime ophthalmic emergency and an eminently preventable cause of vision loss. 2, COVID can potentially mimic the presentation of GCA. And 3, new drugs such as tocilizumab and the immune checkpoint chemotherapy agents are being increasingly utilized and affect GCA, uveitis, and retinal conditions. Now, to review, giant cell arteritis is the most common primary vasculitis in the elderly and can result in irreversible and occasionally bilateral blindness, in addition to myocardial infarction, arteritis, stroke, or death. Pathology shows granulomatous inflammation in the arterial wall with activated macrophages that may be abnormally large and multinucleated, leading to the appellation of giant cells. Giant cells are helpful, but not essential for pathologic diagnosis. Now, the immunology of GCA involves activation of dendritic cells at the adventitia media border with release of cytokines, macrophage stimulation, and T-cell polarization to Th17 and Th1. Th1 cell proliferation increases interferon gamma with further macrophage activation, damage of the arterial wall, and vascular occlusion. Interleukin-6 increases the Th17 cells that cause the inflammatory symptoms associated with GCA. Tocilizumab is an IL-6 inhibitor and steroid-sparing agent that helps decrease remissions of GCA. Now, perhaps the variable expression of Th17 versus Th1 components contributes to the wide spectrum of GCA presentation, from occult to isolated polymyalgia rheumatica, to fever of unknown origin, to large limb claudication. Ophthalmologists are most familiar with cranial GCA, presenting with headaches, scalp tenderness, jaw claudication, vision loss, and sometimes diplopia. A pallid, swollen disc, central retinal artery occlusion, or diplopia in an older patient are classic for GCA. Early and accurate identification of GCA may prevent the progression of vision loss. If you suspect GCA, the patient should be on 1 milligram per kilogram prednisone while awaiting test results. Use higher intravenous doses in patients with vision loss. Case reports of the less common manifestations of GCA include corneal edema, posterior scleritis, or lacrimal gland swelling from ischemia, and also retinal vein occlusion, facial nerve palsy, deafness, and dry cough. The ESR, CRP, and platelets are not specific for GCA and may be abnormal, or may be normal in 4 to 10% of patients. Note that the 1990 American College of Rheumatology classification criteria misidentify many neuro-ophthalmic cases of GCA, in part because age and ESR are dichotomized at or below 50 with loss of much statistical power. Now, due to the difficulty in the diagnosis of GCA and the side effects of glucocorticoids, temporal artery biopsy is traditionally performed to confirm the clinical diagnosis. Although imaging studies are gaining traction, the temporal artery biopsy, ultrasound, or MRI should be obtained within 1 to 2 weeks of glucocorticoid treatment so that the test results are not confounded. The diagnosis of GCA can be difficult due to its wide spectrum of presentation, which can be mimicked by infection, cancer, and other diseases. To illustrate, this is a case of a 77-year-old man with new onset jaw claudication and a 2-year history of polymyalgia-like symptoms and unintentional weight loss. There's a history of amblyopia, but acuity was stable without RAPD. Confrontation fields and motility were intact. There was no disc edema, CRAO, or nerve fiber layer infarct. The temporal arteries were prominent but not tender. The ESR was 35. Temporal artery biopsy showed amorphous eosinophilic material, but no inflammation. Congo red stain shows the birefringence of amyloidosis, and this patient was eventually diagnosed with multiple myeloma. Now, during this conference, you're going to encounter many other rare birds, which will bias your clinical decisions for many weeks. How might we decrease diagnostic errors in patients with more typical presentations of GCA? We must understand that physician diagnosis is prone to bias from factors such as emotions, mental shortcuts, anchoring bias, and recency. Numerous studies have shown that properly formulated classification algorithms derived from the appropriate population can outperform clinical intuition. Also, humans cannot accurately calculate the mathematical risk of multiple predictors, especially when these variables behave in a non-linear fashion. Now, to improve the objective diagnosis of GCA and possibly decrease the number of temporal artery biopsies, we formulated a 10-factor prediction model for biopsy-proven GCA that was compliant with the Tripod Transparent Reporting Guidelines and published this in 2019. From 14 predominantly North American medical centers, we used the data of 1,200 patients who underwent consecutive temporal artery biopsy to develop classification algorithms. Multivariable logistic regression showed that gender and diplopia were not statistically significant predictors for GCA, and this was confirmed on missing data analysis. Age, platelets, jaw claudication, and vision loss were the strongest predictors for GCA. Platelets, like ESR and CRP, are an acute phase reactant. Numerous studies have shown that thrombocytosis is a risk factor for GCA. We found that platelets were a more reliable serologic predictor of GCA than ESR or CRP, with an average level of 372,000 per microliter in our biopsy positive group. Now, although prediction models are not infallible, our classification algorithm weights the risk contribution of the 10 predictors without the bias of human intuition, and is especially useful for the continuous variables shown by the yellow arrows, which behave in a non-linear fashion. Our prediction model is accompanied by a freely available online calculator, which outputs an objective pretest probability for GCA without the intuition bias of human estimates. There's also a post-test calculator. I now contrast the results of our North American study with the published reports of GCA from India. I was able to locate 75 cases of GCA from different regions in India published over a 30-year period. This, in combination with a report from Moorfields of only one patient of Indian heritage with biopsy-proven GCA, supports the rarity of GCA in your subcontinent. Possible explanations for this include genetic differences and the fact that GCA is a disease of immunosenescence. India's pre-COVID life expectancy was 70.4 years, which is 11 to 13 years less than in North America and Scandinavia. Comparison of Sharma's report with our North American study shows that on average, the patients in India were 10 years younger, predominantly male, with 20% more headache symptoms and 30% more temporal artery abnormality, but with 10% less jaw claudication. In both groups, the rate of vision loss was 30%. GCA was not a statistically significant predictor for GCA on our multivariable analysis. In North America, 71% of the patients were female, but this may be due to the increased survival of women versus men in Canada and the United States. In India, GCA was 1.6 times more common in men than women, and perhaps this is attributable to smoking. Smoking increases the risk of GCA by an odds of 1.18. Also, bidis have a more deleterious effect on health than cigarettes. There are at least 10 times more male than female smokers in India, which is a much higher male proportion than in North America or Scandinavia. I now talk about tests for GCA, tests that estimate ocular blood flow are adjuncts in the diagnosis of cranial GCA. Imaging or temporal artery biopsy are still required to confirm the diagnosis. Now, due to time limitations, I'll concentrate on the debate between the main imaging modality, Doppler ultrasound, versus biopsy as the confirmatory test for GCA. Now, temporal artery biopsy is the traditional reference standard for diagnosis, but it's invasive and requires several days for the pathology result. The sensitivity of biopsy is around 77%, likely due to skipped lesions. The specificity of the biopsy is practically 100%, and pathology allows for identification of alternative diagnoses. Complications of temporal artery biopsy are usually rare. Now, note that when I refer to Doppler ultrasound, it is of the temporal artery and not orbital color Doppler, which assesses retrobulbar blood flow. The most reliable Doppler ultrasound sign for GCA is a thickened arterial wall due to edema, which appears as a non-compressible hypoechoic halo. The sensitivity of ultrasound varies from 68 to 77% and has the advantage of examination of the entire superficial temporal artery, other scalp vessels, as well as the axillary artery. Ultrasound may cost less than temporal artery biopsy, and serial ultrasound can be performed to determine the response to medication. However, there are 5% false positives. Atherosclerosis, amyloidosis, lymphoma, and infections can have false positive ultrasound halos and result in inappropriate glucocorticoid use and toxicity. The European and British rheumatology societies suggest that experienced ultrasonographers can use ultrasound as the first-line test for GCA rather than biopsy. Schaefer's OMERAC study proposed that an experienced ultrasonographer, though, had performed more than 300 ultrasounds for GCA. The TAB biopsy is frequently cited in support of ultrasound for GCA. Unfortunately, the TAB abstract does not disclose that their temporal artery biopsies were substandard in comparison with ultrasounds. 7% of the temporal artery biopsy attempts did not yield an artery. When arterial specimens were obtained, 43% of the cases were less than the 1 centimeter length suggested by the British Society of Rheumatology to avoid skip lesions. In my opinion, the side effects of unnecessary prolonged glucocorticoids from false positive ultrasound exceeds the disadvantages of temporal artery biopsy. Individual clinicians have to decide, given the gamut of steroid-responsive diseases that mimic GCA, whether a 5% false positive ultrasound rate is acceptable. So please note, I'm not averse to ultrasound or MRI, and I'd be happy to never perform another temporal artery biopsy. Use the modality that your center has available and is most expert at, realizing that you may have to combine pathology and imaging. If you plan to use imaging to diagnose GCA, I think it'd be prudent to correlate your first 50 imaging diagnosed cases with pathology. The use of prediction models should provide higher yields from testing, and perhaps the number of biopsies performed on low-risk subjects. So, in summary, I hope I've been able to keep you awake and nailed home 3 points. GCA is uncommon in India, but is an eminently preventable cause of vision loss. Patients in India are predominantly male, commonly present in their late 60s, a decade younger than their North American counterparts. 2, platelets, ESR, or CRP may be normal in 4 to 10% of patients with GCA in North America. And 3, although North American GCA prediction models may not apply to India, I encourage you to develop and use prediction models for your more common neuro-ophthalmic diseases as an aid to objective risk stratification. So I thank you much for this opportunity to meet with you. I wish you all invincibility in your work against neuro-ophthalmic diseases and COVID, and I leave you with this last slide to think about.
Thank you, Dr. Edsel. It was really a wonderful presentation and your perspective of GCA in India. Dr. Krishna, your questions.
Thank you so much. It was extremely enlightening, and you covered almost all the aspects of GCA, including the different kind of presentations and the difference in the presentations in India and in Indian patients. One particular question I would have is, according to the study with Neurology India, Sharma et al., there was a higher ophthalmic complication rate in Indian eyes. You've explained the male preponderance as well as the fact that perhaps it's younger because of BD smoking. But what do you think would be the higher rate of ophthalmic, issues with patients of GCA in Indian subcontinent?
Oh, the question's sort of a bit cut, but 30% of the patients in our series had vision loss, and this was the same in India and North America. So the question, a lot of this talk was cut out. I'm sorry there, Krishna.
Okay.
Yeah, I couldn't hear the question, so I don't know if I answered it.
No, perfectly all right. So you say that the ophthalmic complications are practically the same in both the...
Oh, correct, yeah, about 30%.
Okay.
30%. Okay. And this may explain why diplopia was not a strong risk factor for binocular diplopia, especially if there's vision loss in one eye.
And is there any specific differences in the treatment of Asian patients with GCA, particularly considering that they are younger than the rest of the world?
I don't think there would be a difference. I have no idea what the response to tocilizumab would be, but I'm sorry, I don't know the answer. The more experienced people in the audience could probably help me out. There is a question here on the chat line about ethnicity, and ethnicity is it's supposed to be a poor substitute for genetics. So I think what we really need is a genetic test, and that would be invaluable because, in Japan and Hong Kong, they're the longest lived patients, but there's not a lot of GCA in Chinese and Japanese patients. And in terms of the next question I see here, do COVID-19 and GCA overlap? I have this last slide. I don't know, I don't want to, it just sort of summarizes things. So, there's a big overlap in the symptoms. Like you can have fever of unknown origin with GCA. Dry cough due to tracheitis is not uncommon with GCA. Fatigue, loss of appetite, anosmia and dysgeusia can also happen, not that common. They get myalgias. They can get chest pain if they're having myocardial infarction. Headaches is a common thing. You can get strokes and diplopia with GCA and with COVID-19. I think the only, the ESR and the CRP are high. Distinguishing features, thrombocytopenia, and I guess your oxygen saturation would be bad and your CT scan would be different. But it's just dumb luck they both respond to steroids. Whether or not it responds to tocilizumab, I don't know. The COVACTA trial came out and it said it wasn't as responsive as they would have liked.
Yeah, yes, Dr. Lee, Andrew Lee, yes.
So Edsel, I was hoping that you would comment on the age thing. So a lot of the patients that we have biopsy proven giant cell in Indian and Asian patients here in Houston, they seem to be younger. So, you know, my superficial review of the Chinese literature on giant cell, they seem to be younger males. And I wondered if you found that same thing in the Indian patients. There's some overlap in our populations with Takayasu arteritis. And as you know, the age limit was removed from Takayasu in the criteria from ACR. And so it's not clear to me, are these like older Takayasus? Are these older, younger giant cells? What are they?
The only comment on the Takayasus is they say the temporal artery biopsy tends not to be as positive. So our whole study was based on biopsy-proven GCA, probably more applicable to cranial giant cell arteritis. So they say with the younger Takayasu patients that you're going to be doing things, I guess, like PET CT, maybe MRI, rather than temporal artery biopsy. So genetics has a huge part to do with it. The only genetic test I know of is HLA, DRAB 104. But I think if you start combining the genetics with a prediction model, you're going to get more powerful results. They say, unfortunately, to just use something like race, like they say the best identification of race is what the patient self-identifies. But race and genetics are very different concepts, apparently. And they say not to try to use race to define genetics.
Well, Neil and I have this conversation all the time about how we learn as much when we travel than as we teach. So I am interested in what Indian giant cell looks like to this panel and to the experts on the Zoom call, because I don't know what it looks like. And I have been humbled many times by cases presented to me. I said, well, this is obviously not X because it doesn't look like our X, but your ducts look different than our ducts.
Yeah, I mean, the classic example is the optic neuritis that's in many areas is anterior versus the Western Hemisphere retrobulbar, et cetera. It really depends. And actually, I learned it from Andy that when you're speaking in a particular area of the world, you better know what's common and what's uncommon in that area.
Actually, in our subcontinent, doing a temporal artery biopsy in these patients, an invasive procedure is it is really a bit tough. You have to rely on your clinical skills as well as the additional ancillary testing rather than the temporal artery biopsy. One question I'd like to ask, what if your temporal artery biopsy is negative in one side, would you go for the other eye temporal artery biopsy? Other side?
I think that's an excellent question. There's some centers like University of Ottawa is a major contributor to the rule. They routinely do bilateral temporal artery biopsies. One of the centers that I trained at, they would submit the first temporal artery biopsy for frozen section. And if the frozen section came back negative, they automatically went to the other side. If my synthesis of the literature is correct, there's about 5% increased yield if you do a bilateral temporal artery biopsy. Another way of thinking about it is you can look at the post-test probabilities. There's some meta-analyses published in the rheumatologic literature about the sensitivity and specificity of temporal artery biopsy. And if you want to think about it from a more just numeric point of view instead of clinical intuition, you could analyze, like tell yourself, this is my post-test probability that I'm willing to accept if the first side comes back negative. And you could analyze it that way. All that being said, a properly performed temporal artery biopsy is usually a pretty straightforward procedure. So if you're thinking cranial GCA and you have the right time window, I think it's a good yield test. That's my opinion, but like Dr. Miller, if it wasn't for him, I wouldn't have anything to talk to you about. So he's a wealth of knowledge with this. I'd be interested to see what he says.
Well, I would just say that as Edsel says, and he's really the expert, he's much too kind. The issue about bilateral biopsies ranges from, I think Wills did a study that showed only a 1% discordance. Our study was about 11%. My philosophy, if any of you remember the movie years ago with Clint Eastwood, Dirty Harry, where he says, you know, are you willing to take the chance that there's not one more bullet in the gun, basically? I just don't want to take a chance that I'm going to miss GCA. And in the United States, it's very dangerous to treat with steroids an elderly person without some sort of histologic diagnosis. So I've done hundreds of temporal artery biopsies. And my philosophy, and the same thing was true at the Mayo Clinic, I know, is I would always consent the patient for a bilateral biopsy. I would do the biopsy on the side of the visual loss, but I would prep the patient for a bilateral. And as you said, Edsel, send it for a frozen section. And I recognize that's more expensive, but we would send it for a frozen section. Or if I looked at it and it was obviously lumpy and bumpy and hyperemic and that sort of thing, I would sort of say, okay, fine, we'll just do the one side. But if it was a question, I would just go to the other side, because it's such a disastrous thing if you miss the diagnosis. And we all talk about it being a clinical diagnosis, but in the end, I like to see the slide that shows the disruption of the hyaloid and the giant cells, and et cetera.
Yes, Dr. Lee.
I would just say also that a lot of the false negatives that we have received from outside temporal artery biopsies, we go get the block, and our pathologist, Patty Chevis-Barrios, can detect things that Neil just said. Even though there was no active lymphocytic infiltrate, there was no giant cell, they see the disruption of the internal elastic lamina and the CD68 positive histiocytes at the internal elastic lamina, and those biopsies get reread as healed/treated temporal arteritis, even though they were read on the outside as normal.
Well, as you know, back in the 80s, we did a study in which we looked at this sort of chronic process or old healed arteritis. And one of the key features was that we found was that your pathologist has to understand what the criteria are, because there was discordance between the two pathologists who read Dick Green and I've forgotten the general pathologist, but there was definitely discordance. But once they got together and agreed on what the criteria were and then reassessed everything, then it was really concordant. So I think it is, as Andy says, it's crucial to have a pathologist who understands what the readings are and what the criteria are for healed arteritis as well as active arteritis.
Yes, Ambika. Yeah, please.
I have a question to the panel. How frequently you have made a diagnosis of posterior ischemic optic neuropathy due to arthritic etiology?
I think it's a diagnosis of exclusion. Only when you have ruled out every other possible cause, it's only last resort, I think.
The reason is because, as you rightly said, in India, we see in a lesser age group, this sort of acute to subacute vision drop. we had a lady in her 60s who was being diagnosed as optic neuritis outside, and she was referred to us with for the second line of treatment because the local doctor has put her on steroids, and by the time she reached us, she started developing vision drop in the fellow eye. So the question was, in her 60s and loss of pain, she had a signal along the optic nerve and she was diagnosed as an optic neuritis. Well, that was quite tricky for us to make a diagnosis of giant cell arteritis at that moment, because when I discussed with the patient, she's vaguely accepted for the pain. I mean, like the jaw pain was in the beginning. So that was a very difficult situation for us in the 60s to make a diagnosis of a giant cell arteritis when the fellow eye is involved and one eye has not recovered. That's again one of the diagnostic challenges what we had. Yes, Andy?
Before I make the diagnosis of PION, I always do a fluorescein angiogram because we can see the choroidal perfusion deficit. They usually come to me, as your case did, with OCT that is normal because there's nothing to see in the fundus. But because OCT has supplanted fluorescein angiogram in most practices, they don't think to do the fluorescein anymore. They just go straight to OCT. And when they come to me with that normal OCT, they get this retrobulbar optic neuritis all the time. And I can't tell you how many times I've had to tell retina, look, it's retina. You just sent me a retina case, except it was choroid. So what we call PION, I suspect a lot of those are actually choroidal level ischemia as the cause of the vision loss and not really a retrobulbar optic neuropathy from ischemia.
Andy, if you have, or any of the panel, if you have a case of acute retrobulbar optic neuropathy, do you, in an older individual, are you more concerned, or do you get laboratory studies first, or do you send them for an imaging study to make sure it's not a compressive lesion, even though it's an acute loss of vision from a retrobulbar process?
So I admit those people, and we do everything you just said contemporaneous so that I don't let them leave. So I really hate that diagnosis of PION. And so I really don't let PION leave, because what could it possibly be that's good? They're an elderly patient with a retrobulbar optic neuropathy. There's nothing good on that list. I mean, you might end up with non-arteritic PION, but boy, you better work that up. And so I have this list of diagnoses that a generalist should never make. That's one of them. PION, a general ophthalmologist should never, ever make that diagnosis.
Well, even
it's
we
like
would be
chronic optic neuritis.
Right,
Yeah,
exactly. Comment? Yeah. Can I?
Yeah.
Can you hear me?
Yeah.
Yeah. Yes, you can. No, you can't.
Yes. Please proceed.
This is just to add to what's already been said. But when I trained, my mentor taught me that when you find yourself writing at the bottom of the page, impression, posterior ischemic optic neuropathy, just assume that you're wrong. You just got it wrong. So I was pretty much taught that it didn't exist. What we know nowadays is, in fact, it does exist. There's really two settings, and one is giant cell. The other is catastrophic, acute hypotension, usually with anemia. So in that perioperative setting. So those are the two. And if you're in one of those settings, yeah, it really does happen, and you think about it and look for it. But otherwise, just assume you missed something, usually at the orbital apex, or you missed something in the retina or the choroid. But as far as which test to get, I would say agree contemporaneous. You wouldn't want to have to pick. No reason to have to pick SED rate, CRP, or scan. Just do them both as quickly as you can.
There is one question from in the webinar. Can you describe the role of OCTA angiography in GCA?
That was the answer. There you go.
Is the field on OCT angiography wide enough that you're happy with it, Andy, or do you still go back to the fluorescein?
Okay.
Fluorescein. Fluorescein can show perfusion. OCTA, not so much.
Ambika, do you have any experience in OCTA in
No,
arthritis?
No, we don't ask for OCTA. I think by the time we are done with temporal artery biopsy, the patient is out for the steroids. We don't move to this at all, I suppose.
Okay, fine. Okay, I think any other questions, Dr. Krishna?
If we could go back to the earlier presentation, sorry, I have a question to Dr. Marian's case. Maybe I can put it to the panel. Like if you have a patient with a neuritis who has recovered the vision back to maybe 6/9 plus, but the visual fields has not recovered, would you consider that as a criteria for the next line of treatment?
It depends. If it's only the visual field, but you see that the patient didn't recover very well, and you have other clues at the imaging, like you see the differentiation within some in chiasm, for example, that is like a landmark to ask about for another antibodies. Maybe for me, when the patient don't recover, I try to ask always for the antibodies. Unless a good vision but bad visual field, for me is not a good recovery. So I ask for a medulla MRI and maybe aquaporin 4, and if I can, both aquaporin 4 and MOG antibodies.
Maybe if the seromarkers were negative to begin with, Dr. Miller?
Yeah, I think it depends on the case, quite honestly. I don't know that I can give you a general philosophy. I've never understood how acuity can improve and visual field not, or the reverse. I mean, there's got to be some improvement in the visual field if the visual acuity is improving. But in general, I have to say, and John Chen is on, so he's the expert. But I have to say that in general, if acuity improves significantly, I don't consider the issue of antibodies. But remember, I'm getting MOG and NMO antibodies on every patient with optic neuritis because I'm seeing them in the acute phase and I don't know what's going to happen. And I've got to get my Plex team prepared if nothing improves in a week or so. John, what do you think?
No, I agree. I think, with these acute settings, we typically start with IV steroids. Especially if the vision loss is severe, we're going to get those antibodies. But as Neil was saying, the antibodies are going to take 2 weeks to come back. So we're kind of stuck with this kind of dilemma. And so, if it's that severe, there's no light perception, and we've given them 5 days of steroids and they're still sitting at, light perception, and we don't know the antibody status. It's a tough call, but, some would go to Plex if they don't recover in that 1 to 2 week period. But the frustrating part is the optic neuritis treatment trial shows that even the severe vision loss, a lot of these patients are going to recover. It's a really tough dilemma now that we've got these biomarkers, but they take time to come back. Obviously, if they're sitting with an aquaporin 4 positive test, and we know they're NMO positive and they have a relapse, their light perception, no brainer. We treat them with Plex right off the bat. But these first comers that are that severe, those are tough. They really are.
Hey, John, the other thing, Mariana quoted several papers that showed that cell-based antibodies for NMO were about 90% sensitive. But I thought I recalled you, and maybe I'm getting it mixed up, I thought I recalled you saying they were about 67% sensitive. So which is it if you're using a cell-based antibody?
Is this for aquaporin 4 for NMO?
Yeah.
I'm assuming.
Excuse me, we are running short of time. We have to move on to the next session. Okay. I think if we have time permits, we can have it at the end of the discussion. Thank you all the speakers for a wonderful case presentation and all the panel with me in this session. We move on to the next session. Over to Dr. Satya.
Yeah, thank you, Padmavati. So now we move on to the next session, and I would like to introduce the first speaker in our session. And That is Dr. Neil Miller. I hope the slide is seen. Is the slide visible?
Not visible
No,
yet.
no, it is not visible.
Okay. I'll share the slide now. Now? Is it visible now?
Yep.
Yep.
Okay. So here we go. Dr. Neil Miller's introduction could be an entire presentation on its own. He's a professor of ophthalmology, neurology, and neurosurgery, and also the Frank Walsh Professor of Neuro-Ophthalmology at the Johns Hopkins Medical Institutions in Maryland, USA. He has authored or co-authored over 540 articles in 93 chapters and 13 books, including the 4th edition of Walsh and Hoyt's Clinical Neuro-Ophthalmology. He has co-edited the 5th and 6th editions of the same textbook. He has also authored or co-authored 3 editions of an abbreviated version of the textbook, Walsh and Hoyt's Clinical Neuro-Ophthalmology, The Essentials. And the 4th edition, written by co-authors Dr. Prem Subramaniam and Dr. Vivek Patel, has just been published. Dr. Miller has also co-authored 2 editions of the Neuro-Ophthalmology Survival Guide, and he has 62 named lectures given all around the world. And many of Dr. Miller's previous fellows and residents hold faculty positions at major institutions throughout the US and around the world, and some of them are with us today. So let me hand over the reins to Dr. Miller now for his cases. Thank you.
Well, thank you, Satya. It's a pleasure to be a participant in this symposium. And I want to thank Satya and Shika for doing, and their colleagues for doing all this work. It's phenomenal. I've been asked to give 2 cases, so I'll try to do them relatively quickly. Can you see my slide?
Not yet.
Okay. How about now?
Yeah, that's good.
Okay, sorry. So the first case I've titled Optic Neuritis Papilledema, in any event. This is a 70-year-old woman who presented to us with bilateral optic disc swelling. She had a past medical history of lupus, and she had a 3-month history of seeing phosphines and a 10-pound weight loss, not by choice. She was on Cellcept. When we saw her, her acuity was fine. Her blind spots were enlarged. She had no relative afferent defect. Her eye movements were full. She had had a normal MRI. She had no hydrocephalus, no mass lesions. A lumbar puncture showed normal opening pressure, but the protein was elevated. The glucose was normal, and she had no cells. She was treated with IV Solumedrol without any change and referred to us. When we saw her, her acuity was pretty normal in both eyes. Color vision was pretty normal as well. The fields only showed enlargement of the blind spots. I thought she had a trace left relative afferent defect, and the fundus showed obvious bilateral optic disc swelling. So the question then becomes, what next? And in the interest of time, I'll go ahead, and we did repeat MRI. And I would just ask, I guess, Val, what do you think about this MRI? Are you there, Valerie?
Yeah, I am. I was muted. I was oddly muted. Sorry, I'm not usually muted. So this is a non-contrast MRI. I think what I look for nowadays first, what catches my eye is the posterior globe, whether there's any flattening, because I found that to be very sensitive and almost beyond reproach. As far as, is the nerve sheath, the subarachnoid space around the nerve expanded, yes or no? And if the back of the globe is flattened at all, then the answer is yes, that's not normal. So in this case, the right eye is you see more CSF around the nerve just behind the globe. And maybe that's abnormal, but maybe not. I would hold off on calling that.
What do you think about the enhancement? We're seeing enhancement, the better the imaging, the more common it is to see optic nerve sheath enhancement. This is not enhancement, this is hyperintensity, I suppose. Right. But yeah. What do you think about this picture?
Right, so when I had seen that, the question that you had posed about that, and so my image of what that was going to look like was different because it has to do with actual enhancement of the nerve sheath. So I don't know if I've asked a couple of colleagues if that's something they have seen. The question is, with higher intensity, better imaging nowadays, are we seeing more prominent nerve sheaths? And is that a problem? Is that hard to distinguish from pathologic changes in the nerve sheath? I know I've come and the response I got was, I don't think so. It didn't ring a bell for people. But what I'm aware of is that occasionally I would see a scan from another institution and notice the nerve sheath, and it seemed prominent. Okay, so this is a problem when it's bilateral and symmetric. And find myself wondering if maybe that's normal for that scanner. So I'm aware of inter-scan variability in terms of how much you see it. I think probably the best tips for deciding, is it really abnormal or not? One would be, is it symmetric, both sides? Second would be, is it smooth? And so again, we're talking about enhancement, not the specific picture shown here. But is it smooth and regular, or are there areas that are thicker and more enhancing than others? And then of course the clinical piece.
And I think that was exactly what the issue was, both with the enhancement. I didn't add that because this was much more impressive. But what our neuroradiologist pointed out was that this is not a nice smooth area, but there appear to be little lumps and bumps around there. And so they were concerned about
Neil?
It. Yeah.
So can you go back to that picture? So that's kind of the same stuff we see with the flare suppression artifact, where you do the flare and it doesn't suppress the CSF, and that makes me feel like maybe there's something in there that's causing it to look like that. So, you know, when you have the fluid in the sheath, it's normally like a river.
Right along.
This is kind of like not a good river. It's like a kind of a crummy river. And I think I agree with what Val said. When I don't see the flattening of the globe and the empty cella, but I see this, I'm like, wait a minute, we need the post-contrast fat suppressed image now.
Right, and actually I use the arrow over here, but if you look over on the right, it was even more impressive in some respects. You know, one of the things I'd point out is you see this globule, but the sheath normally dilates as it approaches the globe. So you have to be careful of over calling that as well.
Right, exactly why I use the flattening of the globe, because it's a normal finding. That doesn't help you to say, oh, there's more CSF right behind the globe. Yeah, there is. But if
I agree completely.
I think you have logs in your river.
Can I just say, I'm not in your session, and I'm not on even in this day.
Go for it.
But you're not muted.
But to show a scan with only one view, when MRI allows you to have a three-dimensional view, is unfair to put people on the spot about that.
I agree completely, Mark. And if I had 30 minutes, I would have shown you every single.
I'm just saying is that you're asking Valerie to put too many decibels on a slide rule. We have too many views that we can look at, including the intracranial views, to correlate with anything. So any one finding by itself, I wouldn't lean on looking at an MRI. And that's the message for the audience, is that you got to look at all of it.
I agree 100%. In any event, as Andy sort of said, we felt there were some logs in the pathway of the CSF. And when we think in terms of that, we think something badness, I think, as Andy likes to say. So we did a CT chest, pelvis, and spine. They were negative. So now what do you do?
A diagnostic procedure was performed.
Well,
Right, so
yes, it was. We repeated the lumbar puncture and the opening pressure was still normal. The protein was definitely elevated. Glucose is normal. There were no cells and cytopathology was negative.
You still need
Now
to do the
what?
diagnostic procedure that needed to be performed.
We did a third lumbar puncture and now we saw these lymphoblasts, CD20 positive, and this was a B-cell lymphoma. And one of the issues that comes up is how far do you go after this? You know, I was taught that you do 3 lumbar punctures, but we've had lymphomas that we required 5 or 6, or if there was something that we could see intracranially, and there wasn't in this case, we would go to a biopsy. But our cytopathologists say, keep giving us fluid. I don't know what the panel thinks.
Well, I also was trained to expect at least 3 LPs for this purpose, for identifying malignant cells. But I looked into this when all else fails, read the instructions. So I looked at the literature and found a paper that interested me from 2001 in cancer. It's actually from Brown University, where they looked at data for this. And surprisingly to me, what they found was the second LP definitely increased your yield significantly. Third LP, not really. It just didn't really add, which is not intuitively apparent why. They looked at similar studies for, and this was not just, it was their own data plus review of the literature. They also looked at pleural fluid and found the same thing. There was this drastic fall off after the 2 LPs, which I don't really understand. So same thing for blood cultures, why we routinely get 3 blood cultures. Now, maybe for blood cultures, maybe it's different because there's bacteremia in waves. Maybe you caught it during one wave and a few minutes later it wasn't there. So that maybe that makes more sense to simply repeat it. So so that's what I found as far as whether it's worth doing the third LP. I still feel like I was trained to do that. But the other thing I found when I looked into this is nowadays, apparently, we can do a lot better. So this was not in my own armamentarium, but nowadays there's multiple ways to pin this down, to look for these lymphoma cells. So looking for, using PCR to look for monoclonality in the CSF. You don't even, it's not a question of looking at the cells. So it's a very, very sensitive, very refined test. Looking for microRNAs is another way that's been looked at. Cytokine analysis, interleukin-10 is overexpressed in these tumors. So these are usually send-out tests. They're not done in your own lab, and there's places that do this for you. So it's not just only at center, because I checked with an oncology friend of mine to see, is this just for research purposes? And he said, no, you can get these, and they're sent out. So it's not institutional dependent. So that's what I learned for doing this. And I also, another thing, just one more comment about the idea of how many CSF samples. That same paper that looked at the utility of a third or fourth or fifth sample, it looked at other potential sources of inadequacy, of false negative results. Why might that be? So one of them was not doing enough LPs, so doing only 1, yeah, that would be a lower yield. But another one was using a small CSF sample. And I think that happens a lot, especially our neurologists nowadays just get a gazillion tests on the CSF. It just doesn't even, they don't all make sense for whether, does that really make sense? Could this patient have those diseases? But they just run them all, and it takes CSF to do that. So at first tap, you're using up a bunch of the CSF on this kind of shotgun approach, and not enough for a cytology and flow cytometry study. Another, this is one we've encountered, is possible delay in processing the fluid. So my main words of wisdom on the subject to residents and fellows was, don't do this tap on a Friday. That's all. Just, you know, and we were tempted, we often do spinal taps on Fridays for people in hopes of not having them miss work if they develop a post-LP syndrome. So Friday's a good day to do taps, not if you're sending flow cytometry, because it'll sit on a shelf in a lab and it won't get processed till Monday and those cells go away. So that's not true for those PCR, these fancy new ones, but it's definitely true for looking at cells. And so I was kind of relieved to discover it's not just my own institution that has that shelf where things sit. And then another was, the final one was some variability in terms of where the sample was taken from. So whether it's usually routinely it would be a lumbar puncture, but if in some cases it helped to get closer to the source of the problem, so a ventricular tap, not so much cervical. So that was another. So these are all variables. It's beyond just taps were done, and so again, and it certainly will depend on what the nature of what you're looking for. So it's not a simple question. But I totally support the idea. Well, you already did it twice. Most of the time in medicine, why do a test if you already did it? Yeah, I mean, it always seemed mindless to me. You know, you have an abnormal SED rate. What do you want to do? Well, let's repeat the SED rate. Why? You just did the SED rate. You know, you're hoping for a different answer. And then if you get a different answer, you're going to vote on it. Then you're going to need best of 3 to decide.
Well, one of the keys to this, I thought, was the elevated protein, because we felt that there was something going on there and we just had to find it. Andy?
I was just going to add, once you start that steroid thing on there, it kind of makes it less likely to be positive, I think, with lymphoma. I actually thought you were going to say do a PET scan, and probably we would have done a sheath fenestration and got a tissue here if it was us. But I'm amazed and impressed that you got it with number 3, because as Val said, when I try and convince my neurologist to do number 3, they're like, take a hike, Lee. You're just trying not to do a sheath biopsy when you need to do it.
We had one that took 5 LPs, and because there was a lesion in the brain, but it was in an eloquent area, and the neurosurgeons kept saying, we're good, but we really don't want to biopsy that area, so let's keep getting LPs. But there we had something abnormal. Here it was just in the sheath. We found no other site in this case, and so we treated the patient with rituximab and whole brain radiation. And unfortunately, he passed away. And I would just comment that this is an unusual thing, and it was particularly unusual because we looked carefully at the MRI. This is not from that case, but this is, you know, when you see something like this, where all of the sulci are enhancing, then you have a pretty good idea that there's something diffuse around there. But this can be difficult to diagnose. And as we talked about, it may require multiple LPs, although I was not aware of that cancer article. So that's really fascinating. I doubt that that'll change our minds. And I agree with Andy about PET scanning. We never got to that because of the LP, but we would have done that.
I was just going to add also, when I see the elevated protein, we normally image the spine too. So sometimes the leptomeningeal enhancement can be seen in the spine or the cauda equina or something. And that helps us convince people, hey, this person has cancer.
Right. That issue of getting a CT PET scan is sort of part of the broader issue of when you're dealing with an abnormality in a place that's hard to get to or hard to biopsy or has morbidity associated with the biopsy. How hard do you look? I mean, certainly finding it someplace else would be great. And it can take a really long time. We have issues often with insurance approving a scan. If you don't know something, they'll tell it, this person has cancer. Well, I don't know, that's what we're looking for. We'll come back when they have it. And then we'll pay for this test. So you spend all of that time, working to get some other site, some other thing. And then after all of that, you end up going back often and just biopsying the thing that maybe you should have biopsied on day 1. So I think it's a judgment call for how to do a workup.
Yeah, we recently had a case just like that in which the insurance company, we wanted to do a PET scan because of a recurrent steroid sensitive optic neuropathy. And the insurance company said, we said, well, we're looking for possible lymphoma, something like that. And the insurance company said, well, if you find it somewhere else, let us know and we'll let you do the PET scan. It was ridiculous.
Exactly.
The second case is not a diagnostic issue, but I thought I'd bring it up just to find out what the panel thought. This is the objectives, or this rare etiology of NAION, and the underlying pathophysiology. We'll get the explanation from our panel. But this was a 70-year-old man who presented to the Neuro-Ophthalmology clinic because of acute onset of visual loss in his right eye 2 months earlier. And he was a trekker, and he had been up to Kathmandu and then up to Lukla and then down a little bit, but then up further and further in his trekking, and eventually up to 12,500 feet. And at that time, he actually was doing okay, but he then started to come down. And when he reached 10,000 feet, he awoke, and his vision, he said, was doing strange things, but he didn't think too much about it. Went back up to the 12.5, then back down to Lukla, and back down further. And eventually, and this is in my way, so I have to move your thing. In any event, he eventually came down to about 4,500 feet. And a few days later, he reported a blind coming over his right eye. He underwent an eye exam and was told that he had a swollen optic nerve. Otherwise, he was perfectly fine, and specifically no evidence or no symptoms of GCA. He did have hyperlipidemia. He'd had a stage 1B melanoma from his left forehead that had been excised some years earlier, but otherwise was fine. No symptoms or diagnosis of sleep apnea. He was a non-smoker, and he was on medication just for hyperlipidemia. When we saw him, he had counting fingers vision in his right eye with a marked right afferent defect. He had central scotoma, and he had a disc that was moderately swollen with flame-shaped hemorrhages and a little bit of subretinal fluid in the macula. And here you can see on your left, you can see the increase in the nerve fiber layer thickness on the right compared with the left. Here he had already developed significant ganglion cell atrophy. His field in the left eye was pretty good. So we diagnosed NAION in this guy. We did an additional workup. He had some MRI findings, just some punctate changes consistent with either something he'd had before, or maybe it was just chronic. He did have a sleep study that showed mild sleep apnea. And so the issue I wanted to bring up was this relationship to the high altitude. There have been a number of articles that have discussed this issue. And it was interesting. I thought it was neat, Stefan's presentation, because there was a case that we saw that a 12-year-old boy who had optic disc drusen, who developed NAION after a pretty high hike. So all I know is that there was a study some years ago that described retinopathy in a bunch of soldiers who were stationed up at 10,000 feet, but 4 of them actually had disc swelling and engorgement of the retinal veins, and it was unclear to me if these people had a central retinal vein occlusion or if this was some sort of a diffuse retinopathy. But it's really the high altitude's effect on retina has been much more discussed than disc swelling. And this is just, I won't bore you with this, but there have actually been grading of the severity of high altitude retinopathy over the years. In terms of optic disc swelling, this was one of the papers from back in 2008. They had 27 patients, and 16 of them, so over half, had some sort of optic disc edema. And they correlated that with oxygen saturation being lower, younger age, which I thought was really interesting. And there's apparently some sort of cerebral acute mountain sickness score that they looked at. And there was a correlation between the occurrence and severity of that. 79% of the patients had optic disc swelling after only one night of high altitude in this other case. So I guess the issue is the pathophysiology of this. Is it related to blood viscosity? I have no idea. Some of these people do have an increased hematocrit after being at high altitude. Is it related to hypoxia? So that there's been this HACE, high altitude cerebral edema. I know when we used to go to high altitude for the NANOS meetings, a lot of people took Diamox, and I wonder if there's a certain predisposition to cerebral edema and optic disc edema or ischemic optic neuropathy at high altitude. In any event, so that's the issue. I'd really be interested, especially since we've got a bunch of India colleagues, if you guys see this type of phenomenon, either the retinopathy or the optic neuropathy, commonly or uncommonly in the area, and what you think.
Neil, can you go back to the OCT? Did you think anything was in that retinal macular scan OCT? In the right eye? See that? It's real tiny for me, but I don't know. On the
you mean
under the fovea?
Yeah, there was a little
retinal ganglion cell. See that?
I thought it was just subretinal fluid rather than any sort of ganglion cell abnormality, but there was definitely subretinal fluid.
There's some weird subretinal, sub-RPE thing there. So I think that's a clue that something other than regular NAION happened here.
I feel like with NAION, if there's a lot of disc edema, you'll get that fluid track underneath there when there's that significant disc edema.
Yeah, it's
we don't
interesting.
see it clinically, but on OCT, we'll pick it up from time to time.
Exactly. And it's interesting that in our model of ischemic optic neuropathy and also in Joyce-Liao's, we see not only subretinal fluid, we see some intraretinal cystic changes as well.
But John, don't you think those AION case fluids, you can see it tracking from the disc? That looked like it was just like by itself.
Yeah, I bet, Neil, when was that OCT taken? Because I bet you could, I'm guessing, again, it's speculative that there is probably, you could see it tracking and we're catching it maybe later when something's resolved and there's still that puddle of fluid left.
Yeah, this was months later.
The pathophysiology of this high altitude retinopathy is basically dysregulation of the normal autoregulation of the blood vessels. Because of the chronic hypoxia, it's said that the more blood flows to the eye and the brain, and the eyes where the blood vessels could constrict, we don't see any retinopathy or optic neuropathy. But where this normal vasospasm does not occur, the blood flows out, there's tortuosity, and that's something that has been suggested. And I've never seen any case. I don't know about Ambika, I have not seen, but it's been reported in the Indian Journal. One patient who had gone to the Siachen Glacier, and then when he came back, just as you've reported, and the pathophysiology closely related to the retinopathy, the high altitude retinopathy. So the NAION itself, the pathophysiology is some kind of dysregulation, especially we ask patients history of hypertension for this reason. If they've been taking antihypertensives at bedtime, that kind of correlation, something to do with that here. Yes, Sandy, you wanted to say something?
I should, before he does, I should ask Stefan if you think that patients with optic disc drusen should be told not to go up to high altitude.
I think it is very interesting, and we would very much like to do hypoxia studies on these patients, on the drusen patients, and to compare them with the glaucoma patients, for example, and see what happens. But we haven't. I was actually looking for some reports of patients with disc drusen who went up high and what happened, and then now you just gave me this one case report. So it's very interesting, and we're definitely going to look further into this. We have some challenges in the ethical aspects of doing hypoxia studies on patients, but it's definitely very interesting.
Cool.
Not only optic nerve disc drusen, the small disc patients who are who have disc at risk. If a patient has developed ischemic optic neuropathy in one eye, wouldn't we like to tell him avoid high altitudes?
Yeah, probably is the wisest thing to do. Yeah.
Well, not just disc drusen, but we have plenty of patients that want to go to Colorado. Prem is on, and they have had NAION, not disc drusen. I mean, they literally have already had NAION, and they're like, "Can I go to Colorado?" I'm like, "The Mile High place? That's where you want to go?" So I'd be interested to hear what Prem or maybe the others have to say about that. But I just wanted to mention, when you climb Everest, the climb is like this. You go to the camp, then you go base camp, then you go to first camp, then you go back to base camp, then you go to second camp, then you go back to base camp. So it's like a up and down like this. There's none of this, what this dude did, the dumbass way of going.
Well, no, but he did come up and down. But the thing is, the base camp isn't all that much lower, as I understand it, than where you're going up.
It takes them a month to make the ascent because they have to live there for a while, and then they go, and then they come back, and then they go, and they come back. There's no "we're gonna go today" thing. It's not like that.
But Andy, would that make any difference? I don't. It's all about the reaction of the eye. It's kind of how the body is accommodating the thing. That itself is causing the problem. Even if you go in one go, or if you acclimatize and go slowly, I think the eyes which are at risk going to behave. I'm going to land up with this problem. I don't know.
So there's a comment from Varshni
on your session. So
Varshni,
I would say,
good evening,
if I may, to answer Andy, just
so I practice in Delhi, and I just wanted to mention that I've seen one of these patients. Now, Delhi has a direct flight, a short flight to Ladakh, to the capital of Ladakh, which is called Leh. So this is extremely high altitude. This is about 11,000 feet above sea level. And it's become almost a weekend excursion for people from Delhi to go. So I've had a couple of patients who have taken that short flight to Leh and done a weekend tour of Leh and come back to Delhi, and who have developed an AION immediately during the process. So I believe it has something to do with the time taken for acclimatization. Because before this flight started, it was a much more longer journey. You had to go to Kashmir, and then you had to drive up to Ladakh and then stay in Leh maybe for 24 hours before you traveled around. So it was about a 2-week trip, which because of this flight has been shortened to a few hours.
Huh. Neat. Prem, you had commented, at least on the chat, that you don't see much of that in Colorado.
it's not as though we see a rash of it. I suspect that it is a multifactorial thing, that maybe if you have disc drusen, if you have disc at risk, sure, you want to be a little extra careful. The 12-year-old that you mentioned was extremely dehydrated, in addition to having come from Baltimore to Colorado and then hiked at 12,000 feet. So it's all these things together. And I think, Stefan and other members of this group have observed that in patients with disc drusen, there's probably something else that tips them over the edge in certain cases. My patients would laugh at me and walk out of the room here in Colorado if I said, don't go to the mountains because you have disc at risk or disc drusen.
Fair enough.
Okay, so Neil, could we move on now?
Yep.
Yeah, okay, so now I'd like to introduce the next panelist, Dr. Mahesh Kumar, who's a senior consultant ophthalmology in the Department of Neuro-Ophthalmology at Arvind Eye Hospital, Madurai. India. He did his post-graduation in ophthalmology at Arvind Eye Hospital, Madurai, and he trained under Dr. Nachiyar, who's the pioneer of neuro-ophthalmology in India. For past 18 years, he's been a faculty and instructor in various national and international conferences, and he has conducted several neuro-ophthalmic conferences in the parent institute. Over to you, Mahesh.
Thank you, Satya. I'm happy to introduce Dr. John Chen.
All right.
So, John is an associate professor in the Department of Ophthalmology and Neurology at the Mayo Clinic in Rochester. He has been a practicing neuro-ophthalmologist at the Mayo Clinic since 2014, and he's an associate professor in the departments of ophthalmology and neurology. He is heavily associated with teaching. He is the associate residency program director as well as the neuro-ophthalmology fellowship director. And he has held various posts in the North American Neuro-Ophthalmology Society as well as the American Academy of Ophthalmology, and has over 100 peer-reviewed publications. And his main research interests include ophthalmic imaging, idiopathic intracranial hypertension, and optic neuritis. Over to you, John, for your presentation.
Great. Thank you so much for that introduction, and thank you for organizing this wonderful meeting. It's great to see so many colleagues and wonderful people here. Let me start my slideshow. So the title of my talk is Optic Neuritis. It's not just multiple sclerosis anymore. And this is not a crazy zebra. It's a pretty straightforward case, but I just like to use it to introduce and discuss, how we approach optic neuritis now that we have these biomarkers for things like NMO and MOG-associated disorder. So the case is a 48-year-old male who presented with eye pain for 3 days and progressive vision loss over 2 days in both eyes. No past medical history, no other neurologic symptoms. And my ophthalmology resident actually saw this patient in the ER because of this drop in vision. And when he looked in, this is what he saw on the fundus exam. And he called me that night and said, Dr. Chen, I've got a patient with bilateral papilledema. Let's get an MRI, MRV, spinal tap. But the vision was count fingers in both eyes. And if you talk to the patient some more, it really wasn't headaches. It really was pain in his eyes, worse with eye movements. And yes, papilledema from fulminant race pressure can cause count fingers vision, but this is more of a grade 3 type disc edema, so we wouldn't expect, count fingers over 2 days. So really, we redirected, we got the MRI, and we kind of found what we thought we'd see, which is bilateral optic nerve enhancement. But what's interesting about the pattern is it's not only enhancement of the nerve in just a small retrobulbar piece, it really extends down the entire optic nerve length here. And you can see the enhancement spills over to involve the sheath and the peribulbar fat. And so I thought I would just turn it over to the panel. We've got this patient here. What are your thoughts in terms of the differential diagnosis? How would you approach this patient?
John, considering the long segment involvement, could we consider NMO or a MOG antibody, MOG-related optic neuritis? How do we differentiate the two, if so?
Absolutely. I think that, this is just a long differential diagnosis of optic neuritis. And, with this presentation, there's a couple of things that would make you lean one way or the other way. I'd say this degree of disc edema, we don't typically see in multiple sclerosis. We don't typically see that with NMO. We do often see it with MOG-associated disorder. And then this long segment enhancement, we see in NMO and MOG. But then that perineural enhancement, that's also leaning you more potentially toward MOG. And then all of these other things are actually on the differential. Could this be sarcoid? Certainly. Could it be some infection? Certainly. But, there's some pathognomonic findings here that would make you think more toward one entity. But I would just go through, actually on the top of, I wouldn't think MS and NMO, but the others are fair game. So the patient was diagnosed with atypical optic neuritis. And, this is clearly atypical because bilateral is rare in adults. There's a lot of disc edema. It's a male. So it falls into the category of atypical optic neuritis. The initial workup was negative. The CSF showed normal cells and protein. There were no oligoclonal bands. The animal antibody was negative, and the infectious and inflammatory workup was negative. And this patient was seen in 2016 before we actually had commercially available assays for the MOG antibody. So here we just diagnosed him with atypical optic neuritis, treat him with IV steroids for 5 days, and the patient had almost immediate recovery of vision. So within the second or third day of IV steroids, he went from count fingers essentially to 20/20. And that's also atypical for your normal MS optic neuritis, where if you don't treat, they'll get better in 4 to 6 weeks. If you do treat, they get better in 3 weeks. But this was, on day 2 or 3 days of IV steroids, he's back to 20/20. But when he came off the steroids, he had these multiple relapses when he was off the steroids. And clinically, he was diagnosed with chronic relapsing inflammatory optic neuropathy, or CRION. This is essentially a steroid responsive, but steroid dependent optic neuritis. And that's where the CRION comes in, because it's dependent on the steroids. And the patient was ultimately stabilized on azathioprine 100 milligrams twice a day. And not surprisingly, when we had the commercial available assays for MOG, it was positive for 1 in 100. And I just thought I would just take about a few minutes to talk about MOG associated disorder, because it's essentially the newest kid on the block. We've known about MS for centuries, and we've known about NMO had a biomarker for that for 20 years. Now we've got MOG, which stands for myelin oligodendrocyte glycoprotein. And it's a transmembrane protein found on the surface of oligodendrocytes and myelin. And we now have antibodies against MOG, a cell-based assay that's pretty specific for MOG-associated disorder, which is a distinct entity from MS and NMO. And so if we think about MOG as a disorder, the most common way it presents is optic neuritis. And that's why, as ophthalmologists, we need to know about this condition, because it potentially alters the way we manage the patient as well. And so some keys toward MOG optic neuritis is that 50% are bilateral, 50% are going to be recurrent. That disc edema is often helpful. So where MS optic neuritis, only a third have disc edema. 80% of MOG-associated disorder is going to have disc edema. And sometimes it can be prominent, like this case here, where you can have some peripapillary hemorrhages. Not all the time, but certainly if that's there, make you think potentially this is MOG. That perineural enhancement that this index case had is also a strong indicator. 50% have that, where you have not only optic nerve enhancement, but you have enhancement of the sheath and some of the peribulbar fat. If you have that, that's a fairly specific sign of MOG-associated disorder, which is present in 50% of cases. Patients present with severe vision loss at onset, but the good part is patients tend to recover quite well. Only about 6% end up 2200 or worse, and that's compared to NMO, where a third of patients end up with that poor outcome. So they present just as bad as NMO, count fingers vision, light perception vision, but they often respond to steroids. They tend to recover, so the outcomes are much better. Outside of the optic nerve, another common way it can present is transverse myelitis. And so if you have optic neuritis and transverse myelitis, you can actually meet the 2015 diagnostic criteria for seronegative NMO spectrum disorder. And these criteria in 2015 are our most current ones, but at that time we didn't have a good appreciation of MOG. And that's why you can sometimes, and MOG actually explains a third of seronegative NMO spectrum disorder. And so anytime you've got a patient who's got optic neuritis, transverse myelitis, they're negative for aquaporin 4, you definitely want to dip in and check for MOG, because that's going to explain a third of your cases. And then last most common way it can present is ADEM, acute disseminating encephalomyelitis. And you can see this patient has T2 signal here, flare signal in the frontal lobe, the proud occipital lobe. And this most commonly occurs in children, but it can occur in adults as well. And these patients can present with headaches, confusion, a lot of neurologic disability. And before we had the MOG assay, sometimes these patients would come in bilaterally blind with this ADEM. And it was a scary thought, is this infection? Is this neoplasm? Is this inflammatory? And some of these patients even got brain biopsies, but now we've got a specific marker that we can we can check for MOG. Because I remember these patients used to keep me up at night. You know, sometimes we just treat with steroids and hope for the best, and they got miraculously better. In retrospect, I'm sure all those cases were MOG. We just didn't have the assay back then. So I thought it'd be kind of interesting now that we have assays for MOG, we have assays for aquaporin 4. You know, how does that change the way we approach a patient with optic neuritis? And I'd love to hear from all the panel. I've got just, you know, 3 scenarios, and I'm just going to change the variables just a bit. You know, how do we approach it now? This is a 34-year-old female with acute vision loss, subacute vision loss, pain with eye movements in the right eye. They're 20/40. Here's your T1 with contrast with some enhancement of the optic nerve. How would you approach this patient?
Looks like a short segment of the optic nerve being involved and lack of brain involvement, no other brain lesions. Could this be a monophasic optic neuritis treated as a routine optic neuritis?
And as you said, the brain MRI is going to help dictate this. So, you know, if a patient has this, you know, I probably wouldn't have to check. You don't have to check for aquaporin 4. You don't have to check for MOG. You know, this is going to be your run-of-the-mill MS. It still accounts for 50% of her optic neuritis. But what if this patient had no brain lesions? So you said you would treat it as a standard optic neuritis. Would you check for any of these antibodies?
Yes.
I would not unless there is a recurrence.
I would.
Yeah.
I would.
Yeah, this is where there's a lot more gray zone. That first case, classic MS. You know, you probably wouldn't even need anything. You'd obviously probably get a spinal MRI, see if there's any lesions there, but that's classic MS. This patient, no lesions. It's there's a lot of I would, and there's a lot of, you know, maybe you wouldn't have to. And I agree. It's a little bit of a gray zone here. I would say that, you know, this could potentially be, you know, MOG or aquaporin 4 NMO. If it was MOG positive, it really doesn't actually change the outcome. You wouldn't change your management because, just like you said, we treat it as a monophasic optic neuritis. But if they're aquaporin 4 positive, that really changes things, you know, because then all of a sudden, you know, now, you know, if they're NMO positive, aquaporin 4 positive, those assays are so specific, then they've got 99.8% specificity. And if they're actually NMO positive, they're going to need to be on something long-term like rituximab. And
John,
so
if you turn it around and say, what percentage of patients with idiopathic or MS-related, well, let's just do idiopathic, non-serologically negative optic neuritis has enhancement of the nerve or sheath? I mean, is that enough? The thing that always gets me is you do a T1 with contrast, you have enhancement of a portion of the nerve, and the MRI is otherwise negative. What's the likelihood that that is either idiopathic versus NMO or MOG?
Right. Okay, so essentially, what are the relative percentages of these diseases? And it's going to depend on your demographics. You know, in Asia, they have a lot more NMO. And in India, I'm assuming you've got more NMO. And I'd love to hear your thoughts and your how often you see that. But in the US, where it's essentially predominantly Caucasian, the ratio is really swinging toward MS. We recently published a population-based study using the Rochester Epidemiology Project, and essentially 50% are MS, just like we've always known before. But then we actually drew blood on all these patients in Olmsted County, and 5 to 6% are MOG, 3% are aquaporin 4. And so essentially you get all comers. These odd ones, MOG and aquaporin 4, are going to account for about 8 to 9% of your optic neuritis, at least in the US.
That's almost exactly what you found with the optic neuritis treatment trial patients that you looked at.
Yeah, in that one, we went back and looked at the original optic neuritis treatment trial. We had 173 samples from that original trial back from 1991, 1990. And we surprisingly, none of them were positive for NMO, and about 2% were positive for MOG. Our thoughts there is really the inclusion criteria for the optic neuritis treatment trial.
Right. Yeah.
But so all comers, we still have to think about probably 8 to 9%. But I would say this one's definitely a gray zone. Some people would check the antibodies, some people wouldn't. What about this patient here? It's exact same MRI. Now they count fingers. How would you treat this patient? You know, what antibodies would you check?
Yes, Andrew.
Same as the other guy. I don't use the acuity to make that call.
So you would check MOG and aquaporin 4 on both. Yeah.
Right. You don't know. Hey, you
Absolutely.
have good vision. You have it. You have bad vision. I don't know who has NMO. I wish I knew. But only the lab knows. I mean,
No,
I guess if it was severe, I'd be more likely to do it. But I don't think the 20/40 guy gets treated any different than the NLP guy with the scenarios that you outlined. The only person I'm not ordering it on is the classic MS MRI. I'm not doing that one.
Yeah. That's typically how we practice too. But for MOG, ultimately, it doesn't really change your management too much if they're MOG positive. And so you could argue if there's a lot of costs with MOG, hard to get MOG, you could hold off on it. The aquaporin 4 antibodies, they really change management, because if you're animal positive, that's a whole different ballgame. So I think unless it's classic MS, you know, we do tend to check aquaporin 4 for sure. Obviously, I'd love MOG, so I check it on everyone unless you're classic MS, but the specificity is a little bit worse. It's about 98%. So if you check enough people, especially low test probability, you're going to get false positives mixed in there, and then it kind of muddies the water.
But
so
from
definitely classic MS.
From a practical standpoint, and this was brought up with some other issues, you've got the patient in your office. I don't know how soon you get an MRI. We don't do it emergently, but we do the serologic studies that day. So from a practical standpoint, I've already obtained MOG, anti-MOG and anti-aquaporin 4 antibodies before I even get an MRI. Does everybody else get the MRI and then wait?
I get the MRI first.
We get the MRI first.
Yeah, we get the MRI.
Yes, here too.
John, can you comment?
It could go
on,
either way. Yeah.
Like
Okay,
I have some patients where they get better a lot. I mean, really fast. Those people, I actually am more worried.
Yes.
Is that a legitimate concern? Like the next day, the count fingers guy says, "You are awesome." I'm like, oh, that's bad. Is that a good thing to say?
I think, you know, obviously those are much more likely to be MOG positive. And I feel like those ones that are so steroid responsive are the ones that tend to be more steroid dependent. So obviously you're checking MOG on those. And then I tend to do a longer steroid taper, usually over 2 to 3 months of oral prednisone. So yes, I agree. I love how fast they respond, but I am worried it's a ticking time bomb for them to come back.
The other thing I do, John, and see if you agree with this or the rest of the panel, I don't follow the optic neuritis treatment trial protocol for the taper in these. It doesn't have MS on the MRI people because I'm afraid, and I'm waiting for the MOG and the NMO to come back. So I've got this modified, I'm chicken taper. I call it the chicken taper. I'm chicken to taper them. So I keep them on longer steroid until I get the lab back, and I do not follow the optic neuritis treatment trial tapering. I know that's like probably not evidence-based, but what do you say?
I typically, I mean, if they're like a classic MOG, I would do that even before the antibodies are back. But if it's more of a run-of-the-mill kind of optic neuritis, I would just do the IV steroids and kind of call it a day. And you know, if the assays come back positive, then I'll start the steroids. But I still follow the optic neuritis treatment trial unless it's just classic MOG.
Yeah, that's what we do too. If you've got disc swelling, it makes me nervous, and then I may extend things until I get assay back. But if it's an acute retrobulbar optic neuritis and the MRI is normal, then I don't see any reason to extend anything.
John, there are some questions from the panelists, and there is one question is how significant is MOG positive on CSF and negative in serum in a patient with optic neuritis?
Gosh, that is an incredibly hot topic right now. So out of Italy and some groups in Europe are actually finding that occasionally you'll find a MOG positive in the CSF that's negative in the serum. For the most part, the serum is more sensitive for sure, but there's these rare cases where you're going to have possibly a MOG phenotype only positive in the CSF. That's different from aquaporin 4, where really we don't see that. We'll sometimes see positivity in aquaporin 4 in the CSF, but then the titers are much higher in the serum, like 1 to 10,000, and then we'll find a 1 to 100 in the CSF. It's just essentially diffusion. But here there are rare cases where it can happen. So we're actually checking now in a patient who's got classic MOG and they're negative in the serum, we're going to check their CSF. We don't know how often that's going to be the case, but and we don't do it routinely in all patients, but if it's a classic MOG and the antibody is negative, we'll give it a shot.
There is one more question from the panelists. How could you differentiate optic perineuritis, which also has perineural enhancement, from MOG disease? Particularly we in India bump into tuberculosis in anything.
Absolutely. I think, especially in India where there's going to be more TB, I think you're going to have to check MOG and TB. I wouldn't just assume it's MOG. Here in the US, we don't have as much TB. And oftentimes, if it's a classic MOG, I'll treat them as MOG. And if they start not reacting like they should be, then I start expanding the workup. But I think in India, it's all about pretest probability. What is kind of floating around there. And you got to think about TB for sure. And then I saw Andy had a good question. Would you ever biopsy a perineuritis that's seronegative for MOG and NMO? And I think, certainly consider it. I treat them clinically, just like we've always treated them before with steroids. If they respond perfectly, that's great, and they're done. But, if they're, not responding well, then, sometimes we want to know the answer. Tissue is the issue.
I have a follow-up for that, John. Do you repeat the scan on these people?
For patients who are seronegative?
No, they're MOG, but they have the sheath enhancement. They're better, but do you scan them again or no more?
We do for research purposes. We like to, but clinically, if they're responding, you wouldn't have to. But we typically rescan them 6 months later, more for research purposes.
I haven't been.
Yeah, I don't think you need to clinically. If they're responding, you don't have to. Obviously, if anything starts not following the book, you're going to have to. But
there is one more question on MOG disease in children versus adults. We do see probably more MOG in children. Is there any age variation?
Yeah, that's a really good question. So for children, MOG probably explains at least 30% of demyelinating attacks, probably 50% of ADEM. So if they're a child and they have a demyelinating attack, MOG could easily be positive. So it's just incredibly common there. It's interesting because you think about optic neuritis in children, you think bilateral, disc swelling, steroid responsive but steroid dependent. That's all MOG disease. I'm sure all those cases were MOG. We just didn't know it back then.
There's one more question from Carmen. How do you decide to start for MOG positive optic neuritis? How or when do you decide to start second-line immunosuppressants, and which is a preferred immunosuppressant?
Yeah, that's a great question. Do these patients need chronic immunosuppression or not? So aquaporin 4 NMO, it's a real easy decision. Essentially, every patient needs to be started on something, typically rituximab. With MOG, only 2/3 are going to relapse. And if they relapse, the recovery is typically much better. I mean, we often recover back to 2020. We've all seen it. So if they've got a single attack, I don't start chronic immunosuppression. We just treat the acute attack. If they've got a second attack and they've got complete recovery, then we have a little bit more of a discussion. If they have a second attack and incomplete recovery, then we start. And then the question is, what is the medication? We typically start with rituximab or azathioprine or mycophenolate, just the traditional medications for NMO. but multiple studies have shown that it probably does decrease the relapse rate, but there's breakthroughs. So it's not perfect. So we'll start with the traditional ones, and if they continue breaking through that, we've had some good success with IVIG, and there's a multi-center retrospective study with a bunch of providers in the U.S. and some around the world, and we found that IVIG every 4 weeks had a very good job of reducing attacks or relapses in patients that were unresponsive to other medications. So that's our fallback plan.
Okay, thank you.
Thanks, Carmen.
And
John, you've had any cases of MOG positive optic neuritis post-COVID? In India, we have had reports of 3 children where they've had COVID, and after that, not children, one is an adult, where after COVID-19 infection, optic neuritis, bilateral optic neuritis, and they were MOG positive.
No, that's a
Or it was just
good question.
coincidental.
I think, I'm not sure if it's really COVID itself, but about at least a quarter, maybe a third of patients with MOG will have a preceding illness of some kind. And, whether it's the flu, whether it's COVID, some kind of preceding thing that we think ramps up the immune system and creates these antibodies for MOG-associated disorder. So I'm not sure it's specifically COVID specific, but I think any kind of inciting illness can trigger this. And I think that's probably more what it is, because we are seeing some cases, but we're not seeing a huge number. We're not seeing the 200,000 cases, So I think there's an association, but more ramping up the immune system as opposed to COVID. Andy, you have a question there?
Well, I was just going to make a comment. I'm so glad that COVID doesn't have optic neuritis as its presenting, distinctive sign. Can you imagine having to see all these people every time they had blurry vision? I'm just so happy that, it's bad to say it, but I'm so happy we have no role in these people's acute care. Anyway, my question was, I have been testing all my patients who are stable, who had ADEM in the past, or I told them they had cryon, or I told them they had idiopathic, or I told them they had autoimmune optic neuritis. And my hit rate has been about 10 to 20% of people who I told had idiopathic something or other, and they actually had MOG, but nothing happened to them. And I was wondering if you had similar type thing. Nothing happened to them. They had no indication for testing. I just said, I disagree with myself with the past. We need to do a MOG on you.
It's true. Patients can be persistently positive. 2/3 of patients remain persistently positive, and some of them can go decades without a relapse. But then sometimes they'll get a relapse 20 years later, and you're like, oh wow, that was MOG all along. And so that really stresses the importance of, if you've got a single attack, they recover well. You don't want to touch them, because they may never relapse again. So yeah, there's definitely cases floating around. It's nice to have that diagnosis, because then now they know they won't develop MS. I guess that's helpful there. But when I find that MOG positive and they had that optic neuritis 5 years ago, I'm not going to put them on anything.
So we'll sort of wrap it up in the interest of time. One last question, John. Which immunosuppressant do you choose in children apart from steroids? And what is the cutoff for higher immunosuppressors? What is the cutoff?
That's a good question. In children, they're more likely to be monophasic in children. So that's something to keep in mind. They're more likely to become, so we talked about how seropositivity does not mean you're going to have a relapse. But if you're seronegative, it does reduce the risk of relapse, and children are more likely to become seronegative. So we do check titers in children. And then same thing, single attack we don't treat, but if they have multiple attacks, they need to be on something. We typically go to IVIG, actually. In adults, we go to the traditional NMO medications, but in children, to reduce morbidity, we typically go to IVIG. And it does tend to work pretty well.
Okay.
For maintenance, Dr. Chen?
Yes, maintenance every 4 weeks. And we typically go for about a year and then try coming off and hope they do. Obviously, if they've got severe, horrible disease, they're going longer. But if they've got 2 relapses, maybe we'll go to IVIG for a year and then back off. for maintenance.
Do you have some more slides, John?
Oh, no, these are just slides for discussion, and I just thought it'd be helpful to kind of chat about things where MOG and Achmode 4, they're almost never positive together, but it can happen occasionally, 0.6% or so.
Thank you.
So, thank you, John.
Great, thank
Back
you so
to
much.
Thank you very much. Thanks for all that. Thank you. Back to Satya.
Yeah, so now I'd be introducing the next speaker, who has already been a panelist for Dr. Miller, and that is Dr. Valerie Pervin. She did her residency in neurology at Tulane Medical School in New Orleans, and followed by Neuro-Ophthalmology Fellowship at LSU Eye Center. She joined the faculty of Indiana University Medical Center in 1983 and has remained in Indianapolis since then. In addition to several journal articles and chapters, she has co-authored with Dr. Kawasaki the well-received book, Common Neuro-Ophthalmic Pitfalls, a case-based approach to the specialty. She's a reviewer for many journals and has been an editor for the JNO. She has served on several NANOS committees as well as a term on the NANOS board of directors. And her areas of interest are in inflammatory optic neuropathies, optic perineuritis and neuroretinitis, ischemic optic neuropathy, pseudotumor cerebri, and iatrogenic neuro-ophthalmic complications. And she will be discussing with Dr. Miller as a panelist. Over to you, Dr. Valerie.
Thank you so much. Thank you. So first of all, congratulations on organizing this. What an achievement. And I have to say how comforting this is to remember there's a whole world out there for some of us who have been stuck in the same place, in this case, Indiana, where we don't see high altitude optic neuropathy because it's flat, completely flat. I've been here for many months and remembering there's just a world out there and you're all in it. So thank you so much for doing this. I'm going to go ahead and share my screen. And thank you for inviting me to be part of this. So I'm thinking that we can catch up, move this, that we may be able to catch up a little bit because my topic, unlike John Chen's, this is not a hot topic. So I'm thinking maybe it won't generate nearly as many questions and comments. Sometimes for those questions, the questions that come up about the previous subject, the answer, what would you do here? What would you do there? And the answer is call John Chen and ask him what we should be doing. All right, my case for today is shown here. It's called optic nerve double trouble. And this is the story of a 68-year-old dentist who developed a greenish blue halo in the center of vision of his left eye while playing golf. This was initially painless, and he had no other focal neurologic deficits, and he denied any systemic symptoms. He was first seen by his local eye doctor 1 week after onset, who found visual acuity of 2400 in the left eye with disc edema and a couple of nerve fiber layer hemorrhages on the disc. Over the next 2 weeks, he developed mild pain with eye movement and progressive worsening of vision. And it was at that point that we saw him for the first time. So this is his exam 3 weeks after onset, when vision in the left eye had declined to no light perception, with a 4+ left relative afferent pupillary defect. In the right eye, the visual acuity was 20/20 with normal color vision. Visual field testing showed mild nasal depression in the right eye, and he had developed very mild periorbital edema on the left side. And this was his fundus appearance. So this is 3 weeks after onset. The right fundus was normal, healthy looking optic disc with a maybe 0.3, 0.2 cup disc ratio. It certainly wasn't crowded and there was no disc edema. In the left eye, the optic disc was diffusely swollen. There was engorgement of the retinal veins with multiple hemorrhages, some of which were in the nerve fiber layer near and on the disc. Others were in the with intraretinal hemorrhages. There was extensive retinal whitening in the posterior pole with areas of retinal artery occlusion. So the formulation for this fundus appearance was that he had both CRVO, central retinal vein, and central retinal artery occlusions in the same eye. So for the summary of the case to this point, this was a 68-year-old man with acute onset of unilateral visual loss with mild pain on eye movement, ipsilateral disc edema, and retinal venous and arterial occlusions. So the first question that we asked was whether this might be a primary problem with blood vessels, either a vasculitis or maybe a coagulopathy that caused them both to close off in this way, or was it possibly a compressive etiology where the mechanism was something growing in and around the optic nerve that was occluding the arteries and veins by pressure. So in order to answer that question, we obtained an MRI scan, which is shown here. And this is post-contrast, T1. You can see in the left eye, there is enhancement of the intraorbital optic nerve without dramatic enlargement, but even more prominent enhancement of the sheath around the optic nerve. And seen here on the coronal view, same sort of thing with this donut sign. I have a close-up view, this is the same scan, but just magnified, showing again the distinction between the enhancement of the nerve stopping right in the canal, not extending intracranially. We didn't think this is maybe iffy, but there was no definitive evidence of intracranial spread, but this intense enhancement of the sheath seen here on the axial and coronal views. We then ordered a bunch of tests looking for systemic inflammatory disorders primarily. So they're listed here, looked for Wegener, syphilis, lupus, sarcoid. All of these were negative. We did urinalysis, CT chest, abdomen, pelvis, CT PET scan, which were also negative. His spinal fluid protein was mildly elevated at 62, but IgG index, cytology, flow cytometry are all normal. That workup, as we talked about before, that effort to try to figure it out without biopsying the optic nerve took about a month, which we thought was okay because we wanted him to be on high-dose steroids anyway. We were using that time to be treating this, but unfortunately there was, while his pain improved, there was no improvement of vision. And we repeated the MRI at that point. I don't have a picture of it, but it showed posterior further extension of that abnormally enhancing area all the way to the optic chiasm. And at that point, we decided it was time to actually remove that optic nerve. So this was an excisional optic nerve biopsy. That biopsy showed ischemic necrosis of the optic nerve and changes consistent with an anaplastic astrocytoma. So the diagnosis here was a malignant optic glioma, sometimes also called an optic nerve glioma of adults or an optic nerve glioblastoma, this name pointing out that really this is, we think, the same tumor that we see more often in the brain, either as a unifocal or sometimes process, but in this case, it just happens to have arisen within the optic nerve. He was treated with whole brain irradiation, 5400 gray, and chemotherapy, but with minimal response. Maybe it slowed it down, but unfortunately, 1 year later, he had died. So this is just, I just wanted to briefly review this entity. This is a malignant optic glioma of adulthood, which was first described by William Hoyt and colleagues in 1973, who really defined this condition and more specifically distinguished it from the more common and certainly more benign optic nerve glioma of childhood. They reviewed the cases and compiled the following clinical picture, which is really characteristic and has been held out, confirmed by subsequent case reports. This is typically a disease of middle-aged men. So again, very different from the optic nerve childhood glioma. Average age is 52. It presents with acute decreased vision, usually unilateral, which progresses rapidly within 5 to 6 weeks to blindness, with eventual fellow eye involvement and characteristically death within several months, really regardless of treatment. And they also described, and this again has been borne out, a characteristic progression of the fundus findings. And that's actually what I wanted to focus on for this case. The initial phase can have a normal optic disc if the tumor has originated within the intracranial portion of the optic nerve, but more often there is optic disc edema, sometimes with a neurofibrillary hemorrhage, but just non-specific unilateral optic disc edema. Over time, the next stage, there's development of venous congestion with an actual CRVO appearance. And then with a little bit more time, this typically goes on to involve the central retinal artery as well, giving this combination of CRVO. These are not photographs of that progression in my patient, which those were not available, but this end stage, when we saw him, this is again his photograph of his fundus. So what I'd like to focus on is this initial appearance for right now, where that unilateral acute visual loss with disc edema that resembles optic. And they wanted to distinguish it from that. But given the age range of this tumor, what's more likely on the table is AION, either arteritic or non. So I just wanted to briefly talk about how would you distinguish it at this first stage. We're just looking here. The patient presents with a swollen disc. So you think this is AION. What would tip you off that it wasn't? How are they similar? How are they different? So both of these, this is specifically non-arteritic AION versus malignant optic nerve glioma. Both involve middle-aged adults for the most part. Both present with acute visual loss, typically unilateral. We think of AION as being maximal at onset, but in fact, there's this subgroup of, I wouldn't call it chronic, but progressive NAION that actually do worsen over the first couple of weeks, rarely a little bit longer. So that's where the overlap is more of a problem, where it could look initially, NAION could look just like malignant optic glioma. However, in glioma, this further progression of visual loss is relentless. So this is a feature that is clearly different in the two conditions. As far as disc edema in NAION, the disc edema resolves typically within 6 weeks, sometimes a little sooner, but with optic nerve malignancy, it persists. So we could formulate this short list of red flags. These are things that would tip you off if you're seeing a patient, you're thinking they have NAION, what would tip you off to think harder about it and specifically to consider this diagnosis. Another way to look at it is what would tip you off to get a scan, because we don't typically, I don't we could listen to the panelists, but I don't get an MRI in everybody with a diagnosis of NAION. So when would you get that scan? So we could expand the discussion in that way. So, but these are red flags specifically for NAION versus malignant glioma. And the first would be progressive visual loss for greater than 1 month. Second would be disc edema persistent for more than 6 weeks. A third would be hemorrhages not on the disc, but at least one diameter separate from the disc. And this issue of MRI changes, if you do choose to get an MRI and you see some enhancement of the nerve, is that what we talk about sometimes with NAION or arteritic AION. And we initially thought of the MRI in ischemic optic neuropathy as being normal, but with occasional case reports, we recognize now there is sometimes some enhancement. However, the enhancement in ischemic optic neuropathy, the enhancement of the nerve, is maybe subtle, mild, focal. It's not the intense enhancement that we see with this tumor as shown in my case. So that's that first part, the first question, how do you tell it in that early stage? I thought for the panel, I would turn this over to that next stage. How about the next step when it has a venous occlusion with it, venous obstruction or insufficiency? So how do you distinguish that stage of CRVO from this condition, this optic nerve glioma? And another way to ask that question is, what are your indications for getting an MRI in somebody with a CRVO? And then the other question would be, what's your differential for combined CRVO plus CRAO? Obviously, this tumor can do that. Are there other things that can as well? So I'd like to, again, thank the organizers and stop the presentation there.
Can I just, again, I'm sorry to intrude, but if I could make a comment, and that is, when you see a patient with a swollen optic nerve, the OCTA, the OCT, not the OCTA, can give you a very strong diagnostic probability of having a lesion that's retrobulbar versus an intraretinal or optic nerve problem. And this is what Pat Sipping and I have harped on at the Nanos meetings over and over again. If you do the transaxial views, and they're in the office day one, the retrobulbar lesions will almost always have an anterior displacement of the neural canal borders, where the CRVOs, CRAOs, the ischemic optic neuropathies will not. So it tells you, while you have the patient in the office, you don't have to wait for the patient to move to the next phase. And maybe, even though we don't think about this, if we're aggressive enough and smart enough to make the diagnosis of glioma and sacrifice the nerve before it goes NLP, maybe these people wouldn't die like they always do. But I'm just pointing out there is an early, in the office, cheap way to know what you're doing. That's all.
No, thank you. Other panel?
I was going to say that most of my experience with these, and I've only seen a handful of them, have been at the CRVO stage. And the biggest thing that I've noticed is a disconnect between the appearance of the fundus and the level of visual acuity. When I see somebody with what looks like a typical CRVO and the vision is way down, I really get worried. The other thing I would say is that at the earlier stage where you're wondering about ischemic optic neuropathy because the patient's a little bit older, I've noticed, and I thought it was present in the photograph you showed, but I've always felt that the retinal veins are somewhat dilated even in those, whereas in this ischemic optic neuropathy, the retinal veins usually are normal and the retinal arteries may be narrowed. So, but it's the disconnect in the visual function that bothers me. I'd be interested in the standard NAION. It's just seemed to me that the visual loss in those who progress, and it said that like 10% or so progress, is a bit more stuttering, whereas the rapidity of the loss of vision in these patients is incredible and often extends to the opposite side as well. I was disheartened. I was hopeful that you were going to say that your recent research has shown that there are some people who survive. Unfortunately, there are so few of these people that we haven't really done a lot of molecular genetic studies. But my hope is that at some point we'll have, they're less likely, I suspect, to have V600E mutations or Ki67 fusions. But you wonder whether the answer eventually will be targeted therapy, either checkpoint inhibitors or something of that nature, because it appears that we're really in bad shape with them.
Andy, you want to make a point?
Yeah, I was just going to say that, you know, when you see that retinal artery occlusion that's coming off the disc rather than the whole retina, sometimes that's like the cilioretinal artery because the posterior ciliary circulation is a lower perfusion system. So just the vein occlusion alone could produce that little macular looking thing. Right. And the second thing I was going to say is exactly what Neil said is, did you send for the BRAF mutations? Because as you know, the targeted therapies have changed previously uncurable diseases like metastatic melanoma. At MD Anderson Cancer Center, where I part-time work, it's just changed everything, all these targeted things. So the gliomas, even the regular gliomas, we didn't used to biopsy them, but now it's changed everything to have the BRAF and the MEK inhibitors. It really has been a game changer. I guess the guy won a Nobel Prize.
People are even biopsying pontine gliomas because it allows targeted therapy.
Yeah, so I think we have a chance to fix malignant glaucoma. I mean, malignant glioma. It's not a death sentence potentially if this stuff works on them. So maybe we should all just be agreeing that we're going to try it on them because there are not enough patients. Can't wait for a trial. There's not going to be no trial.
Right. I want to thank you for making that point about the cilioretinal artery because it does look a lot like that. But because that's a different association. The idea that a CRVO sometimes picks off the ciliary-retinal artery. And we consider that for this case, although, because it kind of looked like the same distribution, the patient didn't seem to have a ciliary-retinal artery. And then there were all those kind of cotton wool spots, those areas of more intense infarction, I think, off of the branches, the superior and inferior arcades, feeding that area to suggest it wasn't a central one artery that was causing the problem. It was causing the problem in the entire papillomacular bundle. But it's a good point. And this patient didn't have BRAF testing done because it predated that. This is not a new case.
This is one situation where an ophthalmologist can really make a difference in a patient's life. You can save a life, as beautifully Dr. Valerie has presented in the case that the glioma in the early stage can be confused with the ischemic optic neuropathy, and in the later stage with the CRVO with CRAO. And if a neuro-ophthalmologist is involved at any point of time, I'm sure the MRI will be done in these patients. So to get the diagnosis of malignant optic nerve glioma or the glioblastoma of the optic nerve, role of MRI, role of neuroradiologist will be really, really important, because what we maybe they can give us the clue. So do we have Veena with us? Veena, are you there around? I just wanted their opinion, if in any which way, any clue, where we can, have an idea that this is not just ischemic optic neuropathy.
Yeah, Veena is there. Veena, could you comment?
Are you muted, Veena?
She is muted. I think she's not there right now.
In fact, she was complimenting Valerie for her case. She said it's a beautiful case. So I was just wondering if she wanted to make a comment.
Well, maybe while we're waiting for her to come back on, I would love to think that this case, to present this as a really upbeat message of what a difference we made for this patient's life. And if we only knew. But unfortunately, this is just a sad diagnosis still. We look forward to having more to offer. But as far as prolonging the life expectancy, I was briefly encouraged when I did a literature search, and I found a paper that said with long, 2 cases of this tumor with prolonged lifespan, prolonged survival. I thought, oh wow, this is great. And I looked it up, and one of them was like 9 months, and the other was 15, all the way to 15 months. Like, this is not good news. This barely counts. So I think what the aggressive treatment does, it prolongs it. It's kind of like most glioblastomas of the brain. It prolongs it basically from weeks to months.
No, if it was localized just to the orbit and we would have excised the whole nerve, we could have taken the tumor out.
Yeah, I'm not convinced of that.
That's true. Right, I think this is kind of a multifocal, even if you don't see multiple foci discretely on the MRI, but conceptually it's a multifocal process that is arising in all these different places at once. I think it's a part of why it's so difficult to treat.
Yeah, I agree completely. We did a study with the New York group, the Columbia group, some years ago on these tumors when people used to excise the low-grade gliomas. And the fact is that you can see tumor tissue beyond the confines of what the MRI shows. So I would be very hesitant to be very optimistic that you could cure this with a large excision.
Right. In fact, this patient, I mentioned it, but I didn't show the field at initial presentation when it so clearly seemed to be a perfectly unilateral case. I said there was a little field defect. It was infranasal, one eye septor, and supranasal in the other, but it was minor and it was mild and it wasn't supratemporal. So it didn't seem to want to be a junctional scotoma. But that patient, by that end of the 30 days when it had progressed back to the chiasm, but not to include, had already started losing vision in that month in the fellow eye. So I think, it really doesn't go from here to there. It's kind of arising in many places. It's a very sad
I think
tumor.
the other interesting thing is that now that we've been treating benign childhood optic gliomas with MEC or inhibitors or BRAF inhibitors, what we're now seeing is in many cases, the enhancement disappears, but the mass may slightly decrease in size or markedly decrease in size. But the fact is that enhancement resolution is a big part of the chemotherapy. And obviously there's still tumor cells in the area.
Yeah, that's interesting. And I also just another point about, what's the takeaway message? So I for this session, I was asked to present a case of infiltrating optic neuropathy. In this case, I've had this for quite a while, and I wanted to show this sad case to the world. But to make it more applicable to the general ophthalmologists that are paying attention, that are listening and watching, and more of a broader takeaway message than simply this, it's a rare tumor, no question. So how many cases will you see? Not a lot, but NAION, CRVO with management decisions to make, you see that all the time. So that was my main interest in showing the case, was that connection and slicing it through in time in just that way. Other questions or chatting? Other chatting?
Andy wants to make a point.
Valerie, as I recall, the path usually was benign in these cases. Is that still the case, or is it GBM?
No, it's a high-grade glioma. It doesn't, it's not, you're talking about this malignant glioma, not the optic nerve glioma of childhood, but this kind of glioma is, or malignant cells. Although I have to say the path on our case took a couple of weeks to figure out. It was confusing. There was all of that necrosis. There were some histiocytes, there were inflammatory changes, and these abnormal glial cells. And it was sent out for a second opinion, which agreed with our pathologist, but it added a 2-week delay before we could confirm what it really was. And nowadays with markers, probably that would be faster.
In the brain, in the brain, it can be confused with MS. And we've had a couple of cases where outside people had diagnosed somebody as having a tumefactive MS, or the reverse is more common. They've just diagnosed a GBM when in fact it was tumefactive MS. So it can be really confusing, as Val says.
Another thing in India, tuberculosis-related perioptic neuritis can present with CRAO and CRVO simultaneously. I've had a case, similar appearance as you've shown the later presentation of the glioblastoma of the optic nerve. So that is one of the differential which could be more commonly seen.
Right, that's interesting. I think there's a difference in the spectrum of visual involvement in idiopathic optic perineuritis versus some real cause like TB or Wegener or something else. And so we publish our series that we published with the late Dan Jacobson and Aki Kawasaki was, I think it was 14 cases, and they were all idiopathic. We also published 3 cases of Wegener's with much worse vision. But one of our takeaway messages for the idiopathic kind was they have a lot of pain and MRI changes, but little or no visual loss. And it was mild, it was non-central. So that distinction was very helpful. But I think not so much with TB or Wegener's or some specific. And back to Andy, your point about through the retrospectoscope, things we called idiopathic, and now there's an answer. I have horrible thought, like it's the kind of thing you'd wake up, if you woke up in the middle of the night, it might be that. Like people I told that they had idiopathic neuroretinitis. I mean, all that stuff that's idiopathic someday we'll know, and it has a cause, right? None of it is just unknowable. So, but I think my biggest fear has always been giving it that label, calling it idiopathic, and in fact missing something treatable. So hopefully the idea that, yeah, okay, it's not idiopathic, but we would have treated it the same way. A lot of the cryons are that way. The recurrent, we put them on Imuran, other immunosuppressants if that didn't work. We didn't know what to call them, or we just, we had a different name in the States versus in the UK, but it didn't matter, but you would have done the same thing anyway. But I think the big fear is calling it idiopathic or calling it something else, and you missed your chance to save the vision.
Yeah, on that point, I would say my number one, I called it idiopathic and was wrong, has been IgG4. The disorder, like idiopathic hypertrophic cranial pachymeningitis, whatever that thing was, a lot of those patients ended up being IgG4. Idiopathic recurrent orbital pseudotumors that I told, hey, it's idiopathic, those were IgG4. And so that's why I was asking John about IgG4 and the perineuritis MOG mimics. When do you do a biopsy? Because those patients respond to steroids. I haven't been imaging them. So like you, I have these nightmares about, oh, I told this person they were seronegative MOG, but they had IgG4.
Mm-hmm.
Well, the only good thing is that you're going to treat them pretty much the same way. You're going to treat them with steroids. What I worry about is exactly what Valerie was saying, which is I wake up thinking I told somebody that this was benign, and if I treated them heavily, like a sarcoid, for instance, where you might not treat. And in the old days of optic neuritis, when we thought everything was idiopathic or MS related, I gave the patients an option of treating with steroids or not. Now I treat everybody with optic neuritis with steroids because I don't know what's really going on and I don't want to wait for the antibodies.
The other point
go ahead.
I was going to say, the other point this case brings up is just a separate subject of doing an optic nerve biopsy, meaning removing the optic nerve, and how often people do that and what does it take to get you to make that move. Right around the same time that I had this case, there was another man, similar gender, middle-aged man with same CRVO, CRAO, blindness, wasn't going anywhere, negative workup. We took out the optic nerve. So same sort of story, but with a different ending, and just didn't get a diagnosis. They said it was just necrotic. I mean, the pathologist was up and down it and couldn't find anything that explained it. And he was blind in that eye, and he just stayed that way. And I used to call him like every year for a while, just like you're still, which really, if he picked up the phone, I didn't really need to ask anything else. I mean, he was still with us. He was still around. And
did you just hang up on the guy?
It was before I could look at my cell phone at the same time while he was a very nice man. We're happy to hear from him. But I guess kept checking in to make sure that the other shoe had not dropped, that again, we hadn't missed, because I feel like I obviously missed something. Maybe it was viral, like a herpes, some sort of viral optic neuritis. I don't know. It was very dissatisfying. So that was my other point about asking people, have you seen this combination, CRAO, CRVO? Like what else, and has anybody just not had an answer? Doesn't it seem like if you took out the entire optic nerve, if you went that far, the least you could get would be an answer? Apparently not.
I have the opposite story. A patient had the sheath enhancement. It was progressive. They were MOG negative. We worked it up. Nothing was seen. So the radiologist said it's a sheath meningioma. So I just radiated it, and Neil knows this story. We radiated it, and miraculously, the sheath meningioma disappeared completely radiographically, and I think I radiated a sarcoidosis.
Yeah.
But they got better.
I've had several of those where it's a little bit like the optic neuritis being dramatically, the vision improving with steroids. When we radiate what we think is an optic nerve sheath meningioma and the vision dramatically improves, I'm convinced we've radiated some type of inflammatory process.
Right. It's exactly good news, bad news. Good news, your vision is better. Bad news is I have no idea what you have, but it's okay now. Now you're not going to take out the optic nerve.
To this day, that lady thinks I cured her sheath meningioma.
So on this note, can we move on to the next presentation?
Sure. Thank you. Yes, I'm done. Thank you.
Thank you. Thank you, Valerie. And so let me quickly reintroduce Shikha again. So because I introduced her long back in this session today. So Deputy Director Neuro-Ophthalmology at Shankar Nethralaya, Chennai Neuro-Ophthalmology Services. And atypical, her areas of interest are atypical optic neuritis, OCT and neuro-ophthalmology and congenital disc anomalies. And she's won the prestigious SD Athavale Award at the APAO AIOS 2013. And she has excellent papers on optic disc anomalies in adult South Indian population and OCT and papilledema versus pseudopapilledema. Over to you, Shikha.
Thanks, Satya. Now I'll invite Dr. Andrew Lee to give his talk. Dr. Andrew G. Lee is Chair, Department of Ophthalmology, Blampton Eye Institute, Houston Methodist Hospital, United States. He did his Neuro-Ophthalmology Fellowship from Wilmer Eye Institute, Johns Hopkins Hospital in 1993. And he is served on the editorial board of 15 eye journals. He is the founding editor-in-chief of the Journal of Academic Ophthalmology. He has served as a principal investigator at HMH on a number of national research trials in ophthalmology. But what excites him most and what he loves doing most is teaching. He's an excellent academician, and he's also been the past president of NANOS. He's completely committed to teaching. So it's an honor and a pleasure to have Dr. Andrew G. Lee with us. And I request him now to present his talk.
Well, thank you so much. And I can tell you, I've been on about 1 million Zoom calls. Can you see the screen already?
Yes.
Okay. And I do about 4 hours of Zoom a day, and this is the best Zoom I've ever been on. So thank you, Satya and Shika, for having me. It's rare that you get to be on a Zoom call with your peers, but also your mentors and your heroes. So I'm so happy to be able to participate in this, and as well as see our junior people who also will serve in the long line of neuro-ophthalmology. And John Chen and I share an alma mater at the University of Virginia. The other thing I wanted to mention to you is Nanos, as you know, is going virtual. So this is kind of a dry run for us. And I'm so happy that you're going so well with this. And we will be definitely taking a lot of your best practices to the Nanos virtual meeting. So thank you so much for that as well. And my little presentation is going to play off a lot of what's already been given. And I was hoping it to be a little bit more interactive. So after each slide, I will stop and let Shika teach us something. As Neil and I told you before, when we travel, the best part of traveling for me is learning the local culture, having the local food, meeting the local people, but most importantly for neuro-op, learning the neuro-op disease of the country that we are traveling to. So that's what I hope this session will be about for my section is, what does MOG and NMO and optic neuritis look like in India? Because here in Houston, Texas, we have 150,000 Indian Americans. So I kind of need to know what India optic neuritis looks like, because all I have is John Chen's Million Mayo Clinic White People papers. And that doesn't apply to everybody in our country. So I hope that you'll be able to teach us something. So what I want to cover is, if it quacks like a duck and looks like a duck and flies like a duck, it's probably a duck. And hopefully for the audience, what I'm going to show you is, what does an ophthalmologist need to know about ducks? And you've heard a lot about what we used to use as an algorithm. And so this will be one of the main discussion points is, I learned, here's what you did. If it was typical, it had a workup. And if it was atypical, it had a different workup. And that the optic neuritis treatment trial said, we don't work up typical optic neuritis. We don't do all these labs. We don't do an LP. We don't do anything. But an Indian duck, this is an Indian duck, by the way, might look different than a Mayo Clinic, Olmsted County, St. Mary's Hospital duck. So here's what I would consider a typical duck in the United States of America. A 20-year-old previously healthy white woman who has acute unilateral loss of vision. She has a central depression on her field. She has an RAPD. She has pain with eye movement and a normal fundus. An MR shows white matter lesions and enhancement of the nerve. She's given intravenous steroids and gets better. My neurology guys say, okay, disease-modifying therapy for MS. This would be like quack, 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 quack. I don't do NMO or MOG on this. So this is the one circumstance where I don't do NMO and MOG. I hope you agree, John. It's just like regular optic neuritis from MS. It's a waste of money. In fact, we have people who, as John said, they get tested and then they're positive. But then we retest them and it's a false positive, or it's a super low titer on the MOG. And so I've sent some of these to John, and John says, that's kind of a low titer, dude. I'm like, I know, it was MS. And then he'll say this, why'd you order that? I'm like, I didn't order that. The neurology team ordered that. So this is the part where I'm going to turn it over to Shika after this slide, see what she has to say and what our Indian colleagues say. So this is what I learned last time I was in India, that there are some things about your optic neuritis that your ducts do look like our ducts. It's a young female. But then I learned this. The things that we just told you are our indications for ordering the MOG, the disc edema, rather than retrobulbar. That's kind of your normal optic neuritis. The bilateral, John's case, the bilateral optic disc edema case, that's going to get NMO and MOG for sure in the USA. Recurrence, didn't we just say that too? It comes back. So the conclusion to this paper by Rohit and some of his colleagues who you all know is that your clinical profile, your duct does not look like our duct. So Shika, I'll turn it over to you and the panel at this point to teach me something.
Shika, if you don't mind, I have a comment to make here.
Sure.
Okay. I think, Andrew, you just pointed out something very interesting. You know, all these antibody testing has penetrated or is just penetrating Indian states and cities in the last year or two. So I think all we are doing right now is just rediscovering those same conditions which you've already discovered there. So maybe we are already looking at all these patients which you said are bilateral papillitis and they have recurrence, and probably they're all MOG. They've just not been tested for it.
Test the hypothesis, come back and write it up. I mean, I want to know. I got 150,000 Indian people.
So if you could stop sharing the slide for a while, we'll go and involve the other panelists as well. Very interesting thing you have brought up, Andy, that what we see now, what you've compared here is both typical and atypical optic neuritis as a group. That's a one duct, you want us to specify one duct for the optic neuritis. Now, in India also, it has been divided into two things, that is typical and atypical. Agree that of all the optic neuritis, we see a little more of atypical cases of that group. Again, a little more of probably tuberculosis related and infectious stuff. But the typical optic neuritis that we see is probably, and especially the MS related, is quite similar to what you've reported. Ambika, would you like to add on anything to that?
Yeah, I think as an extension of what Rohit has brought up, we have more bilateral, more disc edema, less pain, and I don't stop with a MRI. I ask for blood investigations when I see a disc edema. So it's immaterial because we see a lot of TB, dengue cases presenting with disc edema, because we have a lot of infectious conditions also presenting, because most of the times patients did not reveal the history of a prior illness like fever or anything. So unless it's been probed for, but we see less of MS classical ones, and we see more of optic nerve sheath enhancing lesions. That's why I asked that question of what's the role of differentiating an optic perineuritis from a MOG entity, because that's one thing which we find it very difficult to differentiate, because I think being in India itself, we are having TB swimming around us. If half of the Indian panelists, if you get a manto, you will be partly reactive. So I can't be brand TB. But if at all a patient comes with a old healed Cox lesion in the chest and having a sheath enhancement, well, how do I go about unless I have a MOG positivity in such a patient? So if I have to immunosuppress, having in mind that the latent TB can reactivate any time, our ID people will bounce on us because they would say that we could not go on the next line of antituberculous therapy because the guy has already completed one course of ATT. So our patients are having higher chances of disc edema. So probably what we were saying as idiopathic, as they could be MOG, but in the last 2 to 2.5 years, we have been analyzing our patients like this, where we found we see a lot number of patients, we see more number of double negatives also presenting like this. They were negative for MOG, they were negative for NMO antibody, but still they presented with disc edema. So probably we are keeping them under still as a probable MOG, and we may have to repeat the MOG in this when they throw a relapse. So now coming to the question, one sec, Shikha. Coming to the question, Dr. John, when would you recommend a repeat test of a MOG when it turns to be negative once?
Yeah, obviously the sensitivity we're still working out, and if it quacks like a duck of MOG optic neuritis, I would definitely check again. And all assays are not created equal either. It has to be a cell-based assay, and then the live cell-based assay is slightly more sensitive and specific than the non-live cell assay, and so you also want to look at the assay. We recently collaborated with a group in Sri Lanka and tested 500, I think it was around 500 consecutive demyelination attacks, and 17% were MOG. So that's far higher than anything we see here in the States. And I'm not sure if that may explain it, but just like you're saying, is that explaining why there's so much bilateral optic neuritis? And then, a third of them are going to become seronegative over time. So are we just missing them now? But obviously time will tell.
Can I just ask,
Coming back to Andy's original question, that is, do our patients present differently from the Western population? Satya,
Yes.
right in the beginning, has given the explanation. This is a 2014 paper, and probably if we run these antibody tests, these will turn out to be MOG or NMO related cases, which we were calling previously as tuberculosis associated cases. In fact, we have now it's become, TB related optic neuropathy, at least in my clinic, it has reduced since these tests have come. So probably we need to come up with our pure MS related presentation again. We need to relook at it.
Can I just ask, in the United States, as it has been obvious, the environment doesn't play a role in the vast majority of cases of optic neuritis. They're not going to be infectious. Do you make a distinction if somebody comes from in India and surrounding area? Do you make a distinction if somebody comes from a rural area or a particularly poor socioeconomic area as opposed to urban dwellers in terms of the likelihood of an infectious process?
It's for us.
Yes,
Yes.
He is asking us.
Got it.
Not really. Actually, no. It's kind of changed with the. It's made so much of a difference running these tests. Previously probably I would have said an atypical presentation, a positive MAN2, a little bit of past signs of TB infection on the X-ray. Yeah, I would have labeled it as tuberculosis associated, coming from a lower socioeconomic background. Yeah, all these things would have made a difference to my diagnosis. But now in the first go, running all those tests, if it comes positive, unless I have an active TB proven by an ID specialist, I wouldn't take into account the patients coming from this background or from a good background. Some people are just susceptible, even from good socioeconomic backgrounds. If they're susceptible to TB, they are susceptible to TB.
Yes, Ambika.
There's no change from the background. Immaterial if a patient presents with disc edema, and if I suspect that I have to run all the tests for granulomatous, I would ask for TB evaluation. So there's no background scoring on that.
Okay, one comment here is that we do get tuberculosis in a good number of higher socioeconomic status patients in India. We've had doctor colleagues who have been getting tuberculosis. So it's so rampant here that, tubercular optic neuropathy has to be kept in our, the first three differentials. But yes, in the lower socioeconomic status patients or those from the villages, I think the typical or atypical optic neuritis demyelinating is lesser. What do you say, Ambika?
I think even it's poor or urban, I don't see that much of MS, what we see in West. It is whatever the population we have been getting in our hospital, it's more of a non-MS type of neuritis is what we are seeing. But still, we don't have any longitudinal studies down the line which are proving that. But whatever Rohit's study is, by 3 years, he got around 5% of cases, I think, in that paper. And we are doing a longitudinal study of almost 10 years. We are going to come up with that, which also had showed that we had almost in 165 number of patients, we had only some 6 to 7% of them turned at the end of 5 years. So, which means like, again, the incidence is not that much like what we see in West. We see a lot of atypical. We see probably we may be the forerunner in MOG also, like what we are doing in COVID now. So maybe MOG can be more in our group is what I feel. And whatever the pediatric group, what we analyzed and published, also that children, what blood samples we had preserved, we have run through for few of the children for MOG, which also turned to be a MOG because they started throwing relapse. And few of them have started coming as a encephalopathy also, because ADEM by understanding is a monophasic event. But those children did present to us with an encephalopathy like picture with a vision loss, even on their relapses. And they turned out to be MOG positive. That's what we observed in our group.
So this is Mark. So I want to ask this question, and I just asked it to you privately, and that is, so we don't have to face this issue, but you do. You have all these people who have had TB or a TB positive study, so they have indolent TB. What about those cases that you have to put on protracted steroids or other immunomodulatory drugs? What are you doing with all of those patients? Because you can reactivate the TB, and that's what scared the heck out of me to have the obligation there. So what are you doing, and what's your experience about reactivating TB?
We give ATT along with the steroids in these patients. If there is a suspected, these patients are treated along with the ID specialist, and if there is a suspicion of tuberculosis, ATT is added. 2 drugs are added. Ambika, you want to add anything?
These patients we can split into 2. If you're going to deal with a typical neuritis, I hardly have seen a typical demyelinating neuritis turning out to be TB where I dealt, because the first line I have treated and I have sent to the neurologist. And most of the times when the neurologists keep them on a longer immunosuppression, they involve an infectious disease consultant. So I don't do the classical demyelinating ones for the ID follow-up. But 2, atypical neuritis, yes, I involve the infectious person from the beginning. And most of these patients, they respond very fast to steroids. So I have not required the necessity to keep them on a longer course of steroids, because most of the times they did recover, like one of the few cases which has been described earlier. So they recovered very well, and their necessity for immunosuppression was less, but we do cover all these patients for an antituberculous treatment therapy immaterially, and an ID will be in a close follow-up. The top it up, I will give one more thing. And one of the patients had recovered from neuritis and came back with a sudden drop in vision in both the eyes. But when I saw it was still pale disc, guess we bumped into ethambutol optic toxicity. So that's another one thing which we have to watch out. So that's also going to add a confusion to our atypical neuritis patients. So we see a lot of ethambutol toxicity also. So when I send the patient to ID guy, look, it's an optic neuropathy. Warn the patient that if you're going to give ethambutol, and if you're going to give the patient an ethambutol, please pack him back to me. So that's what we deal with.
Yeah, I remember coming to India the first time, and the very first case, Mark, was
Andy.
Was the TB case, and I was like, I have no idea what this is. This would be grand rounds in our place. Dr. Lee, you're so dumb. This is tuberculosis. So then the second case, I said, well, I would obviously consider tuberculosis in this case and do the PPD. And they're like, everybody is going to be positive, Dr. Lee. We don't do that. And I said, okay, third case. I said, I would do a chest x-ray. They said, everybody has old granulomatous disease on the chest x-ray. We would go straight to the PCR for MTB on the CSF. What kind of visiting professor are you, Dr. Lee? You don't know nothing. Even the medical student knows more about TB, optic neuritis than you. So
I still remember that, Andy.
I do remember that. It was just like, and now we will present these warm-up cases for Dr. Lee, which I got 3 in a row wrong. They were all tuberculous. 3 in a row wrong. Should I go back to the slide?
Yep.
Yes, yes.
All right. Let's see. Is it working?
Yeah.
Okay. So John already alluded to the idea that when I trained with Neil, we would get the MRI and we would tell him, look, good news, your brain MRI is normal. But now we have this, there's also this bad news. Your brain MRI is normal. So the one person I don't have to think about all these weird things is the MS person. But what if I don't have that? Then you could have nothing, just idiopathic optic neuritis, a one and done. Maybe we never see you again, or you might be back here in like a month and be blind. So one of the things that's interesting is in our country, ethnicity matters. So here I changed the stem of the patient to make it an atypical duck in our country. What would make it not quack right? They're older, they're 40 years old. Instead of a white person, they're Afro-Caribbean, they're a male instead of a female. They have the loss of vision, but the pain is like 10 out of 10 scale. Or they have the swollen disc, and then the good news, bad news thing. The good news is I don't see any MS. The bad news is I don't see any MS. And then the thing I alluded to before, on day 2, they're like thanking me. Dr. Lee, you're a miracle worker. My vision already is better. So John, are these legitimate things for me to say, you know what, you ain't following Mayo Clinic, Olmsted County?
No, absolutely. This person definitely gets the antibodies. There's no doubt about it. And
so my question for you, John, and also for our Indian panel is, how many of these things in America, John, and what kind of likelihood ratio would you put on, how much strength should I put on African American, Afro-Caribbean? How much would you put on male? How much would you put on the severity of the pain? How much would you put for the disc edema? Because it's what Neil said, right? It's individualized, but I loaded everything I could into this slide. But how many of these would say that's enough, or any one of these is enough?
There's a mix, because you got the Afro-Caribbean, which is leaning toward NMO, because MOG doesn't have that ethnicity kind of thing, unless, you know, maybe in Sri Lanka and India, it's actually higher. But at least in the studies in the US, we haven't seen that huge variation. You've got the severe pain that's leaning toward MOG. The disc edema is leaning toward MOG. The MRI is no MS, so it's not MS, or theoretically, usually not MS. And then the male would also lean you toward MOG, because it's got essentially a 50-50 split, whereas NMO is going to be much more female. And the marked improvement is leaning more toward MOG. So here, you've got a little bit of a mix, but I would lean toward MOG. I would call it an atypical duck. I would treat him. I wouldn't give him the option to observe on this one, actually. I would treat him with the IV steroids, and I would get the assays.
Shika?
What about sarcoidosis? Whatever, it's sarcoidosis also melts with steroids. Then you've got that Afro-Caribbean male there. Well, it could be just about anything. But in India, yeah, MOG, NMO, it could be just about anything. In India, it could be just about anything. I'll have to do the atypical workup. Other than your antibodies, it'll include the test for tuberculosis and other granulomatous diseases as well.
So that means my question for you and for John is, being from India, I got 150,000 Indians in my town. Is that enough? John, is there ethnic breakdown? African, Afro-Caribbean, I know that one for sure. But how about Indian subcontinent or Sri Lanka?
The Sri Lanka study suggested that there's more MOG. It wasn't population based, but it sounds like our colleagues in India are really sounding like there's a lot of MOG floating around there. And of course, the TV and all these other things we have to think about. We can't just think about MOG and OCT4. But yeah, I'd love to hear your thoughts from India.
I think probably we will be able to answer this question by 2022, probably, Andy. I think that's what I should end it up with, because we have to see these patients in the long run, and we have to run the MOG for all these patients, immaterial of them being with TB or without TB, because, and only one thing we can rule out is the good improvement with steroid. Definitely they are not MS. So we are dealing with something, a granulomatous etiology, or probably a MOG, having a disc edema, pain, and a probable sheath enhancement and a good vision recovery with steroids. So 2020, you await another global fest. We will answer this question.
In the United States, MS, and I guess around the world, there's a suggestion that where you grew up, or if you move to an area from that's commonly has MS at an early age, you don't have the same risk of developing MS, and vice versa. Is there a difference in either NMO or MOG if you moved from, say, India to the United States? You're Indian Americans, if it's somebody from India who moved at an early stage, do you think that makes any difference?
I don't know. It's kind of like what Edsel said. It's not really their skin tone or they're from India. It's probably their genetics. So I would have said no, but the MS story says otherwise, I think. I do like what you said about the TB thing. So this is what I do in my Indian American population here. And I'd be interested in our Indian colleagues to make sure I'm doing right by these Indian Americans here in Houston. If they have moved here within 5 years, I still am worried as if I was seeing them in India about tuberculosis disease. We do the quantiferon rather than the PPD because they're all going to be positive and they all got that BCG on board. Exactly. I do a screening chest x-ray, and if they have old granulomatous disease visible on the chest x-ray, I send them all to infectious disease, and they end up getting on INH and being followed by ID when we're treating them with the steroids. That is our current protocol in Houston, Texas, for my Indian Americans who have it. I don't know what you're doing, John. You have a lot of Indian Americans in Rochester.
Yeah, I think that approach is, that's how I would approach it here in the US as well. Again, love to hear how you all approach it in India.
It's exactly the same. We run through the entire evaluations like what I had earlier discussed. So I think we'll move on to the next case. We are already running a bit late.
One more slide.
One more slide is there, Andy?
No, I just had a question for John with that slide, which is the sheath enhancement. Is it enough to say it's not MOG? I mean, not NMO.
So the sheath enhancement isn't quite as specific. So if it's just a sheath, you can sometimes get that in MS and NMO. But if you really get that sheath plus the peribulbar fat, that you rarely see. Of course, medicine is never 100%, but you rarely see that with MS and NMO if it goes and extends beyond the sheath into the peribulbar fat. So I would say the sheath alone.
I still have to order both. If it's going, even if it's in the sheath and fat, I have to order both.
If it's just the sheath, you'd want to get both for sure.
That was the point of that slide, Snatch.
That's assuming it's an acute loss of vision, because you can see fingers of fat involvement in optic nerve sheath meningiomas where the sheath is enhancing and it's never a perfect circle, you get stuff out. So I think the clinical setting obviously would be crucial.
Can I ask one question to Dr. John? Am I audible? Yeah. There are like fixed cell-based assay kits which are available in the market, which claim to do both NMO and MOG in the same sitting. You run the sample in that, at the end of it, you will know it's NMO or MOG or maybe double negative. So do you take on it?
Yeah, as long as it's a cell-based assay, it's going to be decent. So the most common one is Euroimmune, and they've got a fixed cell-based assay, and it's decent. The live cell-based assays are just still a little bit better, but nothing. As long as it's a cell-based assay, clinically, I'm perfectly fine going with it. If it doesn't quite make sense, then you could try to send out for a live cell-based assay. But I think just right off the bat, the convenience of the fixed cell-based assay is fine. It's so much better than ELISA, so much better than all the other ones. So as long as it's cell-based, you're going to be okay.
Because as of now, we don't have the access to live cell-based assays way back over here. So whatever we are getting is this fixed cell-based assays. That's the reason what I wanted to know from you.
No, absolutely. I would say that's the most common around the world, and they're pretty darn good. We're talking about, 99% versus 98%, those kinds of numbers. And so you could always repeat it again if something doesn't make sense, or potentially ship out to the UK or the US for these live cell-based assays if you need them live. But as long as it's cell-based, it's going to be worlds better than the other assays.
Thank you.
Thank you, John. And we'll move on to the last presentation. And let me introduce Ambika again. Dr. Ambika is the head of Neuro-Ophthalmology department at Shankar Nethralaya, Chennai, India. And she did her post-graduation at Medical Research Foundation, Shankar Nethralaya, and Neuro-Ophthalmology training also at the same place. She also trained with Professor Andrew Lee, James Goodwin, and Joel Glazer in 2005. She's authored several publications in ophthalmology journals. She's a co-author in the SN Atlas of Neuro-Ophthalmology and the SN Atlas of Neuroimaging in Ophthalmology. And she has several chapters in ophthalmology textbooks. She's an executive member of the Indian Neuro-Ophthalmology Society, and she's a member of AIOS, NANOS, and ASNOS. The areas of interest are optic neuritis, demyelination, ocular myasthenia gravis, and mitochondrial optic neuropathies, apart from neuroimaging. Over to you, Ambika.
Thank you, Dr. Satya, for this introduction. And I think it's time for me to introduce our next speaker, Dr. Luciano, Professor of Ophthalmology of Medical Science College of Minas Gerais and Head of Neuro-Ophthalmology.
Share the screen, Ambika.
I have.
It's not come. You have to choose the slide and then share.
Is it?
Yeah, it's come. Yes.
Okay. So let me introduce Dr. Luciano, the Professor of Ophthalmology, Medical Science College, Minas Gerais, and Head of Neuro-Ophthalmology Service Institute. I hope I'm reading English. Institute Brazil. And he has done research fellowship at Vilsai Hospital. And thank you for joining, Dr. Luciano. Over to you.
I would like to thank this honorable invitation for being here with my mentors. Let me share.
Yes, we can see it.
Oh, so it's a unique opportunity to be here. Thank you once more for being here for this outstanding event. Last but not least, I hope that will be the last case of the day of the mystery of the fellow eye. So this is a case of 19-year-old Caucasian Brazilian teenager with history of suspected glaucoma during her ophthalmology consultation in 2019. During her ophthalmology follow-up this year, her ophthalmologist decided to send her to glaucoma specialist. However, before this appointment, she complained of decreased vision in the right eye in the past 4 days, and glaucoma workup was done. So she was referred to neuro-ophthalmology consultation for this new history, and glaucoma exams were not suggestive. She complained of decreased vision in the right eye in the past 5 days with ocular pain movement, and she denied any complaints in the left eye. However, when I asked her about Uthoff phenomenon, she reported it in the past 3 months after hot bath, and she replied to me, "Is it a concern?" medical history relevant for depression. There was no alcohol, no tobacco, no illicit drugs, and family history was not contributory. Her neuro-ophthalmology exam revealed visual acuity of 20/200 on the right, full on the left. She had corneal plates unable on the right, full on the left. Pupils were reactive, symmetric, and there was a right RAPD. Amela's grid and visual fields by confrontation test revealed temporal scotoma on the right and full on the left. Eye movements were full, and she complained of ocular pain in the right eye. Intraocular pressures were within normal limits. Slit lamp was unremarkable. And the fundus revealed increased cup disc ratio bilaterally with a questionable temporal pallor optic disc. Here is her posterior pole retinography, and that with the fundus that I just described. Her visual fields revealed temporal scotoma on the right and questionable superior scotoma on the left. And her OCT showed in a retinal nerve fiber layer thickness a normal finding on the right, and surprisingly, it shows the abnormalities on the left in the asymptomatic eye, with the decrease more evident temporarily. Her ganglion cell layer also showed normal findings on the right and decreased thickness on the left in all quadrants. We looked for deeper retinal layers, and then we found out normal findings on the right and decreased thickness on the left. And also when we measured the outer nuclear layer, it showed normal findings on the right and that funny appearance on the left, like inferior thickness in the superior retina and enhanced inferior enhanced thickness in the inferior retina. The Optic MRI was ordered, and they revealed bilateral gadolinium-enhancing lesions of both optic nerves. And also brain MRI showed bilateral white matter hyperintensities associated to just cortical, periventricular, and infratentorial lesions. And at this point, what we have as a hypothesis was a bilateral optic neuropathy with the myelinating lesions on orbits and brain MRIs, suggestive of multiple sclerosis. So she underwent a neurology workup, and she fulfilled the McDonald criteria, diagnostic criteria of MS. She presented the bilateral optic neuropathy, multiple brain matter lesions, oligoclonal bands in the CSF analysis, in that additional abnormalities in the OCT in her asymptomatic left eye. So she was diagnosed as multiple sclerosis patient. The OCT findings in multiple sclerosis have been reported for a long time, and they help us understand that mysterious immune-mediated pathogenesis associated with axonal damage, neuronal loss, and demyelination. The challenges of the OCT start with the unique opportunity to elucidate that neuroaxonal structure of the anterior visual pathway, as the back of the eye is the front of the brain. Reports reveal that lower RNFL and GCL-IPS thickness may reflect subclinical optic, worse visual outcomes, more clinical disability, and higher MRI lesion loads, and more relapses in relapsing remitting MS. The INL and ONL thicknesses in MS may represent a distinct global CNS process not related to that RNFL or GCL-IPS issue. And one of our findings, the higher INL thickness in non-optic neuritis eyes, also was reported as a potential inflammation in the retina as well as in the CNS. And when in the same may also happen regarding to a CNS inflammation, when lower outer nuclear layer thickness is measured in that patients. So our case of early stage of MS is an initiating symptom presented as optic neuritis in the right eye that showed normal findings in a symptomatic eye and revealed that abnormalities in the OCT that may reflect that active CNS inflammation seen in MRI scans in the CSF oligoclonal bands. Future, the OCT technology may be the unique opportunity that may represent the neuroaxonal anatomy of the retina and anterior visual pathway that may reflect in vivo the pathophysiological process of MS. As multiple sclerosis is a multiple disease, OCT is being considered one of the multiple biomarkers of the disease. It may help characterize MS phenotypes according to the retinal disease expression. And it may help monitor the response to therapy, as some reports revealed that reduced NIL thicknesses as a good response to immunotherapy in MS in patients that was previously recorded as the enhanced thickness in the INL. And it may be considered its inclusion in the diagnostic criteria of MS. And the final concern will be that question, the $1 million question. If glaucoma workup was done before the optic neuritis event, would it be possible to prevent more inflammation and start some therapy as she was sent to glaucoma specialist in the beginning of the case, and she postponed that evaluation, and then she just looked for her ophthalmologist or her glaucoma specialist because of the pain in the eye. So she would have multiple brain white matter lesions and optic nerves gadolinium enhancing MRI. She would have the CSF analysis with the oligoclonal bands and that additional OCT abnormalities in the left asymptomatic eye. And if this would happen, she would probably be a possible MS patient or a radiologic isolated syndrome. So we can't underestimate the back of the eye because it can preclude inflammation disability, and maybe you can start early treatment of multiple sclerosis. All we have discussed here is only a part of MS. And if someone has this new release of Mystery of the Fellow Eye, please let us know. Thanks, special thanks for everyone. And I'm here to wait for the comments. Thank you.
Luciano, I have a comment here. What you have made us think about is just like Prem Subramanian has suggested something called, incipient NAION. That is, you can detect NAION before it happens. You may have a disc edema, but with no visual symptoms, and then it goes on to, or it's an impending NAION. Similarly, you are talking about detecting an optic neuritis before it can occur, or you're detecting MS before it can cause optic neuritis, or you're talking about demyelination via OCT. So the floor is open to the other discussants.
Yes, that's our concern, because we know that the MS diagnostic criteria it has continuously evolved, and maybe OCT should gain that part of the criteria to help the neurology community to accurate the diagnosis and start early treatment if indicated, And as we saw in this case, the asymptomatic eye was not bothering her, except when I asked her about the Uthoff phenomenon. And then if she could have that glaucoma workup before the optic neuritis, that is the concern. Will you treat? We will send her to neurology people to start early treatment and prevent more inflammation. That's all what you have to
Your comments, Andrew?
Mm-hmm.
Yeah, I think that's fascinating. I mean, I don't see kids, but what I see is when they transition over from Texas Children's Hospital to adulthood, we see the kids. So I think there are differences. I'm interested, Luciana, in the differences between pediatric and adult disease in your population.
Yes, she is 19-year-old, so she probably is more in the age of adulthood, but young adult. But we see children here with bilateral involvements. Yeah, that's very common, and anterior optic neuritis. So and they can be classic. That's another concern. But in some atypical cases, we can see also the ADEN related optic neuritis, you know, but they usually go well. The problem in children is because they don't show you that that they are having decreased vision until the other eye or in the unique eye should be involved, you know.
Yeah, so I'd be interested in what John has to say about that too, because I just told you I don't do the MOG and the stuff on the white matter lesion people. I do it on the kids. John, you think that's legit?
I think, again, if they've got tons of periventricular white matter lesions, again, it's a matter of pretest probability, but the pretest probability for kids is so high, you know, 30% are going to be MOG positive. So I think you can. I know we're looking at collaborating with this group at UCSF, and they sent us, I think, 500 MS patients, peds, and the false positivity there was actually pretty low. Yeah, in kids, the pretest probability is so high, unless it's just classic MS. I'm going to check it for MOG.
Yeah,
how about Luciano's case with his MR?
His MR, you know, 19-year-old, it was bilateral, so I probably would check, but again, you know, I think this is probably gonna be MS. It really is. And then if I got a MOG titer of 1 to 20, I might even ignore it. But you know, if I get 1 to 1,000, something ragingly high, it might lean me, might get me a little bit more worried. Might want to see some changes in the periventricular white matter changes over time. I might do a spinal tap to confirm oligoclonal bands. But again, just because it's bilateral, but for me, that was classic MS, other than the bilateral nature. Actually, for you, no, actually, I'm sorry. Yours was not simultaneous bilateral. It was an old attack and then a new one. I actually don't think you should test it. You're going to get too many false positives. If it was bilateral simultaneous, I think I would check. Sequential, it looked like classic MS. I think there's too many false positives mixed in there.
Yeah, so for me, when the kid turns 19, they age out of the children's hospital. And so I get to inherit all these ADEMs and optic neuritis to childhood. And then they end up with me, but I didn't see anything that they had before. I just get this, you know, kid who's now an adult. And so I've been shocked at how many times they come to me with the diagnosis at childhood ADEM, and then we have the MOG, and they were carrying that diagnosis at our children's hospital the whole time. Nothing happened to them, but you know, it's like 20 years later, I'm making the diagnosis.
Well, at least they won't get MS.
Well, that was the other question I had. Is it the same caveat for MS treatments in childhood for MOG and NMO as it is for adults, or no? Makes it worse?
For MOG, I don't think it makes it worse. For NMO, it can make it worse, but for MOG, it doesn't work though. And so if you're suspecting MOG, you're going to want to, or let's say there's a borderline case and you're really unsure, you could theoretically use something like rituximab, which would treat both. So that's a potential option as well. But it doesn't look like the MS medication is worse in MOG, but it certainly doesn't work. That's been proven over and over. And for NMO, it can make it worse.
The cupping, that was like a pseudo cupping. Can you comment on that? Luciano, can you copy?
Oh, yeah.
The cupping?
That was the concern, because if we came back to the OCT on the right eye, they were perfect normal, you see, and in the symptomatic eye, she was with 5 days with ocular pain, and then we had the OCT done. So maybe we can have that situation of exoplasmatic stasis, but it was only 110 micrometers in that eye. So she had bilateral enhanced optic disc, completely normal, as she had the great optic discs. So the cup disc radio was because of that. And the weird thing that we may discuss is the OCT. By the time the OCT technology evolves, we start seeing a lot of things in retinal layers, and then we try to associate to CNS inflammation, like the INL. Why the INL was increased in the left eye, the symptomatic left eye, and the other one was not. And also that funny appearance on the outer nuclear layer. How can we explain that? So the time will tell if there are some specific changes that can be considered in the diagnostic criteria of MS. I know that OCT was discussed during the 2017 McDonald criteria, but it wasn't added to the criteria. You know, maybe in the future we can see OCT helping us to decide if this is a mock of neuropathy or NAS or NMO or whatever, you know.
Comments,
Neil? Talking about the issue of differences between the United States and India, it's my understanding in the United States, pediatric optic neuritis, although I was taught that bilateral was more common than unilateral, it actually isn't. But in India, I think the bilaterality that you see in adults is also in children. Is that correct?
Yes.
Yes, yes.
Mm-hmm. Yes, more often.
Yes.
And
I have a
we
question.
started, the more in pediatric patients, we are starting, usually order the MOG patient. But in this patient, we decided not to order because of the highly suggestive clinical appearance of MS. You know?
When do you decide to get the MRI spine? So do you do it in an isolated neuritis, or what is the criteria you choose to do screen the spine? Because every part we add, they're going to cost a bomb to the patient. So we routinely ask for MRI brain and orbit in a setting of neuritis. So when do you decide that MRI spine has to be added when the patient is not having any neurological symptoms?
Mm-hmm. I think that the clinical history is the main important, you know, but if the patient doesn't have any other neurologic symptoms, I usually share with the neurology people if we can go further with the spine MRI, but this first approach will be the MRI of the brain and the orbits. We treat the patients, and then in the follow-up, I think it's a good concern to ask the spine MRI. The opposite happens when we have the clinical status of NMO. If we have NMO SD, it will be the same approach, the MRI and also the spine MRI, brain and spine MRIs.
Dr. Andy, would you like to add?
Yeah, in adults, we do the cervical spine only, MR head and orbit with cervical spine. I haven't been doing the thoracic or the lumbar, unless they have symptoms.
No more symptoms, yeah.
Okay. Thank you.
And what about the UTOF phenomena? Do you usually ask UTOF?
In Houston, everyone has it because they're so hot. Probably India the same.
Of course, we're also on a hot plate.
It's hot every day. I mean, how do you tell the difference? Is it
But
worse when it's hot? You mean like yesterday?
Yes, but she got very scared when she saw me. And then when I asked her, what about the UTOF phenomenon? Why you are asking that? Yeah? And then she realized that she's facing the problem. It's usually unilateral, and in that asymptomatic eye will be symptomatic just after her hot bath. And then life goes on, you know?
Yeah, I usually do tell our patients to avoid the sauna, the hot tub, and I tell them not to get overheated. But I think the UTOF doesn't actually correlate with severity or disability or anything. It's just like an interesting thing. Is that right?
There have been permanent people with permanent visual loss and permanent neurologic deficits after a hot bath test or after a sauna. So I get nervous about it.
Yeah.
There was this guy who had VEP done and he would drink a beer. What, isn't that like a real paper?
So does that make sense? The permanent deficit after getting hot? Do you think that makes sense? Well, like what's up with that? Because it doesn't make sense to me. I know it's like an urban legend. We've all heard that story. That happened to somebody once.
No, it was in the literature. That doesn't mean it's correct, but it was in the literature.
Exactly. Right, because if the point is just transient delay in conduction based on a temperature sensitive area on the myelin that's just that threshold, and when it's 98.6 it conducts, and when it goes above it stops conducting, but it doesn't do damage. So I've never been a fan of that, cautioning patients, with MS that don't get overheated, don't take a sauna, I mean, you want to warn them that this could happen, but if anything, makes sense to maybe warn them that shouldn't be alarming. It's a temporary thing. If you want to play tennis or go for a run, you should do that. Sometimes it's a problem when it gets in the way. If somebody's a runner and after 2 miles, they start getting blurry, you don't fall down. I mean, just try to figure that out. Maybe run on a treadmill where you could hold on. So I think it's sometimes a management question, but I will say that
in the old days, when we used to still do hot bath tests, there were patients who got so weak you couldn't get them out of the bathtub. So you have to be aware of that.
Yeah.
They're slippery.
And you also see more relapses in MS patients during the summer, Maybe, yeah, that's a correlation, yeah.
Well, you remember there was that paper that was done that didn't correlate internal body temperature with VEP. Jack Selhorst did that thing where he had the guys doing a VEP while riding a stationary bicycle and measuring internal core temperature, and found there was no relationship between the temperature reading and when the VEP latency increased. So I still believe in that it's a temperature related, but it's kind of interesting that not everybody has found that.
Right, and maybe it's lactic acid, or it's a pH change. It's possible.
I think, Dr. Neil, we have observed few children because in India we have summer vacations during the peak summer. The children would go to water theme parks. So after playing in the water theme parks, I have seen few kids. The parents used to bring me saying that they have malingering the moment they are rejoining the school, pretending that they have lost vision. I have seen couple of patients having retrobulbar neuritis following that summer attacks after the water theme park after they're playing in it. So it is possible. Probably their exhaustion and in hot temperature, taking part and playing in that has triggered an event and resulted in a neuritis.
So another reason, in addition to dissection of the carotid artery, not to go to water theme parks.
When my son was young, years old, he used to have an onset of acute flaccid weakness when we took him to a museum. He'd be sitting on the bench in the museum and he just couldn't move. He just, but we have to go and move. And then we took him out to the play. It was fine. But we used to hypokalemic periodic paralysis, induced by looking at art. This is what happens when you have two neurologist parents who are both neurologists. We think this stuff is funny.
Great, thanks, Satya. It's good. Thank you, Dr. Luciana. That was a nice case.
Thank you, everyone, for the entertaining and interesting and enjoyable day today. So let's hope that all of you can attend tomorrow, the same time, 4 p.m. Indian time. And
Satya, not let's hope. It's a request.
It is a request.
We would love to have you all tomorrow. Please make it as lively as it was today. Would love to have you all tomorrow.
Thank you.
Thank you, Miller,
Bye.
Dr. Lee, John, Valerie,
thank you.
Luciano, everybody should be there tomorrow.
Thank you.
Okay, thank
bye-bye.
you so much. See you tomorrow. Bye-bye.
Bye. Thank you.
It was awesome meeting. Bye-bye.